a hiatus hernia of whatever type. It requires judicious judgment what not to and what to operate, like Sultan was asking. And then there are difficult and probably damage to the digestion structures in a big hiatus hernia in obese patient is much more likely than the esophagectomies that we usually do. So it's a very well done and very commendable decision. And I don't know how many thoracic surgeons as such are doing routine laparoscopic hiatus hernias right now. And I agree with you that most of them can be done from the abdomen side, even the recurrent ones, but they require
securing the gore mesh, and the patient did very well, no problem. Evening when I went to see the do the decompression of the pericardium, and the absorber tach had actually not gone into the heart. It was just enough there for the pericardium. Each time it will contract, it will rub against it, and it produce laceration in the myocardium, causing the blood in the pericardial cavity. So, and I went and read the literature, the absorber tach and ProTac, they in their literature, they say, do not use it next to the heart. They mention it to protect themselves, but the literature is full of pictures showing that absorber tach everywhere has been. Some of our own papers as well have got the similar diagrams. But never ever I'll use absorber tach anteriorly. It's gone. Because I had to open her chest. She was the GP, local GP. She had worked with me as a house officer when I was the registrar, and it was very frightening. I had to use a defib twice, intrathoracic defib. Thankfully, we have got one, and she survived. I had to transfer her to the cardiac unit to make sure that there was nothing more, and so on and so forth.
Well, thank you for sharing. I think it's very easy for us to share our success stories, but to actually have the conviction to share our complications, especially for the learning of our junior doctors, I think clapping for Dr. Sahar for sharing.
Thank you so much, Dr. Javed Raza, for your presentation. Our next speaker is Professor Bilal Umair, who is working as a senior consultant thoracic surgeon and serving Pakistan Army and currently working in CMH Rawalpindi. Dr. Bilal Umair will be talking about experience of minimal invasive esophagectomies.
Bismillah Rahman Rahim. My very senior and respected senior and junior colleagues, Assalamu alaikum. First of all, I'm thankful to Professor Amir Bilal and the organizers, and I recognize he's the only organizer, a one-team organizer of this conference, and he has done very well to get us all together here, and the talks since the morning have been very enlightening. And after hearing Professor Dr. Khanzada and Dr. Takhar, I don't know what else I have to say about esophagectomy. The topic given to me was an experience at CMH Rawalpindi. So I'll share that experience with you people, especially for the people at the back. And I'm very glad to see a young and vibrant community sitting at the back. I remember the conferences where we were only the front, the speakers were only there. And with all of them, have either learned or are learning one way of performing an esophagectomy. And how to choose and how to go about it, I will just narrate our experience. At the cost of repetition, but for the purpose of context, it's over a century, maybe over 1 century and a quarter, that surgeons have been trying to find out the one best possible way of performing an esophagectomy. And it was a difficult learning curve ever since. And by the middle of the last century, it's a very catching phrase for me actually was, history is for every esophageal surgeon that little cemetery of memories where he goes to seek the lessons of his or her mistakes. This is the middle of the last century. And I think the same continued till about 70s or 80s at least. We were all learning on our parts. We were trying to practice one method of doing an esophagectomy, and we were trying to persist with it because that was what we could actually. No single surgeon in their whole lifetime can adopt all the approaches to an esophagectomy. So they learn from their mistakes, and that's the best one of the ways of doing that. And then the standardized approach since morning have all been discussed. Ivor Lewis McEwan, transhiatal left thoracoabdominal, and the modifications of that. And add to that, since the 1980s, minimal access esophagectomy. Again, all these approaches which can be done by the minimal access approach. And to the glossary is the mediastinoscopic mobilization, hybrid techniques, hand-assisted techniques, totally minimally invasive techniques, prone, semi-prone, lateral. And it's all good for us to stand here and talk about our experiences, but the person at the back who has to start his career or to continue with that it's perplexing for him what to do. So what he does is actually, he does what his mentor is doing. Professor Dr. Javed was talking about Dr. Iftikhar. Dr. Iftikhar was talking about Dr. Atkinson, and so on and so forth. And Professor Amir was talking about Dr. Zahoor. तो ये तो सीना बसीना एनो यकीन से हम करते आ रहे. And that to me is one of the best ways of doing it. लेकिन कोई बहुत अच्छा आपको करके दिखा रहा है और आप सीख रहे हैं. At the end of the day, I will come down to the conclusions that we have already discussing. तो हमारे भी मेंटर थे, हमारे मेंटर ब्रिगेडियर सुल्तान मुजफ्फर. But Brigadier Sultan Muzaffar had a different kind of mentoring to us. I'm standing here actually. Farhan is sitting here, Brigadier Asif is sitting here, and subsequent generations are sitting here. He was the kind of person who would not teach you a technique. He would give you an initiative. You request him कि सर ये करने की ज़रूरत है, कर लेते हैं. अच्छा इस तरह कर लें, अच्छा कर लो. Remember at that time the YouTube was not on. We only have Anesthesia, and in Pakistan we are a decade after user, and maybe more than a decade. So हमारा learning curve आप लोगों के learning curve से different. So we have passed through stages, and this is what I'm going to share you with. अब ये जब सारी glossary आती है, for a person who has come into thoracic surgery needs to know कि what decides that this approach is best for us at least. तो क्या होता है? There are proponents and opponents of a particular approach. Okay, whether we can add to a thoracotomy or not, how to reduce the respiratory complications, blood loss, recurrent laryngeal nerve injury, anastomotic stricture, anastomotic leak. क्योंकि जब हम उधर demonstrate भी कल कर रहे थे, तो आप लोग तो discuss यही कर रहे थे कि ये कैसे बचा लें, ये कैसे कर लें, how to fare well, और आपकी technique में क्यों इस तरह है. तो this is what is this discussion meant for. And add to that the location of the tumor, the tumor's location has changed in the last century or so. So it's a gastroesophageal junction tumor, which is another entity now. Staging, TNM keeps on changing, histopathology of the tumor, use of neoadjuvant chemotherapy, and then the surgeon's preference. The training, the resource they have, and the experience they have after doing all these esophagectomies. तो डिसीजन तो लेना है ना कि हमने कौन सा करना है, ये करना है या वो करना है और कितनी टाइप की कर सकते. So this talk is actually meant for the people at the back कि इसका कोई सेंस बना ले. So history of esophagectomy reflects a journey of dedication. Each one of them and each one of you who are sitting at the front have been a dedicated surgeon and have taken use of the collaboration. That is one of the collaboration which is going on today. The technical innovation with ongoing endeavors aimed at optimizing outcomes and reducing complications. और यही डॉक्टर इफ्तिखार ने कहा कि मोर्टेलिटी बताएं आपकी कितनी है, रिजल्ट्स बताएं आपके कितने हैं. दीज आर द ड्राइविंग फैक्टर्स. इसोफेजेक्टमी की तो इतनी अप्रोचेज हैं कि सारी ठीक भी हैं और सारी गलत भी कह सकते हैं. And then he showed you the pictures, and these are the two joints of thoracic surgery. On the right side of your picture is Professor Mark B. Oringer, the champion of transhiatal esophagectomy. Since the 70s, he has been carrying out this transhiatal esophagectomies. And the left is, as mentioned by Professor Khanzada, is James Lukic, who is the champion of minimal access surgery in the US. और वो भी लेट 90 से शुरू होके टिल नाउ ही हैज पास थ्रू अ लर्निंग कर्व. आप उनकी अप्रोचेस देखें, उनकी अप्रोचेस भी चेंज होती रहती हैं. पहले 50 केसेस की, फिर 100 केसेस की, फिर 200 केसेस की. लेकिन दोनों की तस्वीर मैंने इसलिए डाली कि वंस वी वर कंटेम्पलेटिंग कि हाउ टू प्रोसीड अहेड विद मिनिमल एक्सेस esophagectomy once I came back, and just after Professor Iftikhar had a demonstration before me, I was not there. So this is an interview on the YouTube between the two. The professor here, University of Michigan and University of Pittsburgh. And Lukic is trying to convince him that minimal access esophagectomy has certain advantages too. And Professor Mark B. Oringer was cool as a cucumber. And he applied all those answers to which Lukic was trying to refer to. At the end of the 1 hour long interview, James Lukic said, and I was impressed, that with the weight of 3,000 esophagectomies behind him, who can challenge him in this approach? It's still on the news, and so it was thought provoking for me as well. So what is the best approach to esophagectomy? I perfectly agree with both the senior surgeons who were there before. To me, esophagectomy is a subset of small procedures. And if you have attention to details to these small procedures, you end up with a better outcome or a good outcome. तो क्योंकि एक 4, 5, 6, 7 घंटे का प्रोसीजर अगर होता है तो इंसान है ना थक भी जाता. तो अगर आपका एक एक स्टेप थॉट आउट है, प्लान्ड है, केयरफुली डन है, तो you end up with a result as good as in any approach. So how do you get that result? The slides subsequently coming are for you to elaborate upon and for us to discuss during or after the presentation. कि ये जो points of contention है ना, ये हमने discuss किया. So the stage of the disease, evidence-based medicine has come down to the fact that this is a stage and these are the things or the esophagectomy patients that we should take on surgery. देखिए हमारे ज़माने में क्या था? अब हिस्ट्री की आप बात करें तो I was doing my residency in general surgery in the early 90s or late 80s. तो esophagectomy हमारे पास CMH रावलपिंडी में अगर लाइव चली जाती थी तो it was a big day. It was not that the surgeons at that time were not competent enough. Preoperative evaluation, preoperative preparation, like they were referring to, post-operative care, intensive care, none was energy devices, like staplers, nothing was there. तो एक पेशेंट आया, उसने डिस्फेजिया कहा, इसोफेगस पे उन्होंने डिटरमिन किया ट्यूमर, और they would take him to theater. Or once I came back for the training in thoracic surgery, The results had improved much, and I will discuss that. And now those who have come to us, like the Professor Iftikhar, के तो बहुत ही dramatic और बहुत ही exemplary results हैं कि there is no mortality for the last many years or so. तो ये अचीव हो सकती है. This is what I am trying to tell at the back. कि ये चलें not as good as because of patient population and the referral mechanisms are a little different. लेकिन ये minimum तो जरूर हो सकता. So a well-staged, MDT discussed patients adequately prepared is to be taken up. तो T1 not T3 I think ये तो C1 level की चीजें आपको ज्यादातर तो पता ही है. Then there comes the question of complete pathological response. ये पहले नहीं था. This was not present in our training. ये अब आ गए. सर हमने कहा ना we are behind you by at least a decade if not more. तो अब complete pathological response आता है तो there are ways to judge it. तो I believe that there is no definite way of to judge it. तो सर ने कहा protocol driven तो ये है कि उसकी resection आपने करनी है. Whether you find the tumor in it or not, that is a question that comes to a naive mind कि अगर उसमें tumor ही नहीं रह गया तो आप उसकी resection क्यों कर रहे हैं? तो till the evidence comes to the point that a complete pathological response requires only surveillance. So we at present are persisting with esophageal resections. यहाँ तक मेरी understanding है sir. And correct me, ये मैं discuss this is what I want to bring up to discussions. तो उसका कोई तरीका नहीं है. आप EUS कराते हैं, आप PET कराते हैं, उसमें आता है नहीं आता, we proceed ahead with the esophageal resections. A points of contention क्या है कि adequacy of resection margin. देखें, सेंचुरी से ज़्यादा पुरानी बात होगी. We have yet to decide कि ये 3 सेंटीमीटर का है, 4 सेंटीमीटर का है, 5 सेंटीमीटर तो गाइडलाइंस बन गई. गाइडलाइंस बन गई कि यार एडिनोकार्सिनोमा है तो 5 से 5 सेंटीमीटर 4 to 6 सेंटीमीटर ऊपर 5 सेंटीमीटर नीचे होना चाहिए. And still we may get results with the positive resection margins because of multiple factors actually, if it's a big tumor or whatever. लेकिन होता है ना, तो whether that's complete, that resection margin positive does not translate into better survival, that is on, तो फिर आपको clear margins तो लेने हैं ना. So longitudinally and circumferentially. Circumferentially, we are stuck up. Circumferential margins, according to the Royal College of Pathology of UK, are different, and according to the American College, are different. But then again, ये हमारे margins जो प्रोफेसर आमिर बिलाल करते हैं, हम करते हैं, तो उसमें आप 1 mm का रखें डिफरेंस या ना रखें, हमारे लिए वो बराबर है. हमारे अपने मार्जिन हमारे तो ऑलमोस्ट पहुंचा ही होता है ना सर, किधर तो मिल जाते हैं. नाउ दैट द एंडोस्कोपी हैज कम अप एंड देयर सो मेनी अर्ली रेफरल्स, बट नॉट दैट मच एज यू पीपल वुड गेट एक्चुअली. फिर ये आगे तो चीजें लिम्फ नोड डिसेक्शंस वी विल डिस्कस वन बाय वन. सो रिसेक्शन मार्जिन, सर्कमफ्रेंशियल मार्जिन्स तो हमने लेने हैं. And as Professor Asif Askar was referring to mesoesophagus, so that is primarily the purpose कि आप circumferential margin भी लें, apart from the lymphadenectomy that is supposed to be done in that mesoesophagus. Lymphadenectomy 2 field करनी है, 3 field करनी है, पीछे बैठे हैं किताबें पढ़ रहे हैं कि कह रहा है 2 करनी है, कह रहा है 3 करनी है, तो ये तो इनको पता आना है ना सर कि right now with us at present we are doing a 2 field section. इसमें थोड़ी सी कैच डिफरेंट है जो मैं आपको बाद में बताऊंगा. चाइना में, फार ईस्ट में तो शायद 3 फील्ड करते हैं, सर भी अपना एक्सपीरियंस बताएंगे, बट वी आर परसिस्टिंग विद द 2 फील्ड डिसेक्शन. इट इज द नंबर ऑफ लिम्फेडेनेक्टमी के बगैर बात हो नहीं सकती. सो वंस वी वर डूइंग अ ट्रांसहाइटल फिसोफेजेक्टमी फॉर ऑलमोस्ट अ डिकेड, उसकी एक डाउनफॉल तो ये थी, मैं आगे आपको बताऊं. रिकरेंट लैरिंजियल नर्व इंजरी. Evidence ये कहता है कि precise knowledge of the anatomy and plane of dissection close to the esophagus and awareness of middle and rigid retractor and tracheoesophageal grooves. These are the tips. अब देखो सवाल जब chest versus neck anastomosis होता है frequently रहता. We in our department were lucky enough कि we are trained general surgeons first, and then we have by compulsion of army we need to go back to thoracic surgery as a second phase. तो थायराइड ये करते करते और बाकी स्टेप्स करते हो इतना बड़ा इशू नहीं है. एंड वंस यू आर डूइंग इट रूटीनली तो इट इज वेरी अपरेंट इफ यू हैव अ क्लीन डिसेक्शन फील्ड तो रिकरेंट लैरिंजियल नर्व मिल जाता है. प्लेसिंग अ मेटल रिट्रैक्टर इज अ पॉइंट ऑफ Markby or Ringer, and I think it is a well taken point, and we should take care of handling how to handle the, and within the laparoscopic approach, like we were doing last night. If you don't have a tumor in the proximal esophagus, if it's down below, then I think if you stay close to the esophagus, and that is why I was referring to the fact that if you take it fiber by fiber, then you can actually save that nerve. राइट साइड की तो पहले ही ऊपर है, लेफ्ट साइड का थोड़ा सा इशू है, तो इफ यू आर अ लिटिल जेंटल तो इस पे सेव हो सकती है, तो वो बिल्कुल करनी है। अप्रोच आपने जो भी करनी है, ये चीजें बचाएं। सर्वाइकल वर्क के थोड़ा ये फिर ये डिबेट चलेगी, अभी कोई प्रोपोनेंट होगा, तो आई थिंक इन वेल एस्टेब्लिश्ड वेल ट्रेन्ड यूनिट्स the rate of cervical leak is more actually, and statistically. Lekin it's easier to manage. That is our point, that those who do it in the neck actually. Because we do not have the same facilities as you people as far as the intervention radiology is concerned, as far as stent placement is concerned, as far as the stay of the patient in ICU or a prolonged HU stay is concerned. TPN. तो ये फिर चीजें देखते हुए ना, we are persisting with the neck anastomosis, but obviously the gold standard remains the chest nose. We can't argue that. So this is one of them. Secondly, in a minimally access approach, the learning curve for an anastomosis in the chest is more than I think to do it in the neck. क्योंकि जो भी आप करते हैं, देखें, it's very easy. It is very easy to show you कि ये पर्सनिंग स्विच लगाया, but you have been trained in that. इतना आसान नहीं है। मैंने देखे, मैं आपको आगे बता रहा हूँ, it's difficult. आपने कहा कि आई यूज अ पर्सिंग डिवाइस, सर ने कहा आई डू इट हैंडली। ये ऐसे तो नहीं आता, और जब ऐसे नहीं आता तो फिर आप लर्निंग कर्व में जब वो करते हैं तो लीक का चांस बढ़ता है ना सर। तो जब लीक का चांस बढ़ता है तो हम नहीं हैंडल कर सकते विद आवर आर्मामेंटेरियम ऑफ डूइंग दैट। देन हैंड स्विंग वर्सेस स्टेपल्ड, ये भी डिबेट चलती रहेगी। यू डू इट इंटरप्टेड सिंगल लेयर, यू डू इट डबल लेयर, you do it circular anastomosis, you do a stapled linear anastomosis. At the end of the day, it's a well perfused conduit which is in the neck without tension that determines whether the leak is going to be there or not. तो आप जो भी तरीका कर लें, और इसका एविडेंस को इतना कंफर्म भी नहीं हुआ कि one is better than the other. Drainage procedure, I agree with Dr. इफ्तिखार, हम रूटीन में करते थे, हम लर्निंग में करते, हमने भी छोड़ दिया, आपने भी छोड़ दिया। And as you are saying that you put in an endoscope, dilate the pylorus, and it does all right. And the trick to that is कि don't make your tube of wider diameter. अगर आपको अपनी ट्यूब के डायमीटर ज्यादा नहीं है तो it's unlikely to hold and then pull on the anastomosis. तो वो अगर आप थोड़ा डायमीटर जुडिशियस रखें 4 to 5 सेंटीमीटर का, तो ये अमूमन प्रॉब्लम देता नहीं है। And we have never had any problem afterwards, क्योंकि हमने तो दोनों साइडें देख ली ना सर। फीडिंग जज डालें ही ना। मैंने प्रोफेसर आप आसिफ, डॉक्टर आसिफ का जिक्र कर रहे हैं रॉयल मास्टन वाले का, तो आई वन मीटिंग विद हिम, मेरा तो इतना एक्सपीरियंस नहीं है, अपर जे की कॉन्फ्रेंस थी, तो उसने कहा कि वो नेजोजिजनल ट्यूब डाल देते हैं पोस्ट ऑपरेटिवली। आप लोग भी डालते होंगे सर? आप कुछ भी नहीं डालते, तो देखे ना, एक डाल ही नहीं रहा, एक डाल रहे, तो हम फीडिंग यूनोस्टमी डाल। तो कहता आपने यू नेवर हैड अ प्रॉब्लम विद फीडिंग यूनोस्टमी? होती तो है, कभी ट्रेनिंग डाल दी, कभी किंग कर गई, कभी वन ऑफ, लेकिन वी टेक इट एज अ सेफ गार्ड अगेंस्ट। और हमने पोस्ट ऑफ घर भेजना होता है जल्दी, फिर उसको न्यूट्रिशन होता है, फिर पहले ही मालनरिश्ड पेशेंट, वी रिसीव अ पेशेंट इन मच मोर मालनरिश्ड स्टेट देन आई थिंक देन यू पीपल अराउंड। तो आप लोग तो उसको बिल्ड अप कर लेते हैं, हमारा तो जितना मर्जी कह लें सर, उसका एक लेवल है ना उसको इम्प्रूव करने। सो वी रूटीनली प्लेस ओपन करना, लेप्रोस्कोपी करना, डू इट एनी वे यू, एज लॉन्ग एज इट इज सेफ। Diagnostic lab is another question. I think evidence is well settled that diagnostic lab in a gastroesophageal junction tumor should be done. Because many times you end up with surprises. और जो है ना, फिर आप बैठे होते हैं, तो इससे अच्छा ये कर लें, एक्सेप्ट फॉर स्क्वेमस सेल कार्सिनोमा, स्मॉल साइज, एविडेंस ये कहता है कि 2 सेंटीमीटर से कम है तो मिड कर दें, लेकिन एडिनो में तो सर मेरा ख्याल में कर दें, क्योंकि and most of the time we are using a neoadjuvant therapy. So you put in a scope, do a feeding anastomy if required, और उनके हवाले करें और फिर बाद में। तो these are the points of contention actually. ये जो लिस्ट थी ना, ये वो लिस्ट है कि जो आपने सोचनी है, अप्रोच तो आप जो भी कर लें, ये पॉइंट्स आप जो है ना, यू टेक केयर ऑफ देम, तो अप्रोच तो खुद आपकी जो है ना वो डिटरमिन हो जाती है कि विच इज अ बेटर वन। पोस्ट ऑपरेटिव कंसिडरेशन, अब तो असल बात तो ये थी कि एक्सपीरियंस हमारा क्या है, तो हमारा फ्लक्चुएटिंग एक्सपीरियंस। Once I joined in 2002 or 1, Professor Farhan was here. तो ट्रांसहाइटल ईसोफेजेक्टमी हमारे लिए लाजिम और मलजूम थी। बस वो नहीं देखे, और रिंगर रिफ्यूज टू एक्सेप्ट कि किसी भी, ही सेज कि एनी काइंड ऑफ केस मिडिल थर्ड व्हाटएवर आई कैन डू विद द ट्रांसआइटल मोस्ट ऑफ द टाइम, ठीक है, वो ही हैज सम रिलेटिव। मैंने इसी कार्डियोथोरेसिक कॉन्फ्रेंस के अंदर 2003 में खड़े होके, द देन चेयर वाज प्रोफेसर मुसद्दक। Professor Musaddiq is a very renowned surgeon from India, Islamabad, who is a cardiovascular thoracic trained surgeon from US. तो मैंने अपनी एक्साइटमेंट में, वो चेयर कर रहे थे तो पूछा कि सर आपका ट्रांसआइटल के बारे में क्या ख्याल है? तो उन्होंने कहा एज अ सीनियर पर्सन से कि पिंडी इस्लामाबाद में ट्रांसआइटल एसोफेजेक्टमी, आई वाज द फर्स्ट वन टू डू इट, ही वाज ट्रेन्ड फ्रॉम यूएस। तो कहते हैं मेरे प्रोफेसर ने कहा कि वार्ड में पेशेंट पड़ा हुआ है, मैं जा रहा हूँ लाहौर, खबरदार तूने ट्रांसआइटल इसकी की। तो ये बहुत आई हुई, ठीक है सर। अच्छा, वो चले गए और उन्होंने कर दी, ठीक है सर। लेकिन उन्होंने जुमला जो मुझे जो कैच किया, ये आई वाज स्टन्ड बाय इट वाज, तो कहते मैंने कहा सर फिर अब, कहते अब मैं नहीं करता। क्यों सर? वो कहते हैं यू ओनली हैव टू हैव अ वन डिजास्टर टू रियलाइज दैट इट इज अ ब्लाइंड प्रोसीजर। एंड दो वी वर नॉट, हमारा कोई डिजास्टर्स नहीं हो रहे थे, लेकिन दो तो हमारे भी हुए। एंड देन द लिम्फेडेक्टमी पार्ट ऑफ इट, तो मैं आई मस्ट एक्सेप्ट कि ये भी हम नहीं करते थे जब हम, लेकिन लर्निंग कर्व से गुजरे हैं ना। जब प्रोपगेशन नहीं थी, जब एविडेंस इतना था भी नहीं, तो लोग कह रहे थे हम रिट्रीव भी कर लेते हैं, तो हम भी जितना निकल आता था निकाल लेते थे। Professor Farhan has a much longer finger than me. He could take out more lymph nodes. And actually, अच्छा sorry, I felt I forgot to mention, जो पहली ट्रांसआइटल सर सुल्तान ने की थी ना, वो बीर आसिफ ने करवाई थी मेरे से बहुत पहले, once I joined in. So it was a norm of that. Sir, for a decade, Dr. Iftikhar, we persisted with ट्रांसआइटल एसोफेजेक्टमी, उसके अलावा कुछ कहते थे तो डांट पड़ती। खैर, और we were doing well, ये तो ऐसी बात नहीं है। फिर आ गया टाइम बीच में कि वी वर वेरी इम्प्रेस्ड विद प्रोफेसर आमिर बिलाल, क्योंकि इनका वॉल्यूम, इट वाज अ ह्यूज वॉल्यूम। तो वी चेंज ऑन टू लेफ्ट थोरैको-एब्डोमिनल अप्रोच, एंड फॉर 5-6 years वी परसिस्टेड विद दैट। वेरी कन्वीनियंट टू डू, ओपन करते थे, जल्दी से होके आ जाती थी, जिस आपने कहा 2 घंटे में आपने शुरू कराई, उन्होंने की, हमने फॉलो कर लिया सर आपको। एंड देन इन 2013 or 14, once we went back, तो देखें the purpose is to keep abreast of what is going on. Whether it is useful or not, that is another question. That has to be decided once you start doing it. And we were not blessed with the training mentors and the facilities that are in UK or US. It was a learning curve for us. So from 2000 to, and then the patient selection. And let's go on to that. मैं कुछ ज़्यादा time तो नहीं ले रहा, फिर मैं छोटा कर दूंगा सर इसको। सो पैराफ्रेजिंग द फ्रेंच, ये भी एक और कोटेशन है, मैं कुछ इतना लायक नहीं हूं ना, मुझे कोटेशंस का पता है, ये तो मुझे मिल गई सर एविडेंस में, लेकिन ये स्ट्राइक की ना सर मुझे। इट्स इन अ जर्नी, इट इज नॉट द डेस्टिनेशन दैट काउंट्स, बट ऑलवेज द पाथ टेकन, एंड स्पेशली द डिटूर्स। तो वी हैड बीन टेकिंग डिटूर्स, परफॉर्मिंग एन एसोफेजेक्टमी फ्रॉम वन टू अनदर। So right now we are in a minimal access part of it, and maybe 10 years down the lane or 5 years down the lane, इधर कुछ और बैठे कुछ और कर रहे होंगे, रोबोटिक्स कर रहे होंगे, एसोफेजेक्टमी आउट हो चुकी होगी, कुछ और हो रहा होगा सर। तो फ्यूचर तो है, तो आपने यू हैव टू कीप अब्रेस्ट विथ व्हाट इज गोइंग ऑन एंड ट्राई टू टेक ऑन थिंग्स जिनका एविडेंस मौजूद है खास तौर पर। एंड वन गुड वे ऑफ डूइंग दैट इज टू कम टू दिस मीटिंग्स। तो ये पुरानी पिक्चर है ट्रांसआइटल की, ये शॉर्ट गैस्ट्रिक्स बांध रहे हैं, एक हाथ स्प्लीन की तरफ इस तरह गया हुआ है, एक हाथ इस तरह गया हुआ है, सर का उषा उधर से गया हुआ है, फरहान नॉट टाई कर रहा है, तो ठीक है, कर रहे थे, बड़े अच्छा कर रहे थे। आसिफ जो है ना सीजर से काट रहा है, तो काम तो हो रहा था अच्छा। और ये फिर उधर एब्डोमेन से फिंगर डाली हुई है, ये नेक में फिंगर आ रही है, एक्सटर्नल अच्छी बन गई है, और हाँ फरहान की फिंगर है सर मरी। तो वैसे रिकमेंडेड हैंड साइज फॉर अ ट्रांसआइटल एसोफेजेक्टमी 7.5, which is ours. इसका जरा ज्यादा है on the lighter side. So now we are going to share how we got to this point. Case selection was important to start with. तो इतनी easy नहीं थी क्योंकि हमारे cases ही सब नहीं थे. And to be very honest, the last 10 years or so, we have seen advances and we've seen improvement in our oncology department as well. पहले नहीं था. We did not have the trust enough to hand over them the patient, और वहां से patient कभी ठीक तो नहीं होके आया था सर. नहीं, seriously speaking. But now, over the period of time, I think उन्होंने भी हमारी तरह improvement की है, and now they do come back to us, and now we have a regular MDT meeting, we hand them over the patient, do a CRT, and then the patient comes back to us. तो ये फिर part of the learning curve में थे ना सर। फिर आपने पोजीशन क्या बनानी है, कौन सा, अब इस अप्रोचेस में आइवरलोइस करना है, ट्रांससाइटल करना है, और या ये 3 स्टेज करना है, तो ये हमने खुद डिसाइड किया। हमने कैसे डिसाइड किया कि वी ट्राई टू डू दीज थिंग्स अ फ्यू टाइम्स। हाइब्रिड से शुरू किया। हाइब्रिड का मकसद है, जिस सर ने कहा कि एब्डोमेन कर लिया, कभी चेस्ट कर ली, तो देन वी कभी प्रोन कर लिया, कभी वैसे मतलब है कि लेटरल पोजीशन कर ली। तो अब उनमें से जो भी करें, आई टेक द पॉइंट ऑफ डॉक्टर खानजादा एंड डॉक्टर इकबाल एंड एवरीबडी एल्स एज वेल कि आप कंफर्टेबल हो जाए, और आप कंफर्टेबल हो रहे हैं पेशेंट सेफ्टी वाइज एंड पेशेंट के ऑन्कोलॉजिकल रिजल्ट्स वाइज। जब आप समझते हैं कि ये प्रोसीजर मैं एफिशिएंटली कर सकता हूँ, पेशेंट सेफ्टी प्रोफाइल रख सकता हूँ, ये पॉइंट्स ऑफ कंसिडरेशन को आई कैन कीप इन माइंड, एंड द पेशेंट इज सर्व वेल एज फार एज इज ultimate survival and mortality is concerned, that is the approach you have to take. और उसमें इनिशियल टीम को तो मैं भूल नहीं सकता, इट्स अ टीम एफर्ट एक्चुअली। वो ब्रिगेडियर मुजाहिद हो, ये अहमद हो, यासिर हो, सब्सिक्वेंटली जो आते गए हैं, ब्रिगेडियर फरहान है, these were all on board because we were a relatively simplistic laparoscopic surgeons, and to go to that stage, the team is required, and the longer and the anesthesia support as well. तो हमने ये सारी चीजें की। ये तो क्योंकि चले वो इसको मैं डिस्क्राइब क्या करूं, यू हैव अ डेमोन्स्ट्रेशन येस्टरडे, लेकिन ये वीडियो थोड़ा सा मैं इसका पॉइंट पे चले,
नीचे खोल दो उसको,
साउंड बंद कर दें, ये पॉइंटर ये स्टार्ट। सो देख एब्डोमेन फेस तो हम आपको ज्यादा अच्छा नहीं दिखा सकते खानजादा से और डॉक्टर साहब, तो थोरेसिक फेस की जो अप्रोच हमने चूज की है, so this is because this is the not me, the aorta at the top, diaphragm, inferior pulmonary ligament, the tumor which has received its CRT at the lower end, you can see the neovascularization over it, the esophagus with its involved nodes, the azygos, proximal esophagus with the trachea in front, SVC on this side, and some adhesions of it. To take off the azygos or not, अच्छा देखिए हर चीज एक पॉइंट ऑफ कंटेंशन या डिस्कशन बन जाती है कि ये एजाइगस भी बांधनी है कि नहीं। Some people may not do that, लेकिन चूंकि मैंने तो in our technique we take down this esophagus, I think the easier dissection, especially if the tumor is of somewhere around here, and then the stomach has to be pulled up, तो इस विंडो से तो स्टमक नहीं ऊपर जा सकता, लेकिन one point is if you take off the esophagus from the neck and pull it down, तो आप कह सकते हैं बांधे ना बांधे, तो there is not much morbidity involved with, bleed तो कभी करती नहीं है, तो कर भी जाए तो टैकल हो ही जाती है। तो this is the one way of planning, तो ये कोई इतना बड़ा इशू नहीं है, you just take the pleura, अच्छा doing it by hooks, this is for your point of आप इसको हार्मोनिक से करें, आप इसको लिगाश्योर से करें, आप इसको हुक से करें, लेकिन मैं इस एरिया में पर्टिकुलरली हुक प्रेफर करता हूँ। आई थिंक आई कैन टेक small bites and more precise bites with a hook. And then Dr. Khanzada and people would do a stapler and just divide it off. हम उसको tie कर लें, हम उसको clip कर लें, whatever, do it safely. Ensure करें कि आपने इसको secure कर लिया। इसको करने के बाद जो कि कल हमने देखा, it's the pleura being taken off at the top. अब यहाँ पे अगर आपने थ्रेसिक डक्ट लेनी है और इसोफेगस लेनी है, जिस तरह सर आसिफ असगर कहते, तो फिर आप you are just on the adventitia of the aorta because the evidence is not compelling, and we can do it in such a case, you can always do it, but the evidence is not compelling, तो हम अभी इस वक्त महसूस नहीं कर रहे जरूरत, तो we are almost on to the esophagus. We try to take lymph nodes along with the esophagus अगर हो सके तो। कल चूंकि आपने देख लिया तो we won't take much time over it. The inferior pulmonary ligament, the other side of the esophagus, over the pericardium. Now this is a trick maneuver. This is again anybody's preference. तो कल मैंने आपसे जिस अर्ज किया था कि जो spine है, spine becomes important consideration if you have 3 ports and your working ports are like this. तो अगर वो आपके रास्ते में आ रही है तो जो आपकी maneuverability अच्छी है. You might need a sling. लेकिन मैंने देखा कि if you take the ports a little away, and your maneuverability is not much of a problem, both your right and left hands. तो अगर आप esophagus को ही आगे पीछे retract कर देंगे तो precisely आपको vessels भी नजर आ रहे हैं और you can take each fiber. तो इसलिए इतने बड़ा issue नहीं होता. Sometimes you have to take the opposite pleura off. क्योंकि वो तो फिर adherent होगा, tumor होगा तो फिर आप करना ही है. तो opposite pleura भी बीच में आती है, उधर आपको उसके vessels नजर, hilum नजर आ रहा होता है. और these are the intercostal vessels. तो अगर and then on the hook side of it, तो hook का सिर्फ ये है कि मेरे ख्याल में आप उसको pull ना करें, हम जज्बाती होकर जरा जल्दी खींचना चाहते हैं. If you keep it here, buzz it off, और फिर हल्का से इस तरह करेंगे तो ट्रिक होगा. अगर आप वो खींचना शुरू कर देंगे ना फिर then hook becomes a difficult problem. तो lower end पे ना मैं I frequently use harmonic, मुझे लगता है कि उधर कोई ऐसी चीज भी नहीं है and you go down तो वो bulk में हो जाती है. ये subcarinal space in which the lymph nodes are already showing and being taken from the pericardium. ये inferior pulmonary ligament जब ले रहे होंगे तो फिर आप inferior pulmonary vein तक आएंगे. Let's go to the proximal side क्योंकि कुछ चीजें मैंने आपसे डिस्कस करनी है. This is the proximal side. Again, you have divide the pleura on upper and lower part of it. और जिस तरह वो ऊपर से edge नजर आ रहा है ना clear, तो इसी तरह अगर if you stay close and take fiber by fiber those blood vessels, तो movement recurrent laryngeal nerve is not a problem. And by the way, the 2 patients that we operated yesterday have normal voice. ये रात को मैंने वीडियो उनकी मंगवा ली थी, वो मैंने डाली नहीं. तो but you can have recurrent laryngeal nerve problems. इसमें कोई शक नहीं है कि this is one part of the very important part of your this is the whole mobilized esophagus. अब take it as down low as possible. मेरा ख्याल में it helps. Once you have done with the abdomen तो आप जल्दी एक दूसरे से मिल जाते हैं. Even if the tumor is at the lower end of the esophagus. वो ऊपर से मुझे लगता है कि वो आसानी से आप you can take it off. और फिर जब नीचे से आपने सिर्फ rim या crura, you need to take the crura off along with that. तो फिर आप उसको आसानी हो जाती है. वरना नीचे से ऊपर करना जो है ना, and secondly you are doing a laparoscopy afterwards. So we lose gas into the chest and it becomes a problem. अब अपने intracorporeal, let's stop at that क्योंकि ये तो कल हमारी demonstration होगी. If you are doing an intracorporeal stapling, cost तो है, लेकिन उसका भी फिर हर एक का तरीका है. हर एक का तरीका है तो we use 4 or 5 staples और हम ये कर रहे थे रूटीन में. You make a tube, so it's transected, you join it with the proximal stump and then put it out in the neck. तो हमने क्यों ये approach choose किया? ये I think we have deliberated enough. Excellent exposure of the esophagus, more complete mediastinal dissections, ergonomic advantage. Those who have to take this type of surgery at the start of your career, ergonomics are extremely important. आपकी wrist, आपकी elbows, shoulders, back, ये रह जाएगी अगर आप हमारी उम्र तक ये करते रहेंगे. हमने तो लेट शुरू किया ना, तो वो ergonomics are important. So this is one part of it. Blink, इसके ऊपर तो बहुत research हुई. The surgeon blink rate is important. ये पता आपको बात कि आप इस तरह करके सर्जरी कर रहे हैं, आप तो स्टेयर कर रहे हैं, यू डोंट इवन नो कि जी क्या हो रहा है. द ब्लिंक रेट इंडिकेट्स कि आपका स्ट्रेस कैसे चल रहा है, स्ट्रेस कैसे नहीं चल रहा है. यहाँ तक बात होती है जब आप फाइनल पॉइंट्स पे जाते हैं कि वेदर प्रोन इज बेटर और सुपाइन इज बेटर. उसमें वैसे प्रोन के एडवांटेजेस थोड़ा सा एविडेंस है. मोर प्रॉक्सिमल रिसेक्शन मार्जिन्स क्योंकि स्क्वेमस सेल कार्सिनोमा फॉर्म्स अ मोर bulk of our, not a more better bulk but substantial portion of our tumors. तो हमारा ये ख्याल है कि वो और lower reflux. तो ये तो उन questions के answers हैं जो मैं आपको बहुत evidence based नहीं दे सकता लेकिन अपनी reasoning दे सकता हूँ कि why we should have chosen that. अच्छा अब ये this is another important point. देखिए ये जो corrosives हैं ना, ये हमारे सिस्टम में और हमारे पेशेंट वर्कलोड में दे फॉर्म अ वेरी ह्यूज पार्ट. मुल्तान तो जाएंगे तो ऐसा लगता है कि सी एसोफेगस से ज्यादा तो इस तरह ही है ना कि क्रोसिव के पेशेंट हैं. बट बिलीव यू मी दैट क्रोसिव पेशेंट इज more difficult patient to do even in a minimally access approach. तो पहले तो आपको select करना पड़ता है कि ये एक patient minimal access का है कि नहीं है, क्योंकि there will be strictures at the top, there will be strictures at the bottom, there will be strictures at the gastric outlet obstruction. तो आपकी esophageectomy वाला patient कौन सा है तो दूसरा कौन सा है, तो फिर आप करते हैं. And then people might debate कि in advanced end stage eclasia esophagectomy is on or not. But we have been doing about not many patients, but somebody who we think will not do well with the routine procedures first. So we have done esophagectomy in those patients. And one or two cases, few cases of trauma, which were then excluded, and then we needed to go to a esophagectomy. Start with. ये तो फिर एरस का very well spoken of. एरस कर लिया, टेक्निक हमने आपको बता दी. I don't think so. फिर वर्कशॉप भी हो गई है. Let's go to some other finer points. लैब तो डॉक्टर इफ्तिखार ने हमसे अच्छी आपको दिखा दी लैब. इंट्राकॉर्पोरियल वर्सेस एक्स्ट्राकॉर्पोरियल सुचरिंग, नेक फेज भी आपको स्टेपल्ड वर्सेस वो भी दिखा दिया. अच्छा, ये सर ज़हूर ने पूछा कि टोटल रेंजो फ्रेंजो एसोफेजेक्टमी की कोई अभी तजर्बा है होता है कि नहीं होता. सर हमें बहुत होता. Our ENT people have given a way of doing this total range of pharyngoesophagectomy because they think it's tedious enough. And secondly, वो stomach तो हमें नहीं ऊपर लेके आना है. हम jejunum पे नहीं है सर अभी. We are not onto the jejunum. हमारा उसका learning का भी तो we think stomach is a good enough organ to be taken up into the up to the base of the skull ही कह लें उसको, जो है ना, ठीक है ना सर. If it is made well, the tube is made well, तो अब वो हमने कैसे करनी थी, वो भी हम minimal access से करें. अब minimal access से क्या problem है? This tube has to be, we have to be more careful in this tube rather than the normal esophageectomy, को इसने बहुत ऊपर जाना है. तो हमने वो भी ट्रांसआइटल डिसेक्शन करके उसमें, क्योंकि मीडिस्टाइनम की प्रॉब्लम नहीं है. मीडिस्टाइनम इज अ वर्जिन फील्ड इन दैट केस. तो वी गो ट्रांसआइटली, वी पुश bluntly and with swab and under vision, and then we put a finger in from the top, and then we can deliver it to the top. So TLPO forms a substantial part of our workload. तो हम उसको मिनिमल एक्सेस करते हैं. तो पेशेंट को आसानी तो है कि लेप्रोटमी उसकी लेदर नहीं हुई और सिर्फ उसका एक नेक का बड़ा इंसिजन है, तो इट डिक्रीजेस द मॉर्बिडिटी. क्रोसिव स्ट्रक्चर्स मैंने आपको बताया कि अगेन फॉर्म मुख्तलिफ तरह के क्रोसिव स्ट्रक्चर्स हैं, लेकिन द पेरीसोफेजाइटिस इन देम इज वेरी डिफिकल्ट. तो उधर जो है ना वो फिर हुक से नहीं, मैं तो डायथर्मी यूज करता हूँ कि पेशेंट्स चूज करते हैं, लेकिन इट इज अ सब्सटेंशियल वर्कलोड. मोटिलिटी डिसऑर्डर जिस तरह ये एंड स्टेज एक्लेजिया है, ये तो वो जो ऊपर से निकल रही है एसोफेगस, पता नहीं आपको क्लियर नजर आ रही है कि नहीं आ रही, इतनी बड़ी एसोफेगस है. द प्रॉब्लम इन दैट अगेन इज कि उसकी वास्कुलरिटी इंक्रीज हुई होती है, उसके ब्लड वेसल्स जो है ना दे आर डायलेटेड. उधर हार्मोनिक यूज करें एंड मे बी डबल सिक्योर करें उसको और फिर यूज करें. मेरी ये टीचिंग है. एंड देन इट इज डिफिकल्ट टू फ्लिप फ्लॉप द एसोफेगस इन द मेडिस्टाइन. बड़ी है ना, सिग्मॉइड है, तो आपको पकड़ के उसको इस तरह नहीं घुमा सकते जिस तरह मैं कल घुमा रहा. तो थोड़ा सा ना उसको केयरफुल के लिए, लेकिन हो जाती rather than going to thoracoid. ट्रांसआइटल भी हो जाती है if you want to do it. तो ट्रांसआइटल की कोई और कंट्राइंडिकेशन तो नहीं है, बस कभी कहते हैं कि ये ब्लड वेसल ज्यादा हैं तो you have to be a little careful. तो अगर अंडर विजन हो जाए तो मेरे ख्याल में adds to the safety factor, तो वो आपको कभी कभी ऐड करें. पोस्ट ऑप वगैरह एराज एंड एवरीथिंग हैज बीन डिस्कस्ड. These are one of the pictures Brigadier Farhan has put up. Since and another distinction from the initial presentations is we are not talking about carcinoma of the esophagus now, sir. It includes corrosives, it includes TLPO, so our total number is 388. कार्सिनोमा में हम आपको मैच ही नहीं करते, एक तो इस लिहाज से भी, और दूसरा ये कि हमारा वॉल्यूम इस 40-50 के राउंड है पर ईयर, कॉम्बिनेशन ऑफ दिस. तो हमारा लर्निंग का जो कर्व है ना वो थोड़ा सा डिफरेंट है. और ये तो फिगर्स ही हैं. उसके आगे रिजल्ट्स वाइज ये है कि ऑपरेटिंग टाइम इज इम्पॉर्टेंट ऑब्वियसली. तो 6 घंटे लगे हैं. जब पहले दिन मैंने 6-7 घंटे लगा के की, शाम को थक के फारिग हुआ, तो पहला फ़ोन मैंने ब्रिगेडियर सुल्तान को, और मैंने कहा कि सर आपको पहली ट्रांसआइटल में कितना टाइम लगा. तो उन्होंने कहा कि मुझे 6 घंटे लगे. मैंने कहा सर आज 6 घंटे मेरे इसमें लगे. एंड ही वॉज द मोस्ट हैप्पी पर्सन. इट्स अ ट्रिब्यूट टू हिम एक्चुअली कि उसने हमें इनिशिएटिव दी और हम लगे. मेरा पॉइंट है कि लर्निंग क्या है. लेकिन कल आपने देखा वी डिड 2 esophageectomies within about 3.5 is an average time, or 320 hours is a decent enough time for a esophagectomy. मे भी इतनी अच्छी नहीं हो जितनी सर वगैरह कहते हैं, लेकिन इट वाज हमारे लर्निंग का मेंबर्स. और फिर टाइम कंस्ट्रेंट्स के हिसाब से सर इस तरह ही है. हमारे एक और भी मसला है सर. द लॉन्गर वी हैव द पेशेंट ऑन एनेस्थीसिया साइड ऑफ इट, तो हमारी पेशेंट्स जो है ना वो इतने अच्छे मैनेज नहीं होते जितने आपके तो 10-10 घंटे की सर्जरी करें तो दे प्रॉब्ली आर मोर विजिलेंट। हमारे करते हैं कोशिश, लेकिन प्रॉब्ली वो जितना हम लंबा करते जाते हैं ना सर, तो प्रॉब्लम्स जो है ना बढ़ती जाती है। तो वी कल्चर नहीं है, तो हम कोशिश करते हैं कि यार टाइम सेव कर लें। ये इस तरह है ना सर, इस तरह ही है। हाँ। तो आईसीयू स्टे तो कभी, अब हमने जब हमारी इसोफेजेक्टमीज अब अच्छी हो जाती हैं, जिस तरह सर आपके तो रिजल्ट्स बहुत अच्छे हैं, तो कई दफ़ा हम एचटीयू भिजवा देते हैं, आईसीयू भिजवाते ही नहीं। और कभी बहुत ही मसला हो जाए तो फिर वार्ड में भिजवा के एक ट्रेनिंग को साथ बैठा देते हैं कि यार देख लो शाम तक ये उठ जाएगा। तो हमें तो एक सब्सटेंशियल इमीडिएट पोस्ट ऑपरेटिव उसकी बेनिफिट नजर आता है। ट्रेकियोब्रोंकल इंजरीज में बड़ी चीज़ों की बात करूँ, सिर्फ 2 हुई हैं और स्टार्ट ऑफ द कर्व में। कल मैंने अर्ज किया और सर आपसे को दिखा भी रहा था कि मेम्ब्रेनस पार्ट द ट्रेकिया से जरा उतारते हो ना, देयर यू हैव टू बी केयरफुल। सर ने कहा कि आप ये हुक यूज कर रहे हैं तो वो तो हुक तो मुझे तो हार्मोनिक का भी तजर्बा वैसे इस तरह है कि इफ यू अगर हार्मोनिक यूज करना है तो बाइट, असल में बाइट छोटी लगती है। अगर आप बाइट बड़ी रखेंगे तो फिर द बिगर द बाइट द बिगर द होल, ठीक है ना सर। तो अगर आप अंडर प्रिसाइज विजन करेंगे तो शुरू में एक को हमने खोल दिया डर के मारे कि अब क्या करेंगे, और दूसरे को जो हमने उधर ही स्वैब रखा और इस तरह एक स्टिच लिया और वो हो गया, प्रोन पोजीशन में ही हो गया। तो इसलिए वो हो तो जाता है, लेकिन उस एरिया में जरा आप केयरफुल हो जाए। उसके अलावा लीक हैं हमारे, होते हैं। अब तो लीक इन एनी केस वो मैं आगे डिस्कस करूंगा। मिनिमल एक्सेस सर्जरी की एक ही एविडेंस अभी ये है कि लीक कम नहीं हुआ, जो मैंने पढ़ा है लिटरेचर में। स्ट्रक्चर्स बन जाते हैं, खासतौर पे क्रोसिस वालों के बन जाते हैं। क्रोसिस वालों की इसोफेगस ना बर्न्ड होती है, तो उसमें अगर आप एनास्टोमोसिस ऑन अ रिलेटिवली अच्छा, उसमें आप 6-7 महीने बाद करते हैं, फौरन नहीं करते, बिकॉज द प्रोसेस इज गोइंग ऑन, द फाइब्रोसिस गोइंग ऑन। लेकिन फिर भी स्ट्रक्चर्स बन जाते हैं जिसमें डायलिटेशन भी चाहिए करनी पड़ती है, और कई दफा स्ट्रक्चर प्लास्टी भी करनी पड़ सकती है। काइलोथोरैक्स हमारी प्रॉब्लम रही नहीं सर, सो 1-2 केस के वो, लेकिन मैं वेस्ट में पढ़ता हूँ, उनके थोड़े से इंसिडेंसेस हैं, तो रही भी है, तो हमें तो उसका कोई मसला नहीं हुआ। हमने जल्दी पिक भी कर लिया और उसको लेप्रोस्कोपिकली थ्रैकोस्कोपिकली क्लिप भी कर। डेथ्स होती हैं, मोर्टेलिटी है 0 तो मैं क्लेम नहीं कर सकता, लेकिन ये जरूर क्लेम कर सकता हूँ कि अब हमारी ना सर ये जो मोर्टेलिटी रिड्यूस्ड है ना, ये इट इज नॉट बिकॉज ऑफ द सर्जरी लोन, इट्स पेरी ऑपरेटिव, आईसीयू केयर, पावर ऑपरेटिव टेक्निक्स, ये सारी मिला के इम्प्रूव हुई है। सर्जरी तो पहले भी बड़ी अच्छी हो जाती थी। So in conclusion is 3 or 4 slides. It's not simple conclusion. Advances in anesthesia and post-operative intensive care, technological revolutions. देखिए मैकेनिकल स्टेपलर से फर्क तो है ना। पहले एक स्टेपल लाइन एक ट्रेनी ऊपर से शुरू होता था, एक नीचे से शुरू होता था, फिर जल्दी जल्दी वो करते थे। अब ये स्टैंडर्डाइज, एक आप ट्राई स्टेपल जो कोई यूज करेंगे तो इसमें स्टैंडर्डाइज तो हो जाता है ना। एनर्जी डिवाइसेस आर बिग हेल्प। कहाँ आप नोटे मान रहे हैं या फिर काट रहे हैं या शॉर्ट गैस्ट्रिक्स, तो अब मसला तो बड़ा नहीं रह गया ना सर। इंडक्शन कीमो रेडिएशन थेरेपी हैज इंप्रूव्ड द रिजल्ट्स एक्चुअली एज फार एज द सर्वाइवल आर कंसर्न। और दूसरी चीज ये देखें, इसोफेगस में ना अगर आज हम बैठे ओवर सेंचुरी यही डिस्कस कर रहे हैं कि इसमें रिकरेंट का मसला है, इसमें रेस्पिरेटरी का मसला है, तो मसला तो है ना, तो इसमें रेंडमाइज कंट्रोल ट्रायल उस तरह नहीं ना हो सकती कि हम एक पेशेंट को कहें कि नहीं हम आपकी ट्रांसआइटल करते हैं, आपकी रिंगर करते हैं, आपकी थ्रैकोएब्डोमिनल करते हैं, आपकी एमआई करते हैं। तो ये तो फिर कोलैबोरेशन जब इंटरनेशनल बढ़ी है और ग्रुप्स बने हैं तो फिर एविडेंस कलेक्ट हुआ है ना, वरना तो प्रेफरेंस है। रिंगर ने कहा कि बस ट्रांसआइटल के अलावा कोई चॉइस नहीं है, दूसरे ने कहा वो कोई चॉइस नहीं है, किसी ने वो पकड़ लिया, किसी ने वो पकड़ लिया। लेकिन कैसे एविडेंस स्ट्रांग हो? एविडेंस स्ट्रांग होता है जब आप कोलैबोरेशन करते हैं। तो अब कोलैबोरेटिव ग्रुप्स बन गए हैं तो और ज्यादा एविडेंस आता जाएगा, आप अपनी चॉइसेस आप अपनी रिफाइन कर सकते हैं। Or 30-day post-operative mortality has gone well below in experienced hands and centers. MIS के तो अपने एडवांटेजेस हैं, एवरीबॉडी नोज, तो मेरा ख्याल में, और लेकिन ये जो एविडेंस बेस्ड है ना ये अनसर्टन है। वो जो खानजादा ने बात की और डॉक्टर इकबाल ने बात की कि कोई एविडेंस ऐसा इररिफ्यूटेबल नहीं है कि MI इज सुपीरियर टू ओपन सर्जरी। अगर इफ यू टेक केयर ऑफ पर्टिनेंट थिंग्स तो रिजल्ट्स बराबर है। स्वाई अर्ली पोस्ट ऑप रेस्पिरेटरी एटिलेक्टेसिस के बाकी कोई एविडेंस स्ट्रांग नहीं। लेकिन मैं आपको बता रहा हूं कि ओवर अ पीरियड ऑफ टाइम along with the allied facilities that we have got, तो हमने ट्रांसआइटल भी की है, थ्रैकोएब्डोमिनल की है, तो हमें लगता है कि हमारा पेशेंट इस वक्त इज फेयरिंग वेल बिकॉज वी डोंट हैव अ लॉन्ग टर्म फॉलो। हमने तो ये देखना है उठा जल्दी है, खाना पीना जल्दी शुरू हो गया, चला गया है, तो हमारे से ये चला गया। अच्छा, ये मुझे एविडेंस का मुझे भी पहले आइडिया नहीं, ये अब कितना स्ट्रांग है ये मैं नहीं कह सकता, लेकिन एनास्टोमोटिक लीक रेट कम नहीं हुआ डिस्पाइट ऑल दीज एडवांसेस। उसकी वजह जो है वो ये ज़रूर है कि अब हम चूंकि मुख्तलिफ टेक्निक्स सीखना चाह रहे हैं, अडॉप्ट करना चाह रहे हैं, तो फिर हर एक का लर्निंग कर्व भी है और हर एक के वो रेट्स भी हैं। तो इट इज़ नॉट डिक्रीज टू द एक्सटेंड कि आप कहें कि अगर मैं स्टेपलर यूज़ कर दूंगा तो ख़त्म हो जाएगा, तो फलाना यूज़ कर दूंगा। और मेरी बात में आई परफेक्टली विद डॉक्टर इफ्तिखार कि जो है ना टेंशन फ्री वेल परफ्यूज्ड कंडोई एनास्टोमोज्ड वेल बाय एनी टेक्निक, तो पिंक इन द बेली, पिंक इन द नेक, ये आपने सुबह सुन ली है, इन्होंने कभी नहीं सुना होता। ये ओरिंगर की स्टेटमेंट, वो कहता है वो यही होता है ना कि सर्वाइकल, तो वो कहता है कि इधर आप पिंक ले आए और मिनिमल एक्सेस में पिंक लाना आसान है कंपेयर टू एन ओपन ऑपरेशन। देखिए इफ यू हैव नॉट टच द स्टमक, कल हमें थोड़ा सा करना पड़ गया क्योंकि शॉर्ट गैस्ट्रिक्स वर इंक्रोचिंग अपॉन, कुछ फाइब्रोसिस हुआ होता, वरना तो हम भी टच बिल्कुल नहीं करते। तो इफ यू डोंट हैंडल द स्टमक इट इज सपोज्ड टू बी पिंक। तो एट द एंड ऑफ द डे हाई वॉल्यूम सेंटर क्या है, इसकी डेफिनेशन मुझे नहीं मिली। एंड पीपल वुड से कि 4 से कम है, कोई कहता है 16 है, कोई 40 कहता है, लेकिन अ डिसेंट वॉल्यूम एंड आई वुड से अराउंड 15 to 20 पर ईयर तो होना चाहिए ना लर्निंग कर्व आपका स्टैब्लिश करने के। क्योंकि अगर आप ओकेजनल ऑपरेटर हैं तो फिर तो ये तो टेक्निक आपके लिए है ही नहीं है, कोई भी टेक्निक आपके लिए नहीं है, फिर आप करें ना, ठीक है ना सर। और खास तौर पे अगर आपने मेंटरिंग करनी है और आपने सिखाना है, इट्स अ कम्प्लेक्स बट टेक्निकली फीजिबल। मैं बार बार कल से आपको ये कह रहा हूँ कि ये फिजिबल है, ये मुल्तान में फिजिबल है, ये रहीम यार खान में फिजिबल है, ये कोयटा में फिजिबल है। ये ऐसी बात नहीं है कि अब आप नहीं कर सकते, क्योंकि आपके पास बेसिक प्री रिक्विजिट्स हैं। अब आपकी ट्रेनिंग रह गई है, ट्रेनिंग या कल से शुरू है और यू आर फ्री टू एनी टाइम टू कम टू खानजादा एंड हमारे पास, या कोई और भी कर रहा है तो उसके पास जाएं। इसका लर्निंग का इतना बड़ा नहीं है और उसके करने के तरीके हैं, तो करें। यूर लॉन्ग टाइम टू गो, जो भी ट्रेनिंग कर रहे हैं इतना आगे जाना है कि वो भी शुरू करेंगे तो हो ही जाएगा। So in an academic setting, learning curves are required, but compare ontological outcome. At the end of the day, it's the patient safety and the ontological outcomes. तो उसमें फर्क नहीं है। ये नहीं कह सकते कि ये आप करेंगे तो आपको लिम्फ नोड रिट्रीट नहीं हो रहे या आप जो है ना मार्जिन नहीं ले रहे, तो कर सकते हैं, तो then it is as good as any other procedure. आगे क्या होना है ये तो मुझे नहीं पता। आगे टारगेटेड थेरेपीज आनी है, आगे जेनेटिक कोई इंजीनियरिंग होनी है, आगे एआईज कैसे यूज होने हैं, रोबोट से भी बात आगे कैसे चली जानी है, ये अब आपने देखना है। हमने तो कर लिया जो करना था, अब आपने यू हैव कीप पेस विद द एविडेंस एंड यू हैव टू अडॉप्ट एज सच। थैंक यू वेरी मच।
Thank you very much for an excellent and elaborative talk on esophagus and esophagectomies. The message is learn from the mistakes and the truth makes the way forward. Just a quick comment, we are already running short of time, probably because of something happened in between. So if there's no comment, we can continue with the next. Okay, so I would request Dr. Rashid Mazhar, and all that glitter is not gold is something which everybody wants to see what is coming out of the box.
Exactly. Thank you very much. First of all, while you're putting up my slides, thank you, Professor Amir Bilal, for giving me this opportunity to rub shoulders with real heroes and giants of thoracic surgery, which this land has produced. I'm really thankful to you, grateful. My topic is not about a particular operation. It's about the way we are operating, and thank you, Bilal, you have set the stage for me with your last slide, the future. Now, when we, okay, so just go down there.
Yeah, okay.
Now, this is a cliche. Everybody knows this. The actual thing, what I wanted to talk about is about the new kids on the block. We are neither the progenitors of methodology or the technology. Whenever you get into these meetings, you will hear this word, which Dr. Muslim now must be very familiar with. I say, stop using the term they. We always say, they said this, they do this. Now they are, where are we? We need to get onto our 2 feet. And this is part of that drive that you analyze what is going on. Now, the basic difference between the thoracic surgery, and I'm talking about general thoracic surgery here, and in the Western world, is that the Western world thoracic surgery, general thoracic surgery, is largely cancer surgery, lung cancer surgery. We have largely infective surgeries. Number 2, they are physically and morphologically, their patient subjects are different than our subjects. They have bigger, wider chests, so you can go in with the scopes and you still have a mile all around you. Now, so if we talk about these 2 things, which you keep hearing now, and I felt this when I came here in the trauma meeting at Dr. Fiza's invitation, that I felt a kind of loss in our youngsters that we do not do these things because we are short of technology. And we are short of technology because we cannot afford it. Simple. This is the sequence. So that's me. Now, let's get on to my conflict of interest. None, except that I always have conflict of ideas with my colleagues. So now, let's on the uniportal wax. You've all heard that. You've all seen on YouTube videos, the glittering images, everything should be done, can be done, must be done by a unilateral. Okay, let's go. I know. Thank you very much for. So this is a good opportunity. You will be in a context. So I'm just doing a contextual presentation. I'll put this thing in context. So when we talk about okay, so there's a critical review. What I would do is that this is started in 2011 by none other but I've met the gentleman. I have highest regards for him. He's an absolutely exceptionally gifted surgeon in that context where he operates, not in every context. So Diego Gonzalez, he started in his group. Now, immediately, people like me who are born skeptics, they said, oh, the first point I will talk the last about, this is the Chi. But let's see, well, there has to be selection bias. You're doing these cases, you're selecting them very well. There are other aspects of that you tell us how much is the skin incision, how much is the intercostal incision underneath. That's invariably 3 centimeters on either side longer than the skin incision. So you're only fooling the patient, not the body of the patient. And pain, you talk about that this is less painful, but pain is a very subjective scoring method and analysis and charting. And we'll talk about that in other. And for cancer, it's the operation which you do inside is not the way you have gone inside. So cutting open the chest is the least important bit in cancer oncological cure viewpoint of surgery. And the Chi is something important for many of my younger colleagues. This thing is now being practiced mostly in none other than our neighbor in China. And the Chinese people have got an age-old long superstition. They have a system of Chi. Chi is equivalent of Ruh. And they say this is the energy of the body which flows in a system which is not arterial, vascular, or lymphatic, but it's a meridian system. So it flows in a meridian system, and you will find the beautiful diagrams, and that's where they put in their needles in acupuncture and get some results out of that. So the point is that if you have one cut on the body, the meridian is not interrupted. Like you have a bangle, metallic ring, and you cut it at one point, it will maintain its circularity. But if you take 2 points cut, then that piece will fall away. So one incision was a hit in China. And that's where I think people found opportunities. And that's why UVAT has become the thing. But we'll talk about this. I'll present to you 4 studies. And the point is very quickly in 3 things that I'll tell their design, tell their findings, tell their conclusion. And for my younger colleagues, you need to learn how to read these studies and go back and read the fine prints and then come back and look at the conclusion and make your own decisions whether you agree with them or not. So now let's see review number 1. These are all in last 4 years. Now that is an American study. It's from the American National Cancer Base. Now first study, I will just put this elephant from the room that is it good for cancer? This method of operating or open method of operating. So, and this is from Stanford and Duke universities. you can see there was a small number of UVATs and large number of open, and they had a good follow-up of about 43 months. And that comes down, say no significant difference except in the red, the median hospitalization. That is 1 day difference. One group had on an average 6 days median stay, the other group had 5 days. So from cancer viewpoint, it's all the same, but it proves the non-inferiority of UVATs. Please remember that. I do not take the shine away from that, what is glittering there. So that was a non-inferiority study, and the conclusion was that they were similar and it is feasible, which is fair enough. Correct? Let's go to another study. Now, this is the study which is coming out from nearly 2,000 UVATs and multiportal VATs. So now you pitch the actual technique against, you make 2 or more holes in the chest wall, and you have only made 1 little hole in the chest wall. And this is coming from Shanghai. So it's a large study. It includes prospective studies, 1 at least randomized controlled trial, and 4 propensity score matched studies. And their findings are these. Now you can see the NS all along. Not significant difference. This is coming from the horse's mouth, from Shanghai General Thoracic Hospital. And all these, the operative time, the blood loss, the resected lymph nodes, conversion rate, length of stay, and post-operative pain. No difference between the two. So their conclusion was that there is no extra benefit of UVATs compared to multiportal VATs. And you should prudently choose. Now that always reminds me of a lecture of one Professor Wakabayashi, who is a Japanese-American surgeon and famous for his lung volume reduction surgery. And I heard his lecture in London. And he said, well, when I go in with a camera and I need instrument, I never lever my instrument. If I have to make 6 holes or 8 holes, I will do that. But I will only go straight because that gives you pain. So here you see that there was no extra benefit of reducing the incision to 1 and doing it as compared to multiple if you are convenient. But again, that is a non-inferiority statement. So you can do if you want to do. Let's see the third study. This was very close to my heart because it came from my alma mater. Professor Eric Lim is now at Brompton and Harefield, where I was trained. And this study came, that was the first randomized controlled trial. We were all waiting for it. So you do the proper thing. And it was a multi-center, I think it was a 9 centers across UK, where all the big names were doing thoracic surgery from Glasgow down to south. And the numbers were not huge, but again, it was a randomized controlled trial. And it was basically for this purpose, that whether you do a lobectomy with the VAT or an open, whether VAT is better or not. Remember that before the other 2 large studies, they were meta-analyses of other here. And they had a primary outcome in that study. Physical function at 5 weeks. Anything strikes you as odd? The number 5 weeks strikes you as odd. And that was highly significant. Okay, great. And then secondary outcomes were all same. So most important secondary outcome you were looking for was pain, hospital stay, bleeding, length of the chest tube. And the longer the chest tube stays, the longer the patient stays in the hospital, and the longer the pain lingers. So these 3 things make a single entity. Now, when I read that article, I said, okay, that is how it is, conclusion is portrayed, that oncologically, although both are same, but VAT is superior to open because it has better physical function at 5 weeks. And then you go into the finer prints and you see that where your problem starts. I said, first of all, you look at the raw data in there or processed data in there, and there's a mean difference point of 1 at QLQ-C30. How many of you are familiar with that? Please raise your hands, juniors. Quality of life questionnaire. with 30 questions. You haven't heard that, haven't you? Neither have I. Okay, because I've never used it. So this is, and the mean difference has to be 5 points. It's a 0 to 100 point score, which tells you how good or bad the patient is. And in the study, they themselves has got few disclaimers which are hidden and nicked inside the study. It's say, okay, how did you decide which patients will go? Is this a randomized controlled trial? How would you say which will go for open, which will go for, okay, we randomize them. But then who will do the UVATs and who will do the open? UVATs will be done by the senior most surgeons. Who will do the open? Open, our registrars will do. So a registrar in Glasgow and a registrar in Sheffield and a registrar in London, they all, one is coming from Sri Lanka, the other is from Gambia, the third is from Pakistan. They all have different methods. So, and they declare that we do not direct them how to do it, because we rely on the UK training method, which is a posterolateral thoracotomy is the standard when we say open. So you already see that there is a heterogeneity in that group. So there is, the surgeon's choice is the type of thoracotomy. The surgeon's choice is the postoperative analgesia preference. And that something which goes against this whole philosophy of comparing the two things. So you did not select the patients, but you selected the surgeons here. Now, come back to this yardstick, the quality of life questionnaire. We haven't heard of it because this is an oncological tool. The physicians use it, oncologists use it. And Dr. Iftikhar will tell us that when you have a patient discharge, you usually follow them after a couple of weeks or 1 week, and then you call them after 6 weeks. I kept scratching my head that in more than 5 years there, I've never seen a patient at 5 weeks. So if I'm doing a randomized controlled trial, I will fit my primary outcome before the trial starts, not after the trial is going on, and then I see the numbers and I see the 5 weeks is standing out, so I put it as my primary outcome. That is not nice. I can't see the slide, sir. I cannot see the slide. This slide again. So the QLQ, the oncologist has got multiple quality of life questionnaires. There are some which are specific for esophagectomy QLQ. There is pneumonectomy or lung resection QLQ. And they have questions which are purely oncological. Can you click again? Yeah. Now you will see. So these two were, you see, they have points like, they will ask the question, every patient will have 1 to 4. So you will have number 0 to 4, I think, on each question. Have you got loss of appetite? They will say a number. Are you stressed? Are you depressed? Do you feel irritable? Do you feel tense? I kept saying all of these are weighted in that scoring when you. Exactly, sir. But none of them, none there was how much you are taking as analgesia. Do you have pain when you cough? Do you have pain when you move your shoulder? Do you have pain in our society say when you pray and go into ruku or prostration? None of that. So I said, this is plus another thing. Now I come from a society in Qatar where 100 nationalities work. And anybody, Muslim is sitting behind you, he will say, well, they widely differ in their pain threshold. Our Pashtun brothers, they have the most famous, highest pain threshold. You look at their heart rate, he's going into SVT. The bugger is not telling you that he's dying in pain. You ask him, he will say, no, I'm okay. So you help him according to his heart rate. And you have, I will not name those nationalities, but you touch them and they will jump out of the bed. So this is one study which was done on this quality of life questionnaire, C30, 30 questions. And what they did, that they found the largest difference of up to 10 points between countries. The highest were from Europe, lo behold, no surprise, with the Vikings, the toughest, the Dutch and the Austrians, who had an empire before. They were the toughest in their pain and the QLQ scoring as compared to other people. So my understanding was that this yardstick was incorrect, and I do not buy a lot in that. The last one is This is from Taiwan. Again, a retrospective study. Now they are meta-analysis of other studies, but they are very large number, and they're comparing the perioperative efficacy. And if you see there, the red ones are not significant. You have a marker here which works. Yes, pointer. Sorry. So the red ones are not significant. Fair enough. Okay. Oncologically, we have already said that you do not kill people by doing one method of opening the chest or the other method. But then these were all okay. Great. So these were all non-significant, but these were all reported in the conclusion that they have less chest tube duration. They stayed in the hospital less, and they had less pain. So that is proving superiority of UVATs. But then when you read, you say that is not in the proper format. Why is this format of the standardized median deviation? So whenever you read a study, please read. Nowadays you have AI everywhere. ChatGPT is so easy. You just say, "What the hell is this?" and it will tell you, and ask it, "Tell me in a very simple, basic secondary school student level," and it will tell you all the details. So when you go in, and the conclusion was that this is better, but I say, no, sorry, I have to look into it properly. It doesn't fit in. And when I go in and I read that, so uniportal and two-portal VATS groups, the uniport group had SMD of 4.19 days on an average. They stayed in the hospital. The chest tube time. And the two-port had 4.16. That means the difference is 0.41. So this group had chest tube longer than the uniportal for 0.41 days. What does that mean? Your fellow has gone for lunch. He will come back in the afternoon and remove the tube. He had other things to do. He was called in. Happens every day. Half a day difference or less than half a day difference. But you can write it as an SMD and prove it that is mathematically it's better. And similarly, then for the other group, that chest tube in the uniport group, this was and the other slide will tell you the other yardstick. The other was how long they stayed in the hospital was 1.1 days. So half a day and 1 day, that's the difference between these two. This is the summary of those 4 studies. These 4 studies have told me when I read the conclusions, and you get impressed, and I get impressed when I read the conclusions, that UVATS is better than multi-VATS, and the total number of more than 3,000 and 5,000. And when you go through these studies by fine comb, then you see that one will say that there's a 1 day extra hospitalization disadvantage in one of them. The other will tell you that there is no extra benefit. The third will tell you that the chest tube comes out at a half a day or 1 day earlier, and that means the pain is less and the hospital stay is less. And the last one we talked about, the Brompton study, which has, I'm sorry to say, used the wrong yardstick to measure surgical outcome. So that's the current evidence. You will hear proponents of those people. Now you're confused what to do. Now your seniors have laid down already. I'll just coin a concept. I'll put a spanner. I put the spanner in the wheels, and now let's make sense of the things. The pain is not an objective assessment. Up till now, we do not have a neurometer, which you can put here, and it will tell you that it is at this scale an objective thing. We ask the patient, and you heard that how patients vary in their perception of pain and reporting of pain. So when you say open thoracotomy, did you notice that none of those studies will show how many ribs were fractured in open? Nobody fractured a rib in 4,000 open thoracotomies. That is a remarkable achievement. When you see people opening, you see people differ in the way they open the chest. There are people who will go on in the intercostal space and above with a cautery, and you are burning along the periosteum. When you cut, you're immediately after half thickness skin cut, you use the diathermy. You're leaving a patient with a burned skin, with a burned periosteum, awfully painful things to do. So the method is important, how much crushing you used, and what is the analgesia management. And we talked about the subjectivity of the visual analog pain scoring systems. This is one small study from Bristol. It had 12 small studies. The total number was not massive, I think about 120 odd patients, and it asked the specific question. The UVAT, is it less painful or not? And the answer was that insignificant effect. You need to have an objective method to assess these differences. So it comes out squarely on the side of non-superiority of UVATs as a method. Now, so what is my take-home message from all of this blabbing? Talk about minimal invasive surgery, sure, but please talk about minimal pain surgery rather than minimal invasive surgery. Minimal invasive is a subset of minimal pain surgery. So how do you think about that? And that when you go in, you think of all those factors which can produce pain. You are the most painful factor, the surgeon. So and all these things which you use during surgery is like a battle, and these are different armamentariums. So for every battle, you have to choose your armaments properly. This is not a single fit either for you as a surgeon or for your patient. So you have an open mind. Of course, you do not want to make a longer incision than necessary. You don't want to make any more damage than what is essential to the patient. Think of all the pain-producing factors all the time. From now on, you're doing open surgery. You start critically evaluating your incisions. See how much part of the incision, why do we have an incision? To have the light go in, to have your vision, to have your hand and instruments go in. And you see which part you're not using. So you can cut down, and I will advise you cut down from the back. Cut down 1 centimeter, 2 centimeters of your incision. Keep moving forward, keep shortening and keep moving forward. Very soon you will be surprised that you're doing the same operation. This is 9 centimeters on an average. You never put your hand like this. You can put your hand like this. So it requires 6 centimeters to put your hand in. You need another instrument, and the most life-saving instrument is a swab-on holder. Massive bleeding, you get in, you stop that, and then you convert things. Okay, so 9 centimeter incision will give you both of these. You reach that target, you have reached minimal invasive. Because how many juniors can raise their hand if I ask you, what's the definition of mini thoracotomy? That's not a question. That's a take-home message. We do not know. So we jumped from thoracotomy, somewhere gray is mini thoracotomy, and then to UVATs and minimal invasive. So you have to create a balance between these things. So that was my, and this is a very famous thing. I usually put that, we all read. And if I read that, I always enjoy reading that the Robert Hutchinson used to pray every night, they say. He would sit next to his bed like a good Christian and on his knees, and he will pray that from inability to let well alone, from too much zeal for the new and the contempt for what's old, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases, and from making the cure of the disease more grievous than the endurance of the same. Good Lord, and in some, dear Lord, deliver us. Okay? I will take questions at the end, if you guys don't mind. And then I'll come to my second part, because in the beginning I said this will be about UVATs and robotics. Robotics will be more visual and a shorter presentation. So you heard that one method was that you are doing the same operation by a small single incision. No onconological superiority, no inferiority there. Pain is an overblown, I don't know why in the literature there's a convoluted presentation that the pain is less. We do not have any evidence for that. Now, if you talk about robotic surgery, there are myths about it. I do robotic surgery. Dr. Muslim is with me. We went to France, we got training, we went to Turkey, they came down, and we do. There are realities to robotic surgery. So let's have a critical review about this. The evidence, what is the evidence in favor of robotic surgery? Now, this is a large study, nearly 1,000 patients, which robotic lobectomy, open lobectomy, and video-assisted lobectomy, coming from with a propensity scoring matching, more than 5,000 cases. And coming from where? Coming from the top places. Harvard, Mayo, MGH, Washington, Duke University, name it. University of Texas, the big names, big numbers. And their summary is, don't want you to go through that, but the summary is that everything is better with the robotic. So the conclusion was that on a goodness scale, robotic was better than VATS and VATS was better than open. Sare taslim kham hai, we cannot challenge them. Great. They have the skills, they have the equipment, they have the numbers, and they have the science behind it now. So perioperative outcomes, and the robotic lobectomy has a reduced length of stay, decreased conversion rate compared to VATS. One thinks, now when? Now what we do? Shall we all pool our all resources and buy lots of robots, train everybody in robotic? And, or is there a way out? Or is there some thing we can do about it? That has been my passion for a couple of decades, technology, innovations, and reductive analysis. You see a problem, you break it down like a child, keep asking why, until you reach nowhere. Now, the term atom, we are the only nuclear Muslim country, atomic power. The word atom is from atomos, Greek, thousands of year old term. At that time, Greeks did not even have a magnifying glass, let alone a microscope. How did they coin the term atom? The definition of atom being the smallest part of a element or a material which you keep cutting until you can cut it no more. That is atom. That's pure logic. When the British came here, they removed our educational system. And in that, my father used to tell me, they were taught into mantiq, logic, how to think logically. We have to learn it ourselves now. So now you go on and say, take the problem, and we are impressed with this data, with the science, with the technology. There's some sleek marketing. And if I can get this video, yeah. Look at this video. Impressive. Can you play this, please, for me? Hello? Can you ये वीडियो प्ले कर सकते हैं जरा? मैंने इनको पहले ही सुबह ही कहा था कि ये वीडियो जो है मुझे दिखानी है सबको. पीछे नहीं, ऊपर और पीछे जाइए जी. ये वीडियो okay, let's see whether if not I'll ask them to prepare it and show it to you. It's just a marketing gimmick that how the robotics are being presented. You know, amazing video, and you have got these animations and 3D presentation, and you say, wonderful. No, okay, leave it. Thank you. Put it back to. Thank you for your trying. Okay. So you have the. Now let's see. What does a robot give you as an advantage? What do they claim? They will tell you, our optics are fantastic. And when I first time I saw it, I fell in love. Amazing optics, 3D view. The chest cavity, I've never seen it like that before. And you can go up to 12-time magnification. And if you compare it with a video-assisted thoracoscopy or laparoscopy, you have an HD tower and you have a good enough view, but nothing like this. So great optics, number one. Number two, instruments. Now they have a wrist inside. See, all your VAT instrument or laparoscopic instrument, if you want to go up, you have to push it down. You want to go down, you have to pull it up. This is counterintuitive. Our cerebelli are not wired. That's why you have a steep learning curve. You go here and there. You see the novice trying to do a video-assisted procedure and will be running around to find the target. That's why the company named itself Intuitive. That I have an instrument with a wrist inside, you want to go down, you just go down, the wrist will go down, and vice versa. So you have counterintuitive movements, there is a learning curve. the degree of freedom. You go onto any robotic company's website, say 6 degrees of freedom. I did not bring Muslim that video which we made together, but I can share you with some. Dr. Muslim is standing with a robot and comparing his degrees of freedom with the robotic degree of freedom. In video assisted, you have 3 degrees of freedom. You can go up and down, you can go right and left, and you can rotate. So you say, wow, so I've got double the degree of freedoms than the video assisted. So it has to be sweeter twice as much as the video assisted. Keep that. And there is a tremor suppressing and a gain scaling in there, which does not exist. You can make it absolutely rock steady, a minor microvascular movement of the needle. Now, please remember that these are the advertising and these are the poster presentations. So now let's have a reality check. I'm sorry for this is a bit busy slide, but let's see. How do you work sitting on a robot? You have your 2 pinch, you put in there and your paddles, and you go, and you're driving. You immediately think, was it made by an automobile engineer? That he copied the car driving philosophy and he made the robot for the surgeons. We are never trained to operate like this. So it's a pinch maneuver. So it is intuitive, but it is not ergonomic. It's not the way we have been trained. Not the way you want to train people who have been using instruments in the conventional way. VATS is more ergonomic, but it's counterintuitive. Open has got no issues. It's ergonomic. You put your hand, you put whatever you do, and you do it in a very intuitive way. Now, you said that VAT has got 3 degrees of freedom, Rashid. My rats, robotic assisted, at 6. So I asked, how much is the degree of freedom in an open operation, human hand? And I'll come to that. We have 23 degrees of freedom. So when you convert from open to video assisted, you lost 20. But when you come from video to robotic, you got double the amount of this. Hang on. Now, tumor suppression and scaling, and some of your senior colleagues already said that it's there, it's not available here. And if you have too much, then you should teach. Stop operating. We all have been trained this little cartoon here. See, this is the fulcrum, and this is the effector end, and this is the application end. If your fulcrum keeps moving forward, the amount of tremor or the span of movement will become less and less. We've all been trained. If I operate like this, standing, the needle at the tip will shake maximum. If I decrease the fulcrum by putting my tummy to the table, the fulcrum has come here. If I put my elbow onto the patient side, my fulcrum has come here. Then I support my wrist, and then I support my needle holder, and I can do. So this journey will practically eliminate your tremor. But still, if you have got Parkinsonism, then you should not be operating. So that is, I think, is a big advertising gimmick. The problems in the red. Osteogenesis is, I learned in this context, is a neurological condition where you have no sensation in both hands. That's what robot does. You have absolutely no haptic feedback, and you rely totally visually that what you're tying or what you're cutting or what you're pressing, how much is the organ compressed by that. And it's a brutal force, trust me. I know of people going into the ventricle. I know people going into the lungs, and I know definitely people going into livers with the force of the robotic, because you have no sensation. You have a visual in VATS and quite reasonable transmitted sensation. You can close your eyes, and with a robot, with a long instrument, you can poke something soft and you can poke something hard, and you will still feel it. That's a transmitted haptic feedback. And there is no problem in the open. Now, we all know that with robotic, you have got very limited suction irrigation and packing and compression, much more here. That's absolutely free here. 2 surgeons are needed in robotic to do the same operation, which can be done by 1 surgeon. And the lead surgeon sits unscrubbed in the corner of the room. So in case of emergency, they say, doc out, pull out. And you pull out everything, you throw away all that fancy sheet around there because that's limited. And then this guy who is there while you run and scrub, and you lose valuable time. So The conversion, there's no need here. These are the red points which are practical in a robotic surgery when you use. Now come to human hand. I promised you that I will show you. Human hands, your fingers, 4 fingers, have got these degrees of freedom. Abduction, adduction, flexion, extension. And if you do that, 12 degrees, or maybe it is 16, I don't know. The thumb has got 5 degrees. And your wrist, if you take supination, pronation included in that, which the engineers will do that, so you have a total of at least 23 to 25 degrees of freedom in your hand. What happens in robotic surgery is that you have a surgeon all of a sudden who has only got a wrist. His elbow is arthrodesed, his shoulder in abduction is arthrodesed, and then his hand is here, and his whole vertebral column has got a rod which is fixing it. So now you've got only this. That's why you need 6 degrees of freedom. In mine and your case, we can move multiple joints. We can go to the other side of the table and access anything, anywhere. Now come to the main thing, cost. A RACS platform, a robotic platform, will push you down millions of dollars. A thoracic video-assisted platform will hundreds and thousands of dollars. Open thoracotomy, nothing. The service fee, and I'll show you the numbers in the next slide. We pay that, but we pay that because you buy petrol. If you take an alternative energy source, and they will not be buying robots, and we will be using robots. So a large amount, $100,000 to $200,000 per year, is just maintenance fee. That is probably thousands of dollars. And to the poor surgeon, you give a karak chai and he is functioning again. And a cigarette for Sir Zahur. So, and consumables, do not forget, every time you work, they have a very clever way. You see the robotic arm and the effector, whether it's a scissor or a forceps or a grasper, you clip on that. Now this is trained. It will not take it after 18, 19, it will reject it. It has a metal. It used to be 10. Now they have, by public demand, they have doubled it. So I have an anecdote. Somebody has told me, who is a big salesman guy of this company, Intuitive. He said, I went to Russia and they did a wonderful robotic operation. And I saw their robotic scissor was crooked. I said, how many cases you have? Were you cutting bone from it or what? I mean, why? I said, no, we have done hundreds of operations. I said, what do you mean by hundreds of operations with one scissor? I said, yes, we don't switch the machine off. So their center is still saying the one operation is going on in Strasbourg or Russia is for last several months. So each procedure will push you back by average $2,000. Can you afford that? And if you pitch robots against robots, now patents have run out from Da Vinci. Da Vinci is about 2 million. So the people who without patent now came down, and this is the newest kid, Shurui block, the one whose video I wanted to show you guys. Very interesting video. If you can you still try and get that video, sir, somehow or the other onto the screen? And you see that these are the companies, these are their brand names, and this is the price. Nearly $1 million. Cheapest is $800,000. The service charges, you can see how much. And the consumables, again, average is the same. So when you asked me, Professor Amir Bilal, to come over here, and I was a few weeks down the line, I was sitting and watching ARY news, and I took these snapshots from my TV. That tells you that the government has, rightly so, cancelled the tender of 7 machines. Because dono machines tahal na kara padi hai. Because you cannot pay the maintenance fee. You cannot afford the consumable charges. So something needs to change. And this is a persisting pain. And I always believe in surgeons. Look at the instruments. They are all named after surgeons. Classic instruments. This is a recent phenomenon that companies have taken over. And they are feeding us these very complicated instruments, which are engineered in the labs. One of my largest, academic award or reward was a project which had $1 million budget on that. And I inherited it. It was not mine. This was to do in the theater by an American Prado University professors combined with Hamad Hospital. And that was a project, please don't laugh, that in America, the operation theater nurse is very costly and small in supply. So I want to create a visual, intelligent robotic solution. So there will be a robotic arm like you see on the automobile manufacturing platforms. And the surgeon will be trained, the surgeon will just give this. The robotic arm will pick up a scissor and give it to you. $1 million. Okay. So we need to have, I asked that professor who visited Doha and I said, I'm sorry, I inherited this and I will work with you. Now tell me, what's your exposure to operating in theater? He said, I have been to operation theater twice. I said, great, that explains. So people started coming up with solutions, handheld instruments with a wrist inside. But you look at them, they are still engineering solution copying the robotic philosophy. And that's why it did not become popular. Expensive, you put your hand in there and then you can move the arm all around. Joel Dunning does it in UK and he has got videos on YouTube. You can watch it if you're interested. So what is the idealized solution for this big problem? The idealized solution is that we need to have a method of minimal access, fair enough. We need to have the surgeon on site, not sitting in the corner. We need to have an instrument with endo-wrist inside. We need to have touch, haptic feedback, and it should be easy to use, not difficult to train people, and it should not be costly. So I've been working on that. Muslim is with me on that for the last few years. And just before I came, I will show you the next slide. It is blurred in purpose, not very, because we haven't yet applied for patent. And I'll not go into the details, but we walked through the process. We did our analysis and constructive synthesis. And you see, nearer to an idealized solution, we have got an optical system whereby you can have cameras not inside, just peeping through the chest wall, 5mm 2 cameras. And it will give you all the zoom, it will give you the whole spectrum, and you can zoom onto one target. And the other one is an instrument where you can close and open with the normal maneuver with which you are used, and on the thumb you have got a rotator which will rotate it all around. So that's our solution for these two things. Thank you very much, and we are working on it.
Thank you very much, Dr. Rashid, for the statistically proven, but this reminds me of the thought that they say there are always two sides of the stories, and the truth lies in between. So we would move on to our next talk because we are running short of time. If we don't have any comment or anything, or maybe we can discuss it over. Yes, because we have to start the session. So can you request, please?
So we will move towards our last and most awaited presentation by Dr. Otto Takahiro from Hamad Medical Corporation, Doha.
Good afternoon, everyone. Thank you very much for inviting me to the Pakistani Association of Cardiovascular Surgery and Thoracic Surgery Biennial Conference. It's my honor to be here today. And I'd also thank to the president of this conference and the chairs and audiences, and especially for Professor Bilal, to giving me an opportunity to talk about the establishment of lung transplant center and the cutting edge of lung transplant surgery. In the next 30 minutes, I'm going to talk about how to establish the new lung transplant program based on my experience and the current problems in lung transplantations. I also present state-of-the-art lung transplant strategies and surgical techniques to address current problems. I have nothing to disclose regarding this presentation. As you know, the lung transplantations are very poor physical conditions and have decreased muscle strength and are very extremely fragile. However, they still require a major surgical procedure called lung transplantations. Patients require immunosuppression immediately after transplant. This means increasing the risk of infections and bronchial anastomosis dehiscence. Usually, donor lung is not perfect because of aspiration, pneumonia, lung contusion, thromboembolism, and neurological pulmonary edema, etc. We always consider not only donor issues, but also recipient issue. Therefore, recipient evaluation criteria must be strictly adhered to. Meanwhile, donor selection criteria have also been established. Of course, lung donors are not always available, and donor shortage are a global problem. Donated lung are extremely valuable, but not all donated lungs can be used for transplantation. According to UNOS is the US the organ sharing organization, 15 to 20% of donated lung can be used, otherwise discarded. But we can't just wait for ideal lungs because the recipient are always waiting for transplant opportunity for a long time. The important thing is to strike a balance that also considers the recipient conditions. This is my background. I have been trained for 5 years as a senior lung transplant clinical fellow at the Alfred Hospital, Melbourne. I have experienced more than 300 lung transplants. These include transplant surgery, transplant pulmonology, organ retrieval, and transplant research. What I'm saying is that a transplant surgeon must be trained at a large transplant center and have extensive experience with transplant. Only surgical training is not enough to start a new program. Setting up a lung transplant center requires simultaneous clinical and admin work. First, we set up a task force and report the detail to the health minister. Formal public comments will be held from the initiation of lung transplant service from the hospital. On the clinical side, we first need to establish a lung transplant team. We will gather people with experienced personnel, such as transplant surgeons, pulmonary physicians, anesthetists and ICU doctors, ID doctors, etc. And of course, the paramedical staffs. However, not all members have experienced lung transplant. In that case, we will train our staffs. When we are ready to accept the patient, we will start listing lung transplant candidate. Careful evaluation of the recipient, full consent, and intensive pre-operative rehabilitation are always required. Donor surgery simulations include collaboration with other organ transplant team. including liver, heart, kidney teams, as well as the timing of donor retrieval. Such as, since it is not possible to simulate the recipient operations, of course. So auto procedure, which is an auto transplant surgery for lung cancer, is used as an alternative. Sorry for the busy slide. This explains the process from donor referral to lung transplantation. There are a lot of evaluations to be done before transplant. At the same time, organ resuscitation should be performed. The time has finally come to us to undergo first lung transplant in Qatar. Simple cases are often selected for the first-time surgery, but this is not always the case for lung transplant. The donor lung was complicated by neurological pulmonary edema, and the right lower lobe was completely collapsed and didn't expand even with suction and ventilation. So we decided not to use right lower lobe. The recipient with primary ciliary dyskinesia requires cardiopulmonary bypass during bilateral lung transplant, and the recipient was a VAP. The recipient is doing well, God thanks, and has cooperated with our lung transplant awareness efforts. So that leads to the second and the third lung transplant. Post-transplant management is carried out by a lung transplant MDT, and treatment plans are decided every morning. In addition to doctors, it is mandatory to include other professionals in your team, such as physiotherapist, pharmacist, dietitian, occupational training, etc. This is my experience in starting a lung transplant program outside of Japan. The most important part is the staff. We are asked to perform first successful lung transplant in Vietnam. Because the facilities and the equipment were not in place, we asked to build a new ICU for caring lung transplant patients. We have also decided to bring the majority of our staff from Japan, and we successfully performed the first living donor lung transplant on a child in Vietnam. A similar thing happened in Sri Lanka, and they prepared necessary equipment such as nitrogen oxide control equipment and electronic beds. And I traveled to Colombo several times to see and to evaluate the patients. The transplant surgery was performed by a joint team with Japan and Sri Lanka because of educational purposes. Even after the surgery, we will continue to provide support to the Sri Lankan team so that they can perform lung transplant in a stable manner. We continue to cooperate by participating in lung transplant committee, dispatching staff to training sessions, and giving the presentation at the transplant conference. Let's move to the current problems in lung transplantations. A common problem around the world is the shortage of donor organs. When you start the program, you will face this problem as well. This is a famous slide showing the number of organ donors per million people per country. As you can see, Japan is facing a truly serious organ shortage. Therefore, Japan needs to find a way to increase the chance of transplant. The country that donates the most deceased donor is Spain, which is also famous for having an opt-out system. Today, I'm not going to talk about opt-in, opt-out system because there is someone more qualified than me. As organ shortage worsens, waiting time becomes longer, and the chance of dying on the list increases. According to data from UK, the average waiting period is 18 months, and the data from Japan shows that it's 13 months. This makes it impossible to save most patients with idiopathic pulmonary fibrosis. The longer the waiting time, the higher the mortality rate on the list. According to US data, 15 to 21% patients die each year. Data from Japan shows that more than 50% of these patients are IPF. I will talk about how we are increasing the donor pool and the transplant opportunities. Since I am a transplant surgeon, I would like to share with you some strategies from surgical side. First, we use damaged and extended criteria lungs from blinded donors. Second, we use lungs obtained from donors after cardiac arrest. Third, we use lungs from living donors. To use marginal lungs or extended criteria lungs, you need to know how damaged the lungs are. We scored lung damage using 5 commonly used parameters: oxygenation, X-ray and bronchoscopy findings, age, smoking history. This is called auto lung donor score. This score can be used to quantify damage to the lung. It helps to inform other teams of the extent of the lung damage. It can also be used to set up cutoff values to avoid using severely damaged lung. Of course, it can be applied to the research purposes. Since our publications, studies on donor lung score have been published by lung transplant centers around the world. The validation analysis revealed that auto score significantly predicts post-transplant outcome. That's why we are using auto score now. We use of marginal lungs, in addition to ideal lungs, would increase transplant opportunities and reduce transplant waiting time. On the other hand, you are more likely to face primary graft dysfunction after transplantation. We don't use marginal lungs in high-risk patients. We use them in intermediate risk patients who require early transplant. While there are many factors that determine the quality of donor lungs, there are also different factors that determine the severity of the recipient disease. We match the quality of the donor lungs and the severity of the recipient disease to perform transplant using the optimum combination. This is very important. For example, patients with primary pulmonary hypertension always receive the ideal lungs. Patients with COPD receive the larger graft, and the patient with ILD receive the smaller graft. Or the high-aged patient receive the high-aged donors, for example. This slide shows an example of a marginal lung used for transplantation at our institution. The donor had a traffic accident with traumatic emphysema in the lung and bilateral dorsal consolidations. All centers in Japan rejected this lung, but we used this lung for bilateral lung transplant. Although there are traces of traumatic emphysema, 2 months after transplant, both lungs are fully functional. Final decision will always made after pulmonary artery flush at the time of donor surgery. After the pulmonary artery flush, the good part of the lungs are intact, but the bad part of the lungs become heavy with the perfusion solution. And when we use the marginal lungs, we prefer to perform bilateral lung transplant, not single lung transplant. This is another marginal lung after neurological pulmonary edema. Lung collapse and consolidation are seen in both lower lobe. After the pulmonary artery flush, we thought that the right lower lobe was unusable. So we performed the lower lobectomy on the back table. In fact, this was the first lung transplant case in Qatar. If lower lobectomy is performed on the graft side, care must be taken during the transplant. Because usually we anastomose bronchus at the level of the main bronchus, and blood flow to the bronchial anastomosis depends on the little blood flow from the lung parenchyma. If there is a bronchial stump, blood flow is extremely poor when the lower lobe bronchial stump, increasing the risk of stump necrosis and rupture. Therefore, instead of anastomosing main bronchus, the upper and the middle lobe bronchus are anastomosed separately at the level of lower bronchus level. This allows sufficient blood flow from the native bronchus and from the lung parenchyma to reach the anastomosis. In addition, both lower lobes seem unusable. Transplant using only the upper lobe is also performed. It is easy to do for the pediatric transplant, but for the adult transplant, the right upper lobe is inverted and transplant to the position of the left lower lobe, which combines with the left upper lobe to create the left lung. In typical transplant, only one anastomosis exists in the main bronchus, one in the pulmonary veins above the left atrium, and one in the main pulmonary artery. However, as you can see, this procedure requires a complex bronchial and pulmonary vascular reconstructions. The next strategy is to use the donor after cardiac arrest. These DCD donors are classified into 5 categories, and those other than category 3 are considered uncontrolled DCD donors. Categories 1 and 2 are when the patient was already in cardiac arrest upon arrival at the hospital, or when resuscitation was unsuccessful in the emergency department. Category 3 is a donor who can wait for cardiac arrest, such as withdrawal of treatment. Categories 4 and 5 are when the patient who has already been diagnosed as a brain death that goes into cardiac arrest in the hospital, or when an unexpected cardiac arrest occurs during admission. In DCD lung transplantation, post-transplant outcome remains poor when uncontrolled donors are used. On the other hand, the transplant results with category 3 donor were equivalent to brain-dead donor lung transplant. According to US data, DCD donors influence the total number of organ donations, but they are still not a large populations. When using DCD lungs, an extracorporeal lung perfusion system should be used to evaluate the lungs, because the performance of the lung's dying period is unknown. The photo shows an ex vivo lung evaluation setting in our hospital. The next strategy is to use a living donor for lung transplantation. In a living donor transplant, the lower lobe is usually taken from 2 donors and transplanted into both lungs of the recipient, rather than transplanting the whole lung as in a blended lung transplant. The slide shows the living donor eligibility criteria. Donor must be ABO blood type compatible, immunologically matched, within 3rd degree of blood relatives, size matching, and willingness of the organ donors. The advantage of living donor lung transfer is no need to wait for cadaveric organ donor. Short ischemic time, of course, the operation is always planned, and the donor is always very healthy. On the other hand, the disadvantage of living donor lung transplant is basically 2 live donors are needed. Smaller graft, require 3 operation room at the same time, 3 teams at the same time. Donor lobectomy could be anatomically tricky, ethical issues because no requirements of the losing lung function. And sometimes no living donor is available in the family. This is an example of the surgical risk of living donor surgery. In lower lobectomy for cancer surgery, the bronchus and blood vessels are removed using a stapler. But in living donor surgery, pulmonary vessels are removed using a vascular clamp. The bronchial and the vascular stump must be closed by stitches by hand. Angioplasty using a pericardial patch is often required to close the pulmonary vessel stump. Furthermore, if the bronchial or pulmonary vessels are disconnected distal to the expected cutting line, the repair becomes very, very difficult. No, start the video. Yeah, you can. Okay. So complications such as stenosis of the bronchial anastomosis often occurs in living donor transplant. A stent for femoral artery must be used because the anastomosis site is a lower bronchus with a small internal diameter. Additionally, the kissing method must be used in most cases because the segmental bronchi bifurcate near the anastomosis. Okay, close. How to go to the next slide?
Yeah.
Okay. Now. No, next.
Yeah, this one. This one.
Please go to the next slide. Maybe this one. Oh yeah, that one. Okay, thank you very much. Okay, despite these risks, the biggest advantage of living donor transplant is it can be used emergency, particularly for patients on ECMO life support. Getting a transplant is a race against time. However, as mentioned before, a family doesn't always have two living donors. If there is only one living donor and a transplant is urgently needed, we offer lung transplant that combines one lobe from a living donor with one marginal lung from a deceased donor. We call this procedure a hybrid lung transplantation. This slide shows an example of hybrid lung transplantation. If a patient is suffering from IPF and only one marginal lung is available, a single lung transplant using that marginal lung is unlikely to be success. When there is only one living donor, performing living lung transplant and deceased lung transplant at the same time greatly increase the success rate of the transplant. After transplantation, the marginal lung suffers from ischemia perfusion injury as expected and has decreased function. But patient is supported by a high quality small living donor lung. Ischemia perfusion injury also disappears on the fifth post-operative day, making it possible to avoid ECMO, and as a result, patient can receive bilateral lung transplant with good functions. Since we started using marginal lung at our institution, our donor acceptance rate has increased from 20% to 75%. So we increased the chance of transplant. When performing living donor lung transplantation, care must be taken to ensure adequate donor and recipient size matching. The best size match is when transplanting from parents to school-aged patients. When grafts from small donors are transplanted into a large recipient, living donor transplant will not succeed because of the grafts are too small. On the other hand, even the lower lobe from an adult donor is too large for the small chest cavity of a child under 3 years of age. In such cases, the lower lobe is divided into two in vivo, and segmental transplant is performed as bilateral recipient lungs. This slide shows 5-year survival rate after lung transplantation. This includes deceased lung transplant using marginal lungs and living donor lung transplant for small children, but there is no significant difference between living and brain-dead donor lung transplant. And both results are above the world average. So in summary, I have presented key factors regarding the establishment of new transplant center, current problem in lung transplant, especially donor lung shortage. Various surgical strategies increase transplant opportunities, and utilizing marginal lung, including DCD lungs, are a realistic option. Above all, the survival rate after transplant looks promising. I hope this presentation will help you to set up lung transplant program, and the number of lung transplants will continue to increase. Thank you very much.
Thank you very much, Dr. Otto. It was a very enlightening talk. Thank you very much for that. And now, because we are short of time and we are going into the live sessions or video sessions now, so अब क्या करना है?
Before starting our own online session, I will request Professor Amir Bilal to come up on the stage for shield and certificates distribution to our honorable speakers. Please. Is Dr. Zubair with us? Okay. Sir Iftikhar, Dr. Javed Raza. Okay. So please, Sir Bilal Umer, please come. Sir Dr. Rashid Mazhar. Dr. Otto. Thank you so much, sir. Yes. Yeah, please. Yes, and we can have lunch. Lunch is ready. Okay, then there's no lunch. Please sit.
Hello. Hello. Are you online? Hello. Can you hear me? Hello. Hello. Can you hear me? Control is there, sir.
Dr. Allen, can you hear us? You You can. We can't hear you.
Alan, you need to unmute.
Are you muted?
Okay, you are the host. Are you the host? I think you're supposed to be the host. We can hear you, but you can't hear us.
No, I can hear you. Yeah, I just can't hear the rest of the audience.
We got you loud and clear now. Can you hear me? Alan, can you hear me?
Can you hear us?
Yeah, I can hear you now.
Okay, so we are connected.
Okay.
We've got Professor Rashid from Doha, who's chairing the session, along with Professor Otto. They've just given us a very enlightening talk on lung transplants. So now we are looking forward to hearing from you on your favorite subject, which is uniportal VATS.
Thank
So
you
over
so
to you,
much.
Alan. Over to you.
Okay, thank you so much. Warm greetings from Hong Kong. Very warm greetings to everybody in Pakistan, and a special thanks to Professor Amir Bilal, of course, for giving me this chance to share with you again some insights on uniportal VATS. I think by now all of you are very familiar with uniportal VATS. I'm sure many of you in the audience are already performing it quite regularly. But nonetheless, I think there's still room for us to have a little discussion about where we've come in uniportal VATS, where we are, and where we're going to go to from here. Now, if we're talking about uniportal VATS, it's, as I said, it's not new. In fact, I think many of us, myself included, we've been doing some sort of uniportal VATS really for many, many years. But if we're talking about uniportal VATS, lobectomy and anatomical resection, this, of course, belongs to our next guest, our good friend and brother, Diego Gonzalez Rivas, who over 12 years ago actually did the first single port thoracoscopic lobectomy. And it all stemmed from there. Now, flash forward to today, and you know that today it's a very standard procedure in many parts of the world. Back in 2018, 5 years ago, this survey in Europe already found that for many common thoracic operations, a lot of our European colleagues were already employing uniportal VATS techniques. Those are those yellow blocks that you can see here. And that's 5 years ago. I think if you go to 2023, these numbers are probably going to be much higher. So that's in Europe. If we come back over here to Asia, we can have a look at the Shanghai experience, for example. So this only goes up to 2015, but we can see here is that not only are the overall VATS numbers increasing quite significantly, but a significant proportion of them increasingly were being done by uniportal VATS. That's 2015. And again, in 2023, Diego will tell you that now in Shanghai Parliament Hospital, they're doing over 100 major lung operations every single day. And the vast majority of them are being done by a uniportal technique. Now, I show these numbers not because we want to show off or anything, but it's to demonstrate two things. One is that everybody around the world is already adapting this as quite standard. And two, if you can see the numbers in Shanghai, rising in such very rapid pace, it also means that uniportal technique is not that difficult. Anybody can do it. If I can do it, anybody here can do it. It's very easy to pick up. And I think if you put your hearts to it, most people can do uniportal VATS very quickly. Now, the reason we're all doing uniportal VATS is quite simple. It's because it works. Now, to demonstrate that uniportal is an effective technique, you have to start with evidence. And the first step of the evidence, of course, is the safety aspect. And so this is a systematic review I published several years ago. And you can see that even back then, the accumulated case series and published case reports over the years has really run into hundreds and if not thousands of patients all around the world for both lobectomy and other types of resections. And you can see the safety figures that are being published are pretty good. In terms of mortality and certainly in terms of morbidity rates, these are comparable to anything you would find with thoracotomy or multiportal VATS. So it's well established over the last 10 years around the world, whatever country you're from, that uniportal VATS can be done safely. Is it effective though? Now, again, this is another systematic review I published a few years ago. And essentially this graph compares uniportal with multiportal VATS. Now, it's a very busy slide, but essentially each row across is a different study, a comparative study. Each column going up and down are different outcome measures. And where the squares are blue, it means that those studies have found that uniportal VATS is better. And where it's red, it shows that multiportal VATS is better. And even if you don't read the words here, you can see that there are many more blue squares than there are red squares. And if you look at particular outcome measures, for example, pain here in this column, consistently uniportal VATS is better than multiportal VATS. So there's, over the last 10 years, the accumulated evidence is now really tending towards showing that uniportal VATS offers clinical advantages over even multiportal VATS. But that itself is not enough. We also want some more objective outcome measures. And in more recent years, some of my colleagues in Hong Kong have also demonstrated that now you can actually measure certain immunochemokines after surgery. And you can find that uniportal VATS actually causes less disruption, less disturbance than multiportal VATS. So this is a blood test objective outcome measure that demonstrates that uniportal VATS really does cause less trauma than multiportal VATS. Now, even this is not enough. What we really want to show is that uniportal VATS is just as effective in treatment as multiportal VATS. And again, fast forward to just a couple of years ago, nowadays, we're reaching the stage where you have some crude meta-analyses coming out. And this has shown that in a disease like lung cancer, uniportal VATS gives you equivalent yields of lymph nodes dissected. This is a good surrogate for measuring how adequate your surgery is. And more importantly, in terms of short midterm survival for lung cancer, uniportal VATS, again, is as good as multiportal VATS. So together, this shows that uniportal VATS is as safe, has some clinical advantages, especially over pain, and equivalent treatment outcomes in terms of survival. And that is the reason why so many surgeons around the world are now turning increasingly to uniportal VATS. Now, if you do uniportal VATS, what kind of outcomes are you expecting? This is my own personal anecdotal experience, so it's not evidence or anything, but just to give you a flavor. So in the days when I used to do 3-port VATS, these were typical outcomes. As soon as I switched to uniportal VATS, you can see that immediately patients actually do recover significantly faster. But more importantly, if you package your uniportal VATS with a good ERAS program, good pre, intra, and post-operative care for your uniportal VATS technique, these are the results that you're expecting day in, day out. And this is not just empty talk. I mean, this is literally my patients from yesterday, the day before. This is how they're doing. They wake up and really, essentially, all they need to take for analgesia is paracetamol. They immediately start eating after surgery. The same day of surgery, they're already going to the toilet by themselves. We usually get our patients home, if they don't have an air leak, within 48 hours. So, pretty good results. Now, this is good for patients on an individual level. But again, that's not the end of the story. Ultimately, the reason we're doing things like uniportal VATS, uniportal RATS, etc., is this. Because in the old days of thoracotomy, for example, for lung cancer, you have 10 patients, only 2 of them can have curative lung cancer surgery, and they don't really thank you for it because thoracotomy is really painful. In the old days, when we changed to multiportal VATS, those 2 patients who can receive surgery are happier because they have less pain and better recovery. Now, the whole idea of doing uniportal VATS or next generation techniques is that not only are patients happier, but you have more happy patients, because those patients who are old and frail, like in those pictures on the right, nowadays, because the trauma you're causing is so much reduced, you can reduce the thresholds for patients receiving surgery, and therefore more patients can benefit from curative surgery. And for me, this is the biggest benefit of going forwards with minimally invasive techniques. Now, if you do decide to do uniportal VATS, the good news, as I said, it's quite easy to learn. So I assume many of you are already doing 3-ports or 2-port VATS. Now, my own story is when I moved from 3 ports to 2 ports, I just simply moved the posterior port to a shared utility port. So you're just learning instrumentation through the same wound. You're keeping your camera port essentially in the same place. And when I moved from 2 ports to single port, all you had to do was just bring the camera into the same utility port. And hey presto, you're doing uniportal VATS. So it's a very easy two-step process, and you're already at uniportal. It's not that difficult in evolution. Now, in terms of the theater setup, well, there are different ways to do it, including the Shanghai style, where we only have one TV monitor. But by and large, in Hong Kong nowadays, I stick to this tried and tested technique here. When I stand on the same side as my assistant, we're standing in front of the patient, looking at the monitor at the back. So it's quite similar to normal multi-portal VATS. In terms of the instruments, now this is the great news. Compared to any of the other more fancy techniques involving expensive equipment, uniportal VATS is actually quite cheap. It's actually quite simple to do. And this is all the equipment I actually use. So you're seeing it here, very cheap equipment. You're using a similar video equipment. I tend to use a 5mm scope, and that's about it. Now, when we actually come to do it, the biggest change from multiportal VATS, of course, is going from this to a single port technique. The 3-port technique, when I used to do it, this is how I used to do it. I always imagined myself sitting at a dining table, looking at my plate of food. So my eyes are looking across the table, and my left and right hands are coming in from the 2 o'clock and the 10 o'clock positions, as you can see here. So we're operating across a flat dining table surface. And because this is the actual view you get during multiportal VATS, isn't it? The camera from a low angle, your instruments coming in from 2 o'clock and 10 o'clock. And here on the right, that's how I used to envisage myself doing multiportal VATS. Now, when we switch to uniportal VATS, you're standing in front of the patient, and this is the actual view you get as a surgeon. There's a vertical slit in front of you, and so it looks like a keyhole. You're actually doing true keyhole surgery. And because our eyes are naturally above the level of our hands, we're looking down on the field of vision. Your hands are, well, if you keep your camera at the back of the wound, as Diego always says, then your left and right hands come in, not at 2 and 10 o'clock, but really from the 5 o'clock and 7 o'clock positions, from these angles. And this maintains the ergonomics of your surgery. So this is where you put your port location, where I put my port location. Essentially, it's almost always between the anterior and mid-axillary lines. And I tend to use the 5th intercostal space, regardless of whichever lobe or segment I'm doing. Occasionally nowadays, I go for the 4th intercostal space if I'm doing upper lobe segmentectomies. But by and large, the 5th intercostal space works quite well. And as we make our wound, again, you're seeing this is my surgeon's perspective. We're looking down the wound. This is a tiny little wound here. And always the assistant should put the camera at the top of the wound looking downwards, and I put my instruments underneath. And that gives the proper hand-eye coordination. So that's the assistant space. This space on the bottom here is my space. And if you do that right, then essentially here's your wound. You have a traffic light configuration. So for 95% of the operation, the assistant's camera is in the red light position, looking down, you can see here. So my right and left hands come in, as you can see here, from the 5 o'clock position and from the 7 o'clock position. Occasionally, I can tell my assistant, please move your camera to the green light position or to the yellow light position, but that's only occasionally. Most of the time, it's in the red light position. To get around obstacles, always remember to use the clock face analogy when communicating with your assistant. I still like to use the old-fashioned light cable on my scopes. I do sometimes use the NDOI, but using this light cable, I can tell my assistant to move the light cable to the 9 o'clock position or the 6 o'clock position, and that will help direct the 30-degree camera around obstacles. And by using that 30-degree lens, and you can move right and left, you can see that you can go right around higher structures. Okay, just simply directing the 30 degrees. Uniportal is no obstacle to looking right at the back of any lung hilo. Most importantly, though, I always stress for beginners that the retraction has to be mobile and flexible. So I use my own left hand for my retraction, and I move the lung, backwards and forwards, left and right, to give the correct angles so that my dissection and my staplers can go across quite nicely. And for example, one of the for beginners, one of the more tricky parts is doing the upper lobe pulmonary vein, for example. If you go straight in like this, the staplers will impinge on structures in the back. And all you need to do is just rotate everything, use a left hand to kind of move the lung forwards, and you can rotate your stapler and it will go nice and easily past any hilar structures. So always be flexible. So these are just some simple tips and tricks. And when you put it all together, you get pictures like this, for example. So this is a typical left upper lobe lobectomy. You can see that I'm looking down onto my field of work. You can see by and large, my right hand is coming in from the 5 o'clock position. My left hand, just off screen, is coming in from the 7 o'clock position to retract the lung. And so you can see here, as I pass my stapler here in the pulmonary vein, I rotate. You see here, I rotate the whole lung sort of anti-clockwise, and that allows the staplers to go past any structures. These are minor tips and tricks only. And by and large, that's how you can do a simple lobectomy. Of course, you can move on from that to do more complex resections, interpericardial resections, sleeve lobectomies. This is a V bronchoplasty procedure. You can see here that it's quite straightforward. It's quite more or less the same as you would do with multiportal VATS. You just have to adjust your perspective and look down like this. And it's actually very ergonomic. You can see many of Diego's videos on similar operations, so I won't dwell on here. And of course, from the very major big resections, you can go down to the smaller sublobar resections. You can do essentially any segment using a multiportal VATS view. And you can see here it's quite ergonomic and it's quite simple to do. Again, I won't dwell on these videos because there's so many surgical videos you can see on the internet today that, I mean, this should, most of you, be quite straightforward. So instead, I'd like to spend the rest of this talk just pondering where we can go from here. So our past journey has gone from open surgery to conventional VATS. And today we've moved from conventional VATS to next generation techniques. Next generational VATS, as you can see, or robotic surgery. Or as Diego will show you in a minute, how you can merge these two together and get uniportal robotics as well. So where do we go from here? Now, if you can see this kind of trend, essentially over the last 20 years, we've been following a trend for increasing difficulty in technique or increasing infusion of technology. So if you project in the future, these are presumably the ways to go. And that, I think, is true. In terms of technique, there are so many new VATS techniques being published almost every year. So today, I think a lot of people are already using a subxiphoid approach for different kinds of resections. There've been talk about transcervical, transareolar, stuff like that. Yeah, it's feasible, but obviously there'll be some years ahead before we actually get enough evidence to show any of these being useful. But nonetheless, it shows that our colleagues around the world are already aggressively thinking of new ways to do surgery. Now, besides improving techniques, we can probably put in a lot of investment into technology. And there's so much new technology today, isn't there? There are new robotics platforms, new 3D visualization. You can even project it onto your goggles or onto the TV screen during an operation to see in 3D. There's new navigation bronchoscopy, which you can actually combine with ablation technologies. So you get non-traumatic surgery. You can have hybrid ORs with, on-table CT scanning. It's incredible the amount of technology that's made available. Now, all of these are still in the experimental stages, but nonetheless, I think the results will mature very rapidly over the next couple of years. And I wouldn't be surprised if many of these become mainstays in the coming years ahead. But ultimately, I think, is this the way forwards for all of us? And I'm not necessarily so sure. Sorry, I forgot to mention, of course, what Diego is going to say in a minute. He's going to merge both technique and technology together, and you have exciting new vistas for uniportal robotics as well. So I'll leave that to Diego to explain to you. But I think my vision for the future is that if we look at the past, I think as we move from open surgery to multiportal VATS, the increase in reward was very great for little risk because there was so much pain involved with open thoracotomy that simply going to 3 ports, you had a lot of reward for little risk. As we move from multiportal VATS to uniportal VATS, yeah, you still get a bit of benefit, but the benefit is not as great because you're already achieving such great results of multiportal VATS. So I think really over the last 10 years, we've reached a point of diminishing returns, where if we continue to increase the difficulty of the technique or the investments in terms of technology, yeah, you might get benefits, but the benefits are going to be quite relatively small for the amount of time, effort, and money you're going to be spending. In fact, if we're not too careful, if we keep pushing the limit, pushing the envelope too quickly, too aggressively, there comes a point where potentially the risk from the investment might start to exceed the reward for the patient. And that's sometimes a little bit difficult. So we have to be a little bit cautious. Now, instead of technology and techniques, where else does the future lie? And I think this is quite important for all of us doing uniportal. I think if we keep pushing technique and technology, what we're saying to the patient is, look, I can reduce your pain even more. I can increase your recovery even better. But is that what patients really want? If you are a lung cancer patient or a patient of any severe inflammatory disease for that matter, is it so important to you to have a little bit less pain when today with uniportal VATS you already have so little pain? Maybe this is not the message that most patients want to hear. If I was a lung cancer patient, I think what I really want my doctor to tell me is, here's a way to give you better survival, a better cure for your lung cancer. I think that message today is even more important than your wound being a little bit smaller or in a different place, or if we're using some latest technology. Better survival is more important. And I think that the better survival doesn't come from the surgery itself. We've already reached a good level. I think in terms of improving survival, this might come in different ways. However, those different ways are avenues where we as surgeons might have a part to play. Now, let me just show you 2 very important examples. The first example of how to increase survival is screening. And I'm very happy to see that in this session later on, we're going to have another talk on screening. Now, screening, as you can see from the studies over the last 10 years, has the potential to reduce mortality from lung cancer far better than any new surgery. It's huge. But if we look at what happens once you find a lesion on screening, whether it's a solid nodule or a GGO, you find that most guidelines around the world just say this. They say, don't do anything. Just get another CT scan in 3 months, 6 months, or get a PET scan. Now, for me, that's defeating the purpose. That's really going backwards. Why do screening if when you find something on screening, you're not going to do anything about it? That's ridiculous. You're just sitting and waiting. And I think that's a bit defeatist. But why do the guidelines say this? Now, the guidelines are so conservative because they're worried about overdiagnosis. Because if every single lesion that you find you operate on, you're causing a lot of harm to the patient, because a lot of them are going to be benign or pre-malignant. So in the days when you're doing open thoracotomy and every surgery involved a lobectomy, then yeah, if you operate on everybody, a lot of people are going to have unnecessary thoracotomies. So the balance swings in favor of avoiding overdiagnosis. However, in this day and age, when we're able to do uniportal VATS, we're able to do sublobar resections, the morbidity of surgery, the cost of surgery is significantly reduced. And this will highlight the cost instead of delayed treatment. So now with better surgery, with uniportal VATS, uniportal RATS, I think it's time that we start swinging the scales the other way in favor of avoiding undertreatment, delaying the treatment too long. And what I mean is this. My friends in Shanghai coined the phrase minimally invasive 3.0. And what do they mean about this? Now, MIS 1.0 is reducing the harm from the incision. So you go from thoracotomy to VATS, and there's less incision, less pain. MIS 2.0 is reducing the harm from how much you're resecting. So you go inside the chest, and instead of doing lobectomy, nowadays we can do a segmentectomy for selected patients, and you're reducing the harm that way. Now, MIS 3.0 is reducing the harm from time, or more specifically, from delays. So if you can use better surgery to make sure that you're doing the surgery more in a more timely fashion, you're reducing the harm. Now, what do I mean by that? Now, let's say you do screening and you find a lesion on the lung. You can either operate today, it's a small GGO, and if you do surgery today, you can do a uniportal technique, you can do a wedge resection or a segmentectomy. And if it turns out to be a small cancer, the survival rates nowadays for GGOs can be close to 100%. That's great for the patient. Or you can follow the guidelines from America that say, no, don't do anything. Get another CT scan in 6 months. And if the lesion is grown by then, by that time, if you do surgery, maybe you need a bigger incision. Maybe you can't do a sublubar resection and you need a lobectomy. So there's more harm to the patient. But because the tumor is now bigger, it might not be T1A, it might now be T2, for example, the survival is compromised. So what we mean by MIS 3.0 is because our surgery nowadays can be less traumatic. Why not operate today instead of tomorrow? And by doing that, you are reducing the harm to the patient. Now, that's the first example I want to share with you. The other example of how to improve survival with MIS is this: multimodality therapy. Today, especially over the last few years, we're definitely in the era of treating lung cancer with multimodality therapy, not just surgery, not just chemotherapy, not just TKIs, but combination therapy. So these two studies are, to my mind, the most important studies in lung cancer over the last few years. I won't go into these in detail, but you can read them up. Now, let's take, for example, the the study here on the left-hand side, ADORA. And this is using third-generation TKI after surgery for lung cancer. And if you look at the most recent update of these results from this year, these are the survivals. So after surgery, if you give this third generation TKI, you get a significant improvement in the lung cancer survival. This is better survival. It's so good that even for stage 1B here on the top left, you can improve survival even more. That's a game changer. But what's more important for me are these two graphs here on the bottom. For stage 2 and stage 3A. Now look carefully at these numbers. These are 5-year overall survival figures. 5-year overall survival after surgery plus TKI, 85%. 85%. Now, if these numbers look familiar to you, these are actually the survival figures for stage 1 lung cancer just 5-10 years ago. So essentially today, even for stage 3 patients, if you can give surgery and the patient has an EGFR mutation and you can give a third generation TKI, you're turning stage 3 into stage 1. Now that is a miracle. That is absolutely incredible. And for us as surgeons, it means that today we can go even more aggressive with treating stage 2 and stage 3 patients, knowing that we can achieve great cure results if we combine it with multimodality treatment. Now, you'll say here, Alan, what does this have to do with uniportal VATS? Well, this is what where it makes a difference. First of all, not everybody after surgery can complete their chemotherapy or their TKI. But over the years, we've shown that if you do VATS compared to open thoracotomy, more patients can complete their adjuvant chemotherapy. And this is a definition we call RIOT, return to intended oncological therapy. How many patients can have RIOT after you do surgery? Now, the more minimally invasive you go, the better the rates of completing the adjuvant therapy. So if this is the benefit you're getting with VATS, imagine what the benefit will be if you can go even further with uniportal VATS, an even higher rate of RIOT. Here's another thing. Now, it's been shown that if you give adjuvant chemotherapy, the sooner you give it after surgery, you see here, the better the survival is quite significant. However, on the right-hand side here, if we give the chemotherapy too soon after surgery, the the morbidity from the chemotherapy overlaps onto the chemotherapy, the morbidity from the surgery. And actually, there's more harm being done to the patient. You want to wait a little bit before you give the adjuvant therapy. Now, this is where uniportal VATS might come into play. If you cause less harm from surgery, less morbidity from surgery, then this delay, this wait before you can give adjuvant therapy can be reduced. And if you can reduce the waiting time, you're actually going to improve survival. So this is a potential area where we as surgeons need to look into. And last but not least, if you're not going to give TKI, what about immunotherapy? Now, if you give immunotherapy after surgery, you can again improve survival. But there's one very important result that is emerging amongst oncologists. And that is after surgery, by the time you give your immunotherapy, if the level of circulating tumor DNA in your circulation is reduced, look at this improvement in survival. Much, much better. So you want to aim for less circulating tumor DNA after surgery by the time you hand your patient to the oncologist to give immunotherapy. And how can we as surgeons do that? Well, it might be by how we do our surgery. So there have been some preliminary studies like this that have shown when you compare VATS with open surgery, VATS actually gives you less circulating tumor cells and less circulating tumor DNA than open surgery. So if we take it a step further and you're doing less invasive surgery like uniportal VATS, maybe you're actually going to have even less circulating tumor DNA and therefore better results from adjuvant immunotherapy. So I don't have the evidence yet, but this is the a guide to potentially where we can go in future. So just to bring this talk to a close, why are we doing uniportal VATS? Well, it's because it's safe, it offers some benefits, and it's effective in treating lung cancer. If you're learning how to do it, the good news is it's an evolution of the whole VATS story. It's actually easy to pick up. And if you combine it with a good ERAS program, you're going to have great results for individual patients, and you can lower thresholds for operating on a whole range of patients. But where do we go from here? Technique and technology, I think it's very important. This is where we're going to invest ourselves in the future. But it's also a potential trap because you do have diminishing returns if you throw too much investment in that area. Instead, I would suggest to you that maybe the future lies in where we take uniportal VATS and uniportal RATS and how we can combine it into overall lung cancer treatment or treatment of any thoracic disease. For example, by considering concepts like MIS 3.0 and also how we integrate modern MIS to enhance the effectiveness of our multimodality therapy. So with these thoughts, I'll leave you and look forward to any questions you might have later. Thank you.
Thank you, Dr. Allen, for a very lucid, very graphic, very clear to understand, and a very logical, chronological progression of your slides and thoughts. So the floor is open for any questions, please.
Hello.
Hi.
Hi, how are you?
Very good. Hi, brother.
Hey, Alan, my brother.
How are you?
Yeah, I just finished my talk. We're waiting for...
Okay, thank you.
Good to see you. I am in Bucharest, in the OR.
Thank you for a lovely presentation. As usual, as Rashid said, you were very lucid and very correct. And I especially like your MIS classification, MIS 1, 2, and 3. Diego is going to be talking about uniportal RATs, but I'm amazed that you've taken up the number in Shanghai to 100 cases a day.
I think...
150. Yeah, no.
Yeah, Diego will tell you more about that. He's been there more recently than I have.
Right,
yeah, they're going occasionally up to 150 plus cases a day. It's incredible. And increasingly, we're seeing a lot of younger surgeons doing uniportal routinely. So as I say, it's a technique that's very easily learnable.
How many theaters are running for 150 cases?
I think it's gone up to about, I don't know, 16 plus.
25
now? Is it 25
Diego,
now? Yeah.
welcome, Diego. Yeah. Nice to see you after a long time.
Yeah.
Hi, Diego.
Yeah.
Hi, Diego.
Welcome.
Right. So
I'm in a break between operations, so it's fine.
Wonderful. Wonderful. Thank you, Alan, for a wonderful presentation. And now I hand over to Diego. You take over. I know you've just come out of theater and probably going back in again.
Mhm.
So you
Yes, but I think I sent my presentation recorded, right?
Yeah, you did. So you want
So
to
you
come
will
up?
play that
No, we would rather have you live.
live. Okay, so then I have to switch the computer.
Okay, then, or you want us to play the recording and you can take the question answer session,
I think it's better because
We'll do
I
that.
hope time.
right? We'll do that. So we'll start with the
Yeah,
recording
play.
and then you can take the question answer session.
Yes,
Thank you
I-
for
Okay,
joining
okay,
us.
okay.
You are in Bucharest?
Okay. Yeah, I'm in Bucharest.
Okay.
I
For how
fly to
long?
Shanghai tonight.
And you fly tonight? Okay.
Yes.
So we just start the recording and then you can have the question and answer session
Together,
at the end.
yeah.
Thank you, Diego, for joining
Thanks,
us.
Diego.
Okay, thank you.
Thank you, Ali, for joining us as well. You'll be on next after Diego. Thank you,
Welcome,
Ali.
Ali. Your beard is getting more impressive by the day.
Hi, Ali. Good to see you. Long time.
Good to see
My
you.
friends. How are you? Everything good?
I'll just
Yeah,
tell the
good.
audience here, Ali, that Ali has been dubbed as the Maharaja of thoracic surgery in India by our Indian thoracic surgeon colleagues.
He's more British than Indian now.
I don't think anybody can match Diego in moving around.
Yeah, you have the lecture. Yeah. This is not the beginning, eh? And there is sound or not?
We are set to go, Diego, in a few seconds. Yep.
Okay.
Apologize, Diego, for a little technical hiccup, but we are very short, and shortly we're going on. Yep.
No sound, yeah? Do you have problem with the sound?
Yeah, if we start from the beginning, Diego, I'm sure you can see the slides. So if you
Yeah,
give
but
us
there's no sound.
we can hear you loud and clear, but can you see the slides?
Okay. Yeah, but I cannot hear the lecture. But this is sound.
Your presentation runs here visually, but there is no sound onto it. So we were asking perhaps if you could help us out while it is running, you can give us an commentary on
No,
that.
I can give, because if without sound it's very difficult. But I say with sound, what happened?
Then tell us something nice about Bucharest in the meantime while they're fixing the sounds, Diego.
I think if there's no sound, I will try to give it. Because without sound, it's not no sense. Let me check. I'm gonna try to enter
No, we got
my
it.
computer.
We got it, Diego. We got it.
You have?
Yeah. The audience can hear you and see you as well. So
You have sound, okay, but play from the beginning.
yeah, we have sound on another device, so we'll put that device onto the mic.
Several facilities for this kind of cases. We did the first cases in the world of fully robotic uniportal rats. No, but September 2021 in Spain. That means that the surgeon controls everything, robotic staplers and the instruments from the console. So this is a very good concept of fully robotic technique. In this way, we have to go through a 6 or 7 intercostal space in order to angulate the staples correctly. So it's important to go lower in decision for robotic staplers. We have published our technique in different textbooks and articles, and also we have a special issue of uniportal rat. My lecture is about the uniportal fully robotic bronchovascular liver sections. My lecture is about the uniportal fully robotic bronchovascular liver sections. And since we started the technique of uniportal VATS in 2010, we have evolved to a more complex cases, and now we are able to do everything, even by a single hole and with a rope. We were evolving the technique of uniportal VATS for more complex cases and carotid resections, and we saw that it was feasible, but you need a lot of experience. But then, thanks to the use of the robot, we see several facilities for this kind of cases. We did the first cases in the world of fully robotic uniportal rats in September 2021 in Spain, where that means that the surgeon controls everything, robotic staplers and the instruments from the console. So this is a very good concept of fully robotic technique. In this way, we have to go through a 6 or 7 intercostal space in order to angulate the staples correctly. So it's important to go lower in decision for robotic staplers. We have published our technique in different textbooks and articles, and also we have a special issue of uniportal rats in the Annals of Cardiothoracic Surgery that you can check online with a lot of articles about this topic. It's important the correct placement of the arms. On the right side, we cancel the arm 1. On the left side, we cancel the arm 4. And several advantages of uniportal rats, such as the cost. It's cheaper because we only use 3 arms. We don't need the 4th instrument. It's very quick, the docking. We don't need to do the targeting, and it is painful because it's a single incision. The only disadvantage we can see is that it's more demanding because the assistant should be experiencing uniportal VATS and should be always controlling the arms to avoid collision at the bedside of the patient. It is important also to have a good specific trocars. You can do it with conventional trocars, but with the transoral, it's much easier because you can do it in a better way. We have different kinds of bronchial sleeve resections and bronchoplasty. Sometimes bronchoplasty is just about cutting the bronchus at the origin and doing a simple suture. When the tumor margin is fine, we don't need to do end-to-end anastomosis. These are very easy cases, and we just need to suture the bronchus with a running suture or with interrupted sutures. Like you can see here in this, we control the artery first, and then we do the closure of the bronchus in a running way. For end-to-end anastomosis, the technique is more difficult. In uniportal VATS, we tie outside and we put a knot pusher to put the knot inside. But in uniportal rats, it's much easier because you can do the knot inside. So this is one of the benefits of the robot for suturing and for doing the anastomosis inside. Normally, we use a barb suture with robot. That means that we use a 25 to 30 centimeter length with 2 needles, and we don't need to keep the tension outside because the barb system allows to keep fix the suture in every stitch. We have different ways of doing the sleeve. As you can see here, we have upper, lower. We can do everything with the portal wraps. On the left side, we like to use several tricks to increase the exposure, like fixing the pleura posteriorly here with a stitch, or fixing the artery with a vessel loop or with a traction in order to have more space. Because as you know, for left upper lobe sleeve, it's some kind of difficult to do the anastomosis because sometimes the left main bronchus is very, very high, very, very deep. For the middle of bronchus sleeve, also we do a similar technique as we do in portal valves, but I think one of the important things is remove the middle lobe first and do the anastomosis from posteriorly. I think we also use the tricks we use in portal valves, such as, for example, fix the artery anteriorly to keep retraction, and then we just do the anastomosis from posteriorly, doing the anastomosis between the intermedius bronchus and the lower lobe bronchus in the same ways, running suture with 2 needles and with a barb suture. Sometimes we have tumors involved in the middle and the lower, so in this kind of tumors, we can save the pneumonectomy by doing bilobectomy and doing the anastomosis of the upper lobe bronchus to the right main bronchus. We do also with the barb suture, running suture, and the most important thing here is to identify the membranous portion and to align with the membranous portion of the right main bronchus. On the left side, most of the time, we can also save the upper part of the lobe. When the tumor is involved in the lower and the lingula, we can do the anastomosis of the B1, 2, and 3 to the left main bronchus. And in this way, we avoid the possibility of doing pneumonectomy, which is something that we have to avoid every time we can. Normally, we put the camera in the upper part of the incision and the instruments in the middle and in the lower to do the bimanual instrumentation. For carotid resections, we can do a ventilation jet, or we can use the possibility of ECMO, like here in this case. So it's important to isolate the vagus nerve, as we do here, and then we do the anastomosis in this case of the right main bronchus to the trachea, and then intermedius to the left main bronchus. It's important to be sure that you are doing a good anastomosis with the barb suture as well. And you can see here the vagus nerve is completely retracted. The use of the ECMO helps and facilitates a lot this kind of resection. Also for tracheal tumors, we can do in the similar way. As you can see here, we don't need to put the incision lower as we do in fully robotic rats, because in this case, we just do a spinal lung surgery, so we just do tracheal resection. So we can go higher in the 4th or the 5th intercostal space, and we can do just the resection of the trachea and do the anastomosis with a running suture. It's important also to dissect or cut the azygos vein in order to have a better exposure. In tumors also involving the intermedius bronchus, we can do spinal lung, like this case, also fully robotic, 5th intercostal space, because as well, in this case, we don't do the lung resection, and also using these tricks to retract posteriorly the vagus nerve, cutting with the robotic scissors, which is a very good tool, and then doing the anastomosis, the intermedius to the joint of the right main and the upper bronchus. This is a partial second.
Very enlightening presentation. Dr. Rashid, please take over.
Thank you very much, Diego. As usual, a very impressive presentation. The floor is open to questions. I think we can combine questions for Diego and Dr. Allen together, because both of them with the UVATs and URATs is a natural progression to one to another. So any questions from the floor, please?
Anyone?
The raised hand was taking pictures. Okay.
Diego, thank you very much for coming online, and sorry for the technical hitch at the beginning. That was something not in my control.
No problem.
Thank you very much.
Thank you very much, Diego.
Sorry for dragging you out of theater.
Everything, I'm between guests, no problem.
Okay.
Thank you very much.
I'm here with my colleague, Mugulu Bosinciano. He is the one who developed the technique with me here in Bucharest.
Hi.
Nice to meet you. And also Veronica Manolache, she's also the other part of the team, our colleague as well, Dimitru. So we developed the technique from here from the beginning, and we are also doing courses here every year to teach the URATs fully robotic.
Wonderful.
Now also we teach in Shanghai. So if you come to Shanghai, we will show you technique as well. Or also in Bucharest, we can be in touch if you want to come to learn. This is a new revolution, absolutely revolutionary technique. You need to overcome a learning curve. You need to learn a lot of things. And now we are developing a new uniportal robot in Shanghai, which is really amazing. It's called Surui, with a new technology, with nitinol, something that is unique. I can show you. Let me check if I can show from here. Well, it's a new technology, uniportal, with nitinol, not with cables, not with the same technology as other companies. And it's going to change the future of thoracic surgery because it's single incision and will aid inside the chest more than any other robot. It's amazing. So the future of the future of surgery for sure is with technology. Robotic is here to stay, and I think in the coming years will be cheaper and more affordable for the rest of the countries. I can see that robotics is like mobile phones. You know, when mobile phone technology started, it was only affordable for a few people, but with the pass of the time, now mobile phones is everywhere. Everybody has a mobile phone, and we have very cheap mobile phones. So I think robotic in the future will be the same, because with one company in the market, it's impossible. But now there are many companies coming. Next year, a lot of robots come from China, from India as well. So, and I think it's going to be the blast of the robotics, because they will develop more single port systems, which makes sense. I mean, for me, it makes no sense to use 5 holes if I can do uniportal VATS. So I don't think it's fair for the patient. But if you can do robotic uniportal, of course it's fair, because robotics give you better view and more precise movements. So I think for the future it's clear that it will be uniportal robotic. There's no doubt.
Thank you very much, Diego. We all appreciate your input and your experience. Thank you indeed. Take care, my friend.
And I liked your
Thank you.
I liked your allegory to the mobile phone. I think that did take the world by storm, and initially it was very elitist, but then now everybody's carrying one. So I'm sure robotics would head the same way.
Absolutely. And in the mobile phones, you have, will happen the same, because in the mobile phones, you have all kind of devices. You have the most advanced, the most technological, they are more expensive. And you have a simple ones that they have all the facilities and they can do the job very well in a very good price. I think with robotics will be the same. There will be different kinds of robots, and according to the country, to the budget of the hospital, you can choose one or another. But there's no doubt that the technology is here to stay. Artificial intelligence, robotic, everything will be by the hand in the next years. It's about time. It's about time.
Very much. Thank you. Indeed.
Thank you, Diego.
Take care, Diego.
Very
Thank
exciting. Thank you very much. Thank you.
Bye-bye.
Thank you for
Okay,
your time.
keep in touch, my friends. Good to see you again.
Thank you. Thank you.
See you soon. Bye-bye.
Bye-bye.
Alan, if you don't mind, I have one question with you. Very interesting, that paper of the circulating DNAs and the response to chemo or immunotherapy. Now, we keep hearing, comparing the uniportal or minimal access with open thoracotomy. Now, open thoracotomy is, I'm sure all of us know, is a heterogeneous group. Has there been any standardization, what you call an open thoracotomy? How long do you have to go on the paravertebral axis going up to the moon, or you can do it with a lateral incision with about 6 to 9 centimeters or 6 centimeter incision, which will allow a hand inside and an instrument alongside it? Has there been any standardization? And the other comment is that when you do open, we were all taught by great teachers who said, don't touch the tumor. So is this the manipulation factor which gives you more circulating DNA in a so-called open compared to minimal access, where you have invariably less manipulation of the tumor? Your comments, please.
Yeah, thank you. That's a very loaded question. There's several different parts to it. First of all, let's talk about the definitions, as you said. Back in the days when we transitioned from open thoracotomy to multiportal VATS, there wasn't a universally accepted definition of what made thoracotomy into VATS. The closest we've come was the CALGB definition published in one of their studies, and that was 2, 3, or 4 incisions. The maximum wound length, I can't remember. It was quite generous. They allowed you up to, I don't know, 6, 7 centimeters. And they stressed that there's no direct peeking through the mini utility thoracotomy. So you have to do the majority of your operation looking at the video scope. As we move from multiportal VATS to uniportal VATS, what's the definition of uniportal VATS? Well, essentially just one wound. But you're right, there's no published figure of the definition for what uniportal VATS is. Now, before the pandemic, I think we came quite close. The ESTS had a uniportal VATS interest group, and we actually formulated a consensus statement working along that line. But it was a consensus statement rather than a pure definition. And I think it was a rather vague thing. So all I can say is really it's VATS through just one small wound. Now, I don't think so much the definition is probably not important. But what is important is the second part of your question, is what actually is the key to minimally invasive surgery that gives you these potential biological benefits. Now, the studies I showed you just now were pertaining to multiportal VATS. We don't have similar data for uniportal VATS yet. Hopefully, some uniportal VATS surgeons in future might be inclined to do some studies along that way. But as we go from open thoracotomy to multiportal VATS, there were a few theories. Now, one is exactly what you said. It's the amount of manipulation. And certainly the less manipulation you have, potentially you should have less shedding. And simply because of the way we do our lung retractions during most VATS, as compared to open surgery, even though in open surgery, as you said, there's a no-touch technique, there's still a lot of manual retraction back and forth. I remember from my days when doing open surgery. So there is potentially more moving around. However, my own pet theory is really to do with the sequence of the lobectomy. Now, for certainly in my days when I was training in the UK and certainly in the early days in Hong Kong, if we do an open lobectomy, we were taught traditionally to do the artery, then the vein. You do a hilar first approach, and you work from the hilar through all the different structures. However, when we moved on to multiportal VATS, we often work from an anterior to posterior approach for upper lobes, and from an inferior towards a more superior approach for the lower lobes. And what that means is that the very first structure we often take during a lobectomy was the pulmonary vein instead of the pulmonary artery. Now, this seems to make a difference because there have been studies initially from Japan and also later on from China, which has shown that if you do the pulmonary vein first, before you do the pulmonary artery, you're cutting off the flow from the blood flow from the lobe, from the tumor into the systemic circulation. And therefore you have less shedding of tumor cells into the systemic circulation as the operation goes on. So this is one potential way why VATS might reduce the circulating tumor cells and circulating tumor DNA after surgery. Now, at the moment, this is a theory. It's backed up by a little bit of evidence, but there's a long way to go yet before we prove it. I'm pretty sure that there will be other elements as well, but we'll have to see. Unfortunately, trying to get some of our surgeon colleagues to be interested in this kind of research is not easy. Everybody wants to play with the latest robot or the latest bronchoscope kit, whatever. Technology is sexy, but doing basic research like this is not. But hopefully some of the young surgeons in your audience today might be inclined to study more on the biology. And I think this is what's going to make a big difference for our patients, survival outcomes rather than fancy new toys.
Thank you very much, Alan. I definitely remember that the contesting theory was that if you do the the vein first, then you will engorge the lobe and it will make it more turgid and more difficult. Plus remember that at least the days I was trained, we used to do hand sewn. So you used to take 15 minutes plus once you cut the artery or the vein. Now you don't have that much kind of time delay. You just engage and shoot. So thank you for your input.
Thank you.
I'll just make a comment on that, Amir. Can I make a comment on that question?
Please go ahead. Go ahead.
Of course, Ali. Sure.
You asked, you said something about a difference between an open thoracotomy versus mini thoracotomy versus VATS. And I have met a few people who do tell that we do the same operation through mini thoracotomy and, we get excellent results. The bottom line, my PhD student did a thesis on this, and he looked at inflammatory and immune responses with open thoracotomy versus mini thoracotomy versus VATS versus robotics. And the single most factor in that creates a difference between a thoracotomy and VATS is the use of a retractor. The moment you put in a retractor, whether it's a maximal thoracotomy or a mini thoracotomy, the moment you put in a retractor and you start winding the ribs away, that is when the inflammatory and the immune response is the highest. And we showed it in our data. So the big difference between VATS and thoracotomy, even though it may be a mini thoracotomy, is avoidance of use of a retractor. And that is what makes the inflammatory response go down. And that's why the outcomes are better.
That's an excellent comment, Ali. That's very practical. And that's why in at least our practice, we have, either the wound protector, the Alexis, which does not stretch the ligaments, or if somebody, my juniors, have to put in a retractor, then I always tell them just a couple of turns, enough space that in case of emergency, you can stick in a swab holder down to the bleeding point. That's all. You don't need to see, because whatever is the incision, we invariably use a camera with that. So the open window or a big door incision is a thing of past, because everybody has access to a camera now. Thank you. So we move on to, that's your turn, Ali, in fact.
Shall I share my screen?
Go ahead. Yeah, of course. You already crashed the gate. You're already in. Come on. Let's start, sir.
I am doing screen share, but you have to enable me to share the screen. The host has disabled me to share the screen.
Now, we have been suffering with technology since morning, Ali. So we will
If
bear with us.
your IT guy can allow me to share my screen, then I can show you my
Oh, please, that will be wonderful. If you can share your screen, that would be fantastic.
There's post-disabled participant screen sharing. So he has got to allow me to share the screen. Just go into the settings and allow me to share screen.
We will, sir. Just a few seconds.
While we are setting that up, Ali, I would like to thank you for joining us. I hope you've gotten over your jet lag. Ali just came back to UK from India, about 2 days ago, 1 day ago.
1 day ago.
And he was kind enough to send me his presentation and to join us. Although we had problem connecting because he was traveling in rural India where the internet connection was on and off. So I'm very grateful to him for joining us despite the fact that he's still not recovered from his jet lag.
No, he's a very fit man. Those who do not know Dr. Ali Zamir, he's a fantastic person. He's a teacher. He's a born teacher. And he has, I was impressed by his videos where he will go and teach the long forgotten art of physical examination to his students. As from a surgeon, that was a breeze of fresh air. Ali is a great teacher and a fantastic surgeon.
They're saying if you click share screen, we should be able to see your screen.
I'm doing that, Amir. It's saying you have disabled participant screen share.
Participant screen share कहते हैं आपको disable है.
I'm clicking the share screen, and it's saying the host disabled participant screen sharing. If it's a problem, you can just play my video. It's okay, but it'll be more fun if I can present live. Okay, I think we are there now. We're there.
You're the host now, so I think we should be
there. We're there now.
Great.
Can you see my screen, please? Can you see my screen now?
A black screen.
Not yet. It's a blank screen we are seeing. Your picture has disappeared.
You can see my writing on the screen. Is my slides coming up? It's coming up on my screen.
Yes, now we can see, Ali. You're on.
You can see?
Yes, go ahead, please.
The VATS and robotics in inflammatory and infective diseases. Can you read that?
Absolutely. Go ahead, please.
Chairman, sir, ladies and gentlemen, Professor Ahmed Bilal, thank you very much for inviting me to present at this prestigious forum. Assalamu alaikum to everybody in the audience.
Walaikum
It's indeed an honor and a privilege to present at this conference. As I said, India, Pakistan have quite similar patient demographics and characteristics, and the challenges that we face while setting up VATS or robotic surgery are quite similar. The first and foremost is, of course, the fact that we all face MDR, XDR tuberculosis. There is a huge caseload of aspergillomas in post-tuberculous cavities. We face TB destroyed lungs and TB bronchiectasis. And when I first went to India in 2009 to set up the program of minimally invasive thoracic surgery, everybody told me I was a fool. There was no way I could put in a camera into a chest in an Indian patient. But I think now we're more than 2,500 cases down the road. We've proved people wrong, and we've shown that actually VATS and robotic surgery is possible. And today my talk is all about just to give you a glimpse of what all you can do in the inflammatory world. Most of our patients have poor nutritional status. We see that all the time. There is issue of cost in terms of installation, maintenance, and disposable use in the in our countries, and the importance of paucity of expertise and training. And India particularly doesn't have a dedicated thoracic surgery program. It used to be cardiovascular and thoracic surgery, but it's only in the last 3-4 years that we've actually got a dedicated super specialization in thoracic surgery. So when you have a CVTS, most people want to do the cardiac side of things because they think it's more lucrative and more paying. And most of the country, as I traveled around India, I found that it was actually general surgeons who were doing occasional thoracic surgery. And I'm very sure that even in Pakistan, the situation must be the same. When an empyema comes, he usually goes to the general surgeons, and they are not that experienced in the chest to be able to do complex inflammatory cases. The benefits of minimally invasive surgery are very, very obvious. The cuts are less, the inflammatory response is less, the immune response is less, the pain is less, and the cosmesis is less. But for we as surgeons, the most important thing is that the view that comes with a camera is unimaginable. Currently, with the high definition camera, you get an excellent view, you get a 10x magnification, and hence the quality of the surgery becomes better. In inflammatory and infective diseases, I find that the camera allows you to dissect each and every adhesion under vision, and thereby the bleeding becomes less than open. When you do an open thoracotomy, you actually tend to put your hand in and sweep your hand around, trying to take down as many adhesions as possible with the sweep. Whereas with VATS, you can't do that. So you have to actually buzz and use a ligature to take down every adhesion. Hence, the overall outcome for the patient is better and the view is better once you take down adhesions under vision. And particularly in areas like the thoracic outlet, the diaphragm, and the hilum, the camera and the use of VATS and robotics, of course, gives you excellent manipulation of the instruments. And as you know, in an aspergilloma surgery, doing the lobectomy is the easy part. It's taking the tumor off the chest wall at the top is where you have most of the difficulties, particularly in open surgery, because there's a lot of neovascularization and bleeding. And so these instrumentations allow you to take down everything under vision and really reduce the morbidity of the operation. So what sort of surgeries do we do in inflammatory diseases? Well, aspergilloma and post-tuberculous cavity is now my favorite surgery for using VATS or robotics. In fact, robotics gives you a lot of benefit when you're doing aspergilloma surgery. Post-TB bronchiectasis that you see with patients coming with hemoptysis, patients with lung abscesses needing resections. Hydrated surgery also has a huge role. VATS is got a good role in hydrated surgery, and I'll show you a bit later. Pneumonectomy for destroyed lungs, infected bronchogenic cysts in the mediastinum. Sometimes you get patients with post-TB emphysema and, cavitatory lesions, and you do what is effectively a lung volume reduction surgery. You do resections of giant bullae in post-TB patients. I do a lot of pericardial windows, and in fact, I like to do my pericardiectomy for constrictive pericarditis by VATS. And I do a phrenic to phrenic dissection, putting in the camera from the right and then dissecting as much as I can. And in a couple of cases, I've also put in a camera on the left to complete the dissection. Somebody is trying to get in, so my slides are stopped. Okay, so I've been fortunate enough to be involved with a few families who had Carter-Jenner syndrome, and we've had to operate on sequential lobectomy in multiple patients of the same family. Endobronchial inflammatory tumor is a pathology that's unique to our part of the world, and these cause obstruction and destruction of the lung distal to the tumor, and that needs resection. You have multiple non-diagnostic mediastinal lymphadenopathy, which will need a VATS or a mediastinoscopy to get at them, and of course, hydrated disease. This is the standard lobectomy. This is a standard aspergilloma that you'll see. This sort of a patient will present with hemoptysis to you, and you end up trying to operate on these patients. Usually, I try and delay the surgery if I can. Of course, if it's an emergency, you have to operate, but most of the times I try and give them at least 2 weeks of preoperative voriconazole. I personally like to continue the voriconazole post-operatively for 3 months. There is no evidence for that. There's a lot of controversy in this, but I've found that a few patients get systemic fungal sepsis, and if you continue the voriconazole, the incidence of post-operative systemic fungal sepsis goes down. Most of these patients should be optimized medically. You shouldn't jump in and operate on the first aspergilloma that you see. You should optimize them medically, and if they are on antituberculous therapy, please make sure that you complete the ATT if possible, and then offer aspergilloma surgery. I frequently found that in aspergilloma, you actually have endobronchial communications. And while the patient is awake and he's got a cough reflex, there is no spillage. But the moment you put this patient under anesthesia and you put in a double lumen tube, you will have a endobronchial spillage and soiling of the opposite side and the remaining 2 lobes. And we actually came up with a technique where whenever we do an aspergilloma, we turn the patient laterally with the affected side down, and we put in the double lumen tube with the patient lateral. Once the patient is lateral, then we take in a Fogarty's catheter and put it on the side of the surgery to protect the remaining lung. So, for example, if you're doing a right upper lobectomy, my tube will be put in laterally into the left side, and a Fogarty catheter will be put into the bronchus intermedius to prevent spillage of the aspergilloma into the lower lobe and the middle lobe. And in this way, we've actually stopped our experience of having systemic fungal sepsis or fungal pneumonia in patients 2 or 3 weeks down the road. And this technique actually has helped us quite a lot. Most of the times, the positioning is quite straightforward. I break my table in a certain way to allow the intercostal space to open wide. I always want my shoulder to be higher than my hip. And I am still an old-time surgeon. I have not jumped onto the uniportal bandwagon. I do my VATS standing at the back of the patient. This is your standard thoracotomy line, and I take away the middle of the portion, and these are my incisions for doing a VATS. When you do a robotic, you don't put any ports in the 3 centimeters lateral to the vertebral column. The principle for management of aspergilloma is that there should be minimal manipulation of the lung. And that's the bottom line, because otherwise, when you start moving the lung around, you will actually have spillage of the aspergilloma. I will always take down the fissures, take down the adhesions at the fissure, get into the fissure, and attack the vascular structures and the bronchus. The bronchus is the most important structure to take before you try to take the adhesions at the apex. Traditionally, in an open thoracotomy, we try to dissect the whole lung off the chest wall. But when you have minimal access surgery, it's best to get into the fissure and try to develop the whole thing in the fissure so that you can get the artery and the vein while you are there. This is how I would do it, either robotics or by VATS. It doesn't matter. The adhesions come down beautifully. And the moment you've got the adhesions down at the fissure, then you get into the hilum and you get the vein. So this is the superior pulmonary vein being taken. I'm just going to speed up a little bit for lack of time, and then we would get into the bronchus. Now, look at this picture. The bottom line is, because the adhesions are holding the lung to the chest wall, it becomes like a retraction. And it's very easy to go around the bronchus and sloop it around to get to get the bronchus. And this, for me, is the most important step, because this is what prevents spillage of the aspergilloma. And then once you've got this, you get the vein and you get the artery. Again, in an aspergilloma, the sequence of stapling depends on what structure you encounter as you go into the operation. And then the last but not the least is dissection of the adhesions. And look at this, with robotics or with VATS, because the magnification is so good, you can dissect clean without having any bleeding. And most of us who have done open thoracotomy would realize most of the bleeding happens because of the adhesions at the apex. As I said, minimal manipulation. I always wash out my cavity with saline, betadine, and hydrogen peroxide. I have used hydrogen peroxide in the pleural space in thousands of cases now, and I have no hesitation to use it. Some people are worried that it causes allergic reaction. I've had allergic reaction only in 2 patients, which was treated with local treatment. So that's the story with aspergilloma. As I said, I always continue post-operative antifungals and, of course, nutrition. And I'll talk a little bit about yoga at the end. I personally like to do sleeve resections, if possible, wherever you're dealing with sleeve resections. If it's a inflammatory tumor or if it's a carcinoid, then my standard pattern is bronchotomy, transection, removal of the endobronchial tumor, frozen section of the margins to make sure that the margin is clear, and then do the bronchial anastomosis. This works very well with robotics, because robotics allows you to suture really well as compared to VATS. It's almost like doing an open surgery. This is an inflammatory tumor in a patient from Bangladesh who's got a tumor in the left main bronchus. His left upper lobe is completely collapsed and destroyed. The lower lobe, he was okay, according to me, but he was offered a pneumonectomy by another team, and I wanted to save his lung. So what we did was we went in by robotics. We got the artery, vein, and bronchus, and then once I got to the we got the artery and the vein, but once I got to the bronchus, I actually did a bronchotomy and delivered the whole tumor out piecemeal. This is the beauty of the robot, is that it allows you to lean into the airway and you can take the tumor out. Now, because this was not a cancer, I could take out this tumor piecemeal, and it wasn't a problem at all. And then once you've done that, then you just do an bronchoscopy from the top to make sure that everything is clear. And the moment you've done a bronchoscopy from the top, then the robot, you finish your lobectomy and the robot allows you to suture. And as Diego said, and Alan said as well, suturing by robotics is a beautiful, beautiful technique. Almost like you're sitting in the chest and doing an open surgery. So it is definitely recommended. This is the sort of picture that we used to see with post-tuberculous destroyed lungs. A lot of people say, why do you want to do this surgery by VATS? But I find that the moment you get your first incision in and you dissect under vision in a uniportal way, you can actually then dissect the whole chest wall and the lung off the chest wall. Surprisingly, in tuberculosis, the hilum is usually spared. If you find difficulty in dissecting the hilum, then I open the pericardium and do an intrapericardial pneumonectomy. And then the whole destroyed lung can come out. One of the techniques that I do is, because of the TB surgery experiences, I like to put a flap onto my bronchial stump. And whenever I'm doing a pneumonectomy, I actually use a phrenic nerve pedicle. And I can just swing the whole phrenic nerve pedicle, cut it off, and then put it onto my stump. And that gives me a good coverage and also allows the diaphragm to rise. If I'm still worried, then I'll take an intercostal muscle pedicle at the same sitting. Segmentectomies are something that I really like, and I'm a great fan of segmentectomies. They could be unisegmentectomies, bisegmentectomies, and even multiple segmentectomies, depending on whatever is the destroyed area of the lung that you're dealing with. Tuberculous empyema is a big entity. I think almost all the time you can do these with the VATS. I'm an aggressive dissector. I will take down all the adhesions from apex to the bottom, hilum to the hilum, so that I can recruit all of the lung and recruit every single alveoli. And I do a visceral as well as a parietal decortication, because that allows the chest wall movement to be better. And as I said, I wash out with betadine and hydrogen peroxide, and I always leave a single drain under vision. And that's how I mobilize the chest. This is a standard empyema that you would see. Again, as you get in there, I would break down all the adhesions under vision. Everything is done under vision, so the bleeding is relatively less. I would do a parietal pleurectomy first, dissect off the chest wall tight pleura, and then get onto the lungs. And then I use a knife as a standard procedure, and then make an incision on the lung. And at this stage, I asked my anesthetist to go on 2 lung ventilation. So I hold the pleura back, and my anesthetist inflates the lung. So effectively, he is doing the decortication while I am holding the pleura back. And that technique allows us to get a good dissection. Sometimes you have a very bad cortex, and in that case, I would just make multiple incisions and scores on the thick cortex and allow the lung to expand as much as possible. The most important thing is that it should be released right from the top all the way of the diaphragm, hilum to hilum, and that is what gives you good outcomes for patients. This is the sort of thing preoperative, but it takes you at least 3 to 6 months before you can get a half decent X-ray in these patients. Hydrated surgery is something that I learned from Tarek Kilani in Tunisia. He's got the highest experience of VATS. What I do in hydrated surgery is that I go in and put in betadine, hydrogen peroxide, and saline into the chest cavity through the port and leave it there for 20 minutes. And then you just suck it out. Don't wash it out. Leave the hydrogen peroxide and the betadine there. And then you do your surgery. And do whatever is needed. So I might do a lung incision and deliver the whole of the hydrated cyst. If it's a hydrated cyst, if it is multilocularis, then sometimes I have to do lung resection and take out wedge of that. But as in a hydrated surgery, the principle is to conserve the lung. And once you've taken out the hydrated, always place it into a bag and then deliver it out through your incision. You might have to suture the endobronchial communications that are present in the hydrated. Working in India, I was very fortunate to have access to integrative medicine. So I have a yoga therapist in my hospital with whom we do a ward round, and he acts like my physiotherapist. We teach the patient exercises before the operation, and within 4 to 6 hours following the operation, we get the patient mobile again and push hard to get them mobilized. And use of integrative medicine along with VATS has actually helped us to get very, very good outcomes. I have to say, I don't know the philosophy behind the Ayurveda and yoga, but using them as part of my team has actually helped us to get very, very good outcomes in these patients. The bottom line is VATS and robotics in inflammatory disease is technically feasible. That's the only message I want to get across to the people. I mean, I traveled across India purely to get this message that please do not start with an open thoracotomy, start with a VATS. And then if you need to convert, that's okay. That's not a problem. The vision with VATS is better. The dissection is definitely better. The bleeding is definitely less. And most importantly, the outcomes are very good. Thank you very much, ladies and gentlemen. It's been a difficult journey. TB surgery has a price to pay. I started off with a lot of hair, and today, unfortunately, I've got no hair left behind. All thanks to the TB story. Thank you very much for your time and attention.
Wonderful presentation, Ali. Thank you very much. So your loss of hair is not lost. You've grown it at the other end of your face. Okay. Any questions from the... I'm sure there must be questions. These are all inflammatory surgeons here.
Yeah, absolutely.
Thank you very much. It was a pleasure listening to you, and probably we are sharing the same pathologies which you have already highlighted, and we were always afraid of going in, and we always think that things are frozen up. So at the end of the day, anything specific instrumentation which you have devised and you want to improvise and you want to suggest us so that that can make things much easier for us.
Yeah, so when I was in India, everybody told me we can't do VATS because we don't have specific VATS instruments. Actually, that is incorrect. You can do most of your VATS with an open thoracotomy set, except that you need a slightly longer instrumentation. The good thing about working in India and Pakistan is that if you have an idea, you can get an instrument made locally very easily. All you need is an extra long instrument, you know, an 18-inch or a 30-centimeter instrument. A peanut is very important. I'm very fortunate to work in the UK where I have access to LigaSure. LigaSure has dramatically changed the way I do my surgery. But when I was operating in India, because of the cost issues, I used a peanut. And I just had some extra long instrumentations. Even today, I have created a set for India, which is only about $500 for 10 instruments, which is about 50,000 rupees, I think. And most of my people who come for training to my VATS wet lab actually have to take the set back with them because that excuse that I don't have instruments is taken away. These are just simple extra long instruments with double joints from the top. They're not Scanlon. They're not Scanlon quality. They are lesser quality, but they're good enough to do day-to-day VATS surgery.
Yeah, I totally agree what you're saying. But we heard from the European Society, they have made a committee and they have made a group of people who are working for this inflammatory lung resections. And they were improvising the staples basically. So have you come across those? Basically this thing I was asking, that those heavy staples or something which can have the hold of the bigger tissues, especially while you're doing these resections en masse, or sometimes you feel like that you have to do like en masse. So those staples or things have.
They are working on these cheaper staplers, but I because I used to work in smaller centers and smaller cities as well, I learned to use hemolocks. And I learned to suture quite a lot with VATS. And a lot of my VATS lobectomies would be tying of the stump like in an open surgery or using a large hemolock. I think Diego has come up with the Grena hemolock, and there's quite a large size of the Grena hemolock which you can safely apply to the vessels and manage to do lobectomy, and they're much, much cheaper than using staplers. I have demonstrated that you can actually do a lobectomy without using staplers by VATS. It's technically cumbersome. That's all. You need to learn to use these things. The newer staplers which they're talking about are not yet in the market, but there are some Indian and Chinese companies who are coming up with similar staplers like Ethicon and Medtronics, but at a much lower cost.
I'm Dr. Asif. An excellent and very crisp presentation, Dr. Ali. I wanted to ask about your experience regarding empyemas with bad bronchopleural fistula. Usually you must have seen, rather we all have seen such x-rays with a collapsed lung, not showing very much evidence that it is going to re-expand with decort and with having hydropneumothorax. So do you have experience of such kind of cases, and what your plan was in such cases?
I do indeed. Anybody who does TB surgery would see these all the time. As I said, when you peel a cortex, it's like peeling an orange. So sometimes you have good oranges where the peel comes off easily. Sometimes you have bad oranges where the peel doesn't come off easily. So I do a lot of cruciate incisions in these sort of situations. I think the use of Medela or the Topaz in the post-operative period has helped me a lot to expand these fibrotic lungs up to the chest wall. In our own personal experience, we actually use a flutter bag very quickly after surgery. So within 4 or 5 days after surgery, we will connect the patient to flutter bag and get him mobilized and get him out of hospital rather than staying in hospital. The longest leak of air that I've had is 28 days is in one patient. Most of them will be 14, 15 days. With regards to the bronchopleural fistulas, you can either suture them, but I personally believe that the correct way to stop a bronchopleural fistula is to get it to stick to the chest wall. And that is why I'm very aggressive with my decortication. I will not stop till I've released the whole lung, hilum to hilum, superior to inferior. And I think that is the best way to get the lung to re-expand and fill up the chest wall. In 2 cases, I have had to do a thoracoplasty as a subsequent operation for a long-term fistula. But I don't have much experience with thoracoplasty. Rajan Santosham has done more than 3,000 thoracoplasties. In my personal hand, I'm about 2,500 or 3,000 cases down the road. I have done very few thoracoplasties. Most of the times I've got away with a VATS decortication, but an aggressive VATS decortication, use of a flutter bag and mobilize the patient as soon as possible.
You see, an excellent idea. We have been doing open surgeries, and we were using this latissimus dorsi pedicle flaps, putting it inside. I was always thinking that is there a possibility that we mobilize the LD outside, and from that small defect in the ribs, we bring it inside and use this endo procedures to fix it over this fistulous area. It will do the space filling as well as control the fistula. What's your take on that?
Yeah, I have actually done that as well. I have used a muscle flap into the chest to close certain areas. When I was dealing with Elozer flap closure, patients who had previous Elozer out there with 8 or 10 years of leaking chest wall, I worked with a plastic surgeon to get closure of the Elozer flap. In those sequences, what we did was laparoscopically, we harvested the omentum and then swung it through a subdiaphragmatic area into the chest and used the omentum to plug these areas as well. So yes, you can use intercostal muscle flap, you can use latissimus dorsi muscle flap, you can use omentum. Personally, I found omentum is a better substance because it is more vascular and it really fills up the space very well. With latissimus dorsi, because you're pulling it down through a small incision in the chest wall, the blood supply can get kinked sometimes. Whereas omentum is much more freely vascularized. So if I was you, I would suggest using an omentum. It works very well. We did about 16 cases like that, but always with a plastic surgeon. I don't do these cases without a plastic surgeon.
Thank you.
If I'm worried about using muscle flaps and things like that.
Thank you.
Thank you very much, Dr. Ali. And I am Dr. Bilal. And I just wanted to ask, what is your threshold for conversion to open? Because once we are going to start on our own, there has to be a certain time or a criteria for when to open up the surgery.
Absolutely agreed, sir. So there are 3 levels of three levels of VATS surgeons. The first level is when you're new and you're doing your first 40, 50 cases. Your threshold to open is very low because you're worried about bleeding, you're worried about adhesions, you're worried about abnormal anatomy. These are the 3 reasons why you open quickly. The third point of the VATS surgeon is somebody experienced like me who knows when it is not going well and you have to open. The most dangerous is the middle part when you've done 20, 30 VATS cases, and that's when you don't want to open. You want to prove that you're a VATS surgeon, and you push the boundaries to a point where the patient becomes insalvageable. I personally believe that conversion is not a failure of VATS surgery. That's the bottom line. You have a live patient coming in, you need a live patient going out. You should not push it to the point that, the tear has become so bad that you cannot salvage the patient even with open surgery. So convert early if you're not confident. Convert if it is an abnormal anatomy. Convert if there is difficult adhesions that you're struggling with. And most importantly, always, if you're starting a new program, always have an agreement with your anesthetist that in the first 2 hours, if I haven't got a structure stapled or isolated, I will convert. And most of the times I've found that once I have that agreement with the anesthetist actually tells you, you know what, you're doing very well, carry on. I think you'll finish the case. So initially when you start the program, it does take longer. So don't overfill your list. Just keep 1 or 2 cases which you have enough time to do it. And you will find that gradually with about 20, 30, 40 cases, you will then become better and your rate of conversion will drop. Initially, the conversion rate can be as high as 20 to 30%. Once you become experienced, your rate of conversion drops to 3 to 4%. But conversion is never a failure of VATS. Please convert if you're unsure of the situation.
So persons like us who would starting our experience with anterior lobectomies, and you are doing your most of the cases through posterior approach. Can these be done from the anterior approach, these TB cases?
Of course you can. Of course, 95% of the world is doing their cases anteriorly. The reason I do posterior is because I learned VATS 20 years ago when we were all learning how to do VATS and nobody knew, there was no standardized technique. In the UK, Bill Walker was the one who was doing VATS posteriorly. We learned posterior and I just continued doing it because I didn't find any need to change to anterior because I was doing good surgeries through the posterior approach. The only advantage you have through the posterior approach is when it comes to conversion, you just join A to B and you're in the chest. But 95% of surgeons nowadays do it anteriorly. They come directly onto the hilum and that's absolutely fine. My new trainees, I actually send them to my colleague next door and they learn anterior approach and that's fine. There's absolutely no problems doing things anteriorly.
Thank you. And what is your trick for these frozen ribs and overriding ribs? Is there some way of overcoming that, what you're doing of VATS?
In fact, if you've got frozen ribs or you don't have enough intercostal space, you do a rib resection.
Thank you.
Do a 2 to 3 centimeter rib resection to even get into the chest. It does happen sometimes that you can't even get into the chest. So you just cut a piece of rib and get in there. Hello?
Sir, there is a question regarding the VATS hydrated cyst surgery, that whether you close the bronchial openings inside the hydrated cyst cavity while doing these VATS, and do you place the drain? And what is your experience regarding the air leak while in this approach of VATS hydrated cyst surgery? Thank you.
Yeah, so I will actually suture the endobronchial communications in the cavity and I'll then close the cavity on top of it. So it's like a double whammy. You put a couple of sutures at the base of your, I always put in saline and do a underwater test to see the specific area and I'll close it with a couple of stitches and then I'll close the lung on top of that. Air leak is not a problem. You leave a drain and use a medulla. With hydrated surgery, it just comes up nicely. The key thing is to get the lung to re-expand. If you can get the lung to re-expand, all air leak stops. It is actually a patient's game. Most of the surgeons are desperate and they want to do something about the air leak. In fact, I say more experienced you are, the more patient you are with air leak, and all air leak usually stops. And you are excellent. In India, I used to use a urinary bag with a non-return valve on it. And that's a cheap way to just get the patient mobile.
Ali, the more I would
yes,
love...
You do.
Sorry, go ahead, Ali. Go ahead,
No,
please.
finish.
Sorry. No, interrupted you. Go ahead, please.
I was just saying that, yes, you do suture those communications and you do suture the lung on top of it.
Sir, one last question from my side regarding the port position in case of the empyema. You keep the same standard or you alter it according to the, your take on this?
No, actually, in empyema surgery is the only place where the port position is not standardized. What I do is I take a needle and a syringe and I aspirate. And wherever I get the pus, that is where I make my first incision. And then I use that as a uniport. So I put in a camera through there, I put in a peanut through there, and then I dissect out until I reach to my second port, and I make a port incision opposite to where I am, and then I continue with the surgery. So the incisions are not standardized because the pus could be loculated at the back. So, and if you try to come in the front, you will end up into the lung, and that's not what you want to do. So I try to make my first incision over the loculated cavity because that allows me access to get my camera into the lung. So aspirate, many times you have to aspirate in a few spots before you hit that cavity. And always interpret the CT really well before you start this surgery. So you know exactly where to put your port. Most of the times I start with an anterior port, but empyema surgery is the only one where I will put my port dependent on where is the loculation, and it could be posteriorly. So sometimes I have to start with posteriorly. The one thing I don't do is start low. I don't start low because you don't know where is the diaphragm. And the last thing you want to do is put in a camera and see liver. That's not a good idea. So that's why I come high, fourth or fifth intercostal space as far as possible. But use a needle and syringe and aspirate the pus. And wherever you get pus, that's where you make your incision.
Ali, thank you very much for these wonderful practical tips. We would love to keep on hearing you, but time constraints calls. So really appreciate your input, Ali, and hope to talk to you soon. Thank you very much indeed. Take care.
Very much so for inviting me.
Thank you for joining us, Ali. Thank you very much.
Alaikum salam wa rahmatullah.
Thank you, everybody.
So next is Dr. Qadri, who has been patiently waiting. Sohail. Oh, I thought.
Just joined us. Welcome, Faiz. Thank you
Salaam
for
alaikum.
joining us.
Assalamualaikum, guys.
Faiz Rashid here. Welcome to Pakistan in cyberspace.
Thank you very much, Rashid. Can you guys hear me okay?
We can hear you, we can't see you. You disappeared all of a sudden.
How about now?
No, you're not visible. You were visible a few seconds ago.
There you go.
We are having some hiccups with the IT since morning, Faz. Now I think
see.
we are coming back. Yeah. Go on. Yes, we can see you and we can hear you. Go ahead, sir.
Okay, great. Good morning from New Jersey, and it's a real pleasure to be here. There's been a change in the title of our talk. I've spoken to Dr. Bilal about it, but I'm particularly delighted to be here as part of the conference. Thank you again, Dr. Bilal, and the organizers for the very, very kind invitation. I'm also delighted to introduce to you one of my partners, Dr. Shahzad Razi. Just a little bit about our practice. So I'm the chair of surgery for Hackensack Meridian Health Central Region, and our division of thoracic surgery has 5 surgeons, and Dr. Razi is one of my partners and one of my faculty members, and will be helping me with the talk today. So our talk today really focuses on some advanced software that helps with planning of segmentectomies and sublobar resections. I think in this era of lung preservation surgery, it has become increasingly important to identify the subsegmental anatomy preoperatively as accurately as possible, so that the patients can get the most precise operation that they need. And in cases where lung preservation surgery is an option, particularly in our patients with lung cancer, with advanced COPD and emphysema, to try and perform the ideal oncologic operation, but at the same time to take just enough lung such that that oncologic operation could be performed. So in our practice, we look at every case, and particularly for tumors that are 2 centimeters or less, we try and see if an operation less than a lobectomy can be performed. I think with that, we'll start the talk. Shahzad, if you could load the slides, please.
Good morning, everyone, and assalamu alaikum. Actually, good afternoon to all of you over there. May I please request the host to allow me to share my screen so I can upload the PowerPoint? I see I don't have the option to share just yet.
Just,
coming up. Just bear with us for a few seconds, please.
Please, no problem.
So while the slides are being loaded, I just wanted to add that there are a wide variety of software programs that are now available, and we'll be demonstrating one of them that we've been trialing for the last several months. And we found this particular software platform to be very user-friendly, intuitive, and I think importantly, the resolution and quality of the segmental anatomy that results from this particular platform can be achieved without the need of IV contrast. I
Razi,
think
you
most
are
of
the
you.
host now. You can share your slides.
Okay. I still don't see that as an option on my end.
I think they have given you the right to screen share. उनको host बनाना नहीं राजी को I think they mistakenly made Faiz the host. Now they're transferring to you.
Got it.
I think you got it now.
I did, sir. Okay, so I'm going to load my talk here.
First of all, I have to add how impressed I am with Dr. Bilal's IT knowledge here. I thought he was a master thoracic surgeon, but it looks like he also understands the nuances of IT better than anyone.
I think Faiz, that's a good joke.
So this is the title of our talk, and it's Do We Need Advanced Lung Segmentation Software? Again, I will be doing part of my talk, but I'm particularly delighted that Dr. Razi will be participating in this meeting, and I'm glad you will all get to know him. Our other surgeons are Costa Pulakidis and Jawad Latif, and then we have our 2 postdoc fellows as well who form part of the department.
All right. Thank you, Dr. Bora. So I will start with, well, we have no disclosures. I will start with a case presentation briefly. This is a typical lung segmentectomy that we have been performing after carefully visualizing the CT scans in 3 different views: axial, coronal, and sagittal, and really understanding the anatomy the best we can, especially the bronchovascular divisions pertaining to individual segments. And there are some nuances to it. And then following that, we'll dive into some case studies that both myself and Dr. Bora will be sharing from our experiences. And we'll be reviewing the planning aspect for doing these advanced segmentectomies, and how having a 3D rendering of lung anatomy via this software allows us to better understand the anatomy and also the performance of the surgery overall. So this first case, this is a right upper lobe posterior segmentectomy. Brief history: 57, female with past smoking history, incidentally diagnosed with a suspicious solid right upper lobe 12 millimeter PET-avid nodule in the posterior segment, reasonable PFTs. So these are the CT scan at the back end, and then the PET CT scan, which showed the PET avidity. You can see that the nodule is relatively deep, so it's not easy to palpate it or feel it with the robot. So we used Veran navigation platform to tattoo it with ICG and methylene blue. These are our robotic ports. After docking the robot, we checked with the near infrared vision on the robotic console to confirm that the nodule is appropriately targeted and visible to us. So again, I checked during the performance of the surgery. I was unable to really feel it because it was deep. We begin our dissection, and we do this in the same manner for all our anatomic lung resections. Begin by mobilizing the inferior pulmonary ligament, follow up along the posterior hilum, and identify the venous anatomy, the inferior pulmonary vein. In this case, there was an aberrant V2 draining the posterior segment into the V6 of the lower lobe, which was unusual. And it threw us off in the beginning. We had to spend some time over there, again, reviewing the anatomy in detail from the CT scan, and can be cumbersome for these advanced segmentectomies. Followed, after dividing the aberrant V2, we proceeded with lymph node dissection in the subcarinal location. This is station 7. And then we go up along the hilum and continue dissecting the mediastinal pleura away from the hilar structures. Here I'm working underneath the azygos vein to complete my lymph node dissection from the right hilum and to expose the division of the bronchus, the right mainstem bronchus, and identify the takeoff of the right upper lobe in BI. Here, after completing the lymph node dissection, you can see the right upper lobe bronchus. And I identified the B2 segment. And here you can see the division of the right upper lobe bronchus into B3 anteriorly and apical, that is behind B2. So I complete my dissection, again confirm that the nodule is in the target segment, as I understood from reviewing the CT scans prior. And once I was assured, we proceeded with dividing the segment using robotic staplers, segmental bronchus. The next step after this is the most challenging, at least in my experience, is to really understand the vascular anatomy for individual segments. In the interlobar fissure, in this patient, there was no posterior ascending branch that was going towards the posterior segment. So I had to spend some time to look around and identify the recurrent branch, A2, that comes off of truncus anterior, which in this case was rolling around the stump of B2 segment. So after carefully mobilizing this, proceeded with dividing it with the vascular stapler. And that's where I feel ICG comes in very handy, because it helps you identify the intersegmental plane, as I will show momentarily, but also gives you assurance that you have indeed ligated the appropriate PA branch to a given segment. So after this recurrent A2 is divided, we give the ICG, and as you can see that the nodule is lighting up, the remainder of the lung is appropriately perfusing with the ICG, and the posterior segment is devoid of perfusion after I divided the PA branch there. And the intersegmental plane is also visible with a reasonable margin of at least a few centimeters from the lesion. And that allows you to complete the intersegmental plane with the firing of multiple staplers as we proceed over here. And these are some of the nuances in our experience that we have felt before the era of 3D lung segmentation that is sometimes can be very challenging. And as you can see, as you will see from some of our case studies, and also in my experience, we have previously had to convert segment to a lobectomy just because the arterial branch we thought is perfusing the individual segment turns out to be a different one. And then in the usual manner, we complete our paratracheal lymph node dissection, followed by intercostal nerve block. So the final pathology after S2 segment showed 12 millimeter squamous cell carcinoma with margins of more than 2.5 centimeter. There were 12 lymph nodes from mediastinal and hilar stations, and they were all negative. So with that, I will hand over to Dr. Bora to discuss the first few cases for our lung segmentation planning. And he will describe his experiences and correlation with what we found and what we found in the software and how it correlated with intraoperative findings. So please, Dr. Bora, go ahead.
Thank you very much, Azad. So what you saw is a typical segmentectomy done here robotically. We do the vast majority of our anatomic lung resections with the robot. We have 3 robots at our hospital. We also have one robot bronchoscope, just to give you some perspective. So the resources are available. Now, that is pretty much the standard technique and conduct of an operation. anatomic identification as well as robotic division of each individual bronchovascular structure, and then the use of ICG to help with the parenchymal division. Now, the cases that we're going to show you really have been in our practice for the last few weeks, since we've had the software here for the last few weeks. So these are fresh cases. These are not remote cases per se. So we're learning as we go along here. In this case, it's a 65-year-old female, a prior smoker with a 1.2 centimeter adenocarcinoma involving the right upper lobe. This was diagnosed on a transthoracic biopsy. The PFTs here are reasonable, and we'll show you the imaging. Yes, in this case, you see the nodule in the posterior segment of the right upper lobe in each dimension. And I think you can also identify the bronchovascular anatomy. This is a CT scan with IV contrast. So sort of the optimal scan in a lot of respects to be able to identify the arterial anatomy. And this is what the segmentation software describes to you. So you get a very detailed view of both the arterial anatomy as well as the bronchial anatomy, and the software truly guides you as to which particular bronchial branch as well as arterial branch needs to be divided. Also tells you what the appropriate margin would be with a particular segmental resection, as you can see in this particular case, and then also gives you the stump view. So after the resection has been performed, where the stumps would lie and what the post-resectional view would look like. So here, just using the software, we were able to perform a posterior segmentectomy, and you will see that the margins really correlated with what the software kind of predicted to us. So the software told us we would have a greater than 2 centimeter margin, which actually ended up being the case over here. The lesion size was as reported, and this was a stage 1A lung cancer. So really, it reinforces what, in this case, we expected preoperatively, and it made the operation pretty straightforward, smooth, and without too many surprises. So in this case, 1.2 centimeter adenocarcinoma, 2 centimeter margin, all our lymph nodes are negative. Now we do a extensive lymph node dissection, as you know, and we follow the Commission on Cancer guidelines, whereby we take at least one hilar node and 3 mediastinal nodes. And in this case, the patient had a PDL1 score of more than 50%. The next case is when things get really interesting. So this was a patient with a 2 centimeter, very central lesion, and you'll see that on the PET scan. And it was a little bit difficult to tell whether the lesion was in the middle lobe or the upper lobe. The minor fissure was fused and non-identifiable, but our guess was that this was probably in the middle lobe, but extending into the anterior segment of the right upper lobe over here. And her PFTs were really not the best, somewhat marginal. So DLCO was 10 and FEV1 was 1.2, and she had somewhat limited performance status. And so while I thought that I could get her through a bilobectomy, my thought was that if I could save some lung from the upper lobe, that would help her in the postoperative period. So We did not have the software, or I should say, we didn't really use the software for this case. And now, in retrospect, perhaps I wish I had before I did the operation. So my strategy for this case was to start with a middle lobectomy, see what the anatomy kind of looked like while we were doing the procedure. So kind of really chart our course as we operate. I knew I had to take part of the upper lobe, and I was prepared to take the anterior segment on block with the middle lobe, and that's what we did. So we proceeded with dissection of all the middle lobe structures, and then dissection of the bronchovascular structures of the anterior segment of the right upper lobe, and remove that specimen on block. However, on frozen section, the pathologist reported to us that the margin was very close, and with that information, I was not comfortable with leaving the rest of the right upper lobe. So we went ahead and we performed a completion right upper lobectomy. The patient went home in 3 days. She did well. I saw her in the office actually a couple of weeks ago, and she's doing well. But then I told Shahzad, I said, let's put this CT scan into our software and see if the software would have predicted to us that really from the get-go, this patient needed a bilobectomy. So I wouldn't have to perhaps waste the extra half an hour in the operating room trying to figure things out and do a partial bilobectomy and then have to complete it. So I think the next slide I think illustrates this very nicely. So when you plug it in into the software, it really tells you that the lesion is it straddles the middle lobe and the upper lobe, and that you do need to take the middle lobe as well as the anterior segmental bronchovascular structures. However, it did tell us that our margin would be very, very tight, if at all we would get a margin. So the software really did predict to us that, or it did give us that added data point that in this case, really a bilobectomy would have been the ideal operation from the get-go. And this is sort of the residual anatomy that it predicted to us in order to get good margins. So, there's the location of the tumor vis-a-vis what it's recommending in terms of the area of resection. We move on. And so on final pathology, as I said, we ended up doing a right upper and middle lobectomy, bilobectomy. The tumor was 2.7 centimeters. Our margin really was wide since we did the bilobectomy, and all our lymph nodes were -11 in this case. And the stage was ET1C, stage 1A, PDL1 again more than 50%. Next case.
All right, Dr. Bora, I will take over for the next 3 cases. Each one of them have their own unique challenge, as you will see. So this particular case, 63 male, past smoker with enlarging PET-avid nodule, 1.5 centimeter in the left lower lobe medial basilar segment. Patient had a complicated prior history of 3B, right upper lobe adenocarcinoma with N3 lymph node involving the right supraclavicular stations. He was treated in 2020 with carboalimta and concurrent radiation followed by Keytruda, and remarkably done well, remained in remission throughout. However, on surveillance CT scans, he had this enlarging nodule that was PET-avid and suspicious for a second primary. His PFTs were excellent, and patient had excellent performance status. So we reviewed his CT scan, and again, you can see on the 3 views that this nodule is in the anteromedial basilar segment. However, it's difficult to assess and obtain margin information beforehand, particularly. At least I cannot be very sure by just looking at these CT scans whether doing a singular basilar segment or a bisegment would give you adequate margin. So we used our software, and right off the chart, you can see 1.9 millimeter resection margin is what it's predicting if you were to take B8 anteromedial segment. And of course, it tells you the relevant vascular anatomy that goes along with the segment, but we were not happy with 1.9 millimeter. That's not acceptable. So I used the rendering from the lung segmentation and simulated bisegmentectomy, also involving segment 9 in addition to segment 8, and that allowed more than 4 centimeter margin. So that's how we proceeded in the operating room. However, it appeared in the conduct of our case that the posterior segment looked much smaller, and just a longitudinal lip of posterior segment remaining. So we ended up doing a proper basilar segmentectomy in this particular case. But I think that's the advantage of the software, that you can technically do a good segmentectomy for less than 2 centimeter lesions, but I think it's really predicated upon having at least a 2 centimeter margin. And this software allows you to predict that with reasonable accuracy. So after the basilar segmentectomy, final pathology showed that it was 1.9 poorly differentiated squamous cell carcinoma. Margins were in excess of 2 centimeter. 7 lymph nodes from mediastinal and hilar stations were negative, and final stage was stage 1A, more than 50% PD-L1. We do it routinely for all our patients for next generation sequencing. Case number 4, this is an interesting one. This is a 75-year-old female, never smoker, and incidentally found to have a mixed density GGO, but with a very low CT ratio, perhaps less than 0.5. The size of the nodule was 1.8 centimeter, and it had very low PET avidity. TSUV was only 1.6. She had excellent performance status and overall in good health. So we planned for segmentectomy in this case, given that this was a GGO. And you can see from the CT scans that this is located ideally at a very peripheral location, close to major fissure in the S2 segment. And on the top right, you can see this was done with contrast. So it's easy to identify the anatomy as the PA takes off. The right main PA gives off truncus anterior, no surprise there, followed by what appears to be the posterior ascending. Again, no surprise there. So we felt that this would be rather straightforward. However, as I did the lung segmentation, there was some surprises there. I would also mention at this point, one of the benefit of doing the 3D lung segmentation, particularly with this software, Xeosoft, you do not need or it's not reliant on IV contrast CT scans. So most of our patients that we do, they are on non-contrast CT scans. They have to be thin cut, ideally between 0.75 to no more than 1.25 mm. But having contrast definitely helps. So again, it's telling us S2 segment will give you adequate margin of just shy of 3 centimeter. But looking at the vascular anatomy, what I thought to be the posterior ascending is not the posterior ascending. The posterior segment is fed off of a recurrent A2 coming off the truncus anterior. And as you can see over here, that ascending branch is actually an anterior ascending branch. So if I was to do without the help of this software, we would have divided that segment. And when we had checked with ICG, it would have been a wrong segment altogether. One of the additional twists of this particular operation was we could not feel the nodule at all. So we decided to divide the segment along the intersegmental plane after ligating the bronchovascular structures, and in particular the recurrent A2. And after we removed the specimen at the table end, I could not feel the nodule at all. It's almost like a pure GGO. But we went along with how we planned on with the software, having the comfort that we should have adequate margin. And our correlation on the final path was exactly that. This was a 2.5 centimeter total size of the GGO with invasive component of 0.9 centimeter, moderately differentiated lipidic pattern adenocarcinoma, and margins were actually impressive, 3.5 centimeter. 9 lymph nodes from both mediastinal and hilar locations were negative. The final stage of stage 1A. PDL1 in this case was less than 1%. So I think in this case really highlights the capability of utilizing these advanced lung segmentation strategy to plan out and really map out the aberrancies in bronchovascular anatomy.
Brilliant, Dr.
To wrap it up, Rashid, are we going too much over time?
Yeah. Can I remind you we're reaching the end of the time? So if you could summarize it, please.
Yeah.
Sure. Maybe I'll just leave the last case for Dr. Bora and he can proceed with the conclusions.
Sure. Yeah, so last case, I'll just breeze through it. This is a GGO in the left upper lobe, and the patient had a prior right upper lobectomy, so we were trying to be conservative in our lung resection. Should that move on to the video, please? And in this case, the software showed that this was in a segment of the left upper lobe, but in reality, our margins doing a segmental resection would have been tight, and perhaps just a wedge resection in this case being non-anatomic would give us a better margin. So we ended up in this particular case using the software to decide that a wedge resection perhaps would be more suitable than a true anatomic resection. And so if you move on to the last slide over here, and I'll wrap it up with our conclusion. So we have found more and more as we've gone to sublobar type of resections that use of advanced imaging and software allows us to very accurately identify the particular lung segment where the tumor is, which is obviously the most important step. And it's not easy sometimes to know that with certainty. It helps identify the clinically relevant and aberrant bronchovascular anatomy, obviously allows for planning and simulation for appropriate parenchymal resection. I think particularly helpful with central tumors that traverse the fissure and need a complex lung resection. And I think we are beginning to use this more and more in our practice. Thank you for your time, and I'm happy to answer any questions.
That's a wonderful presentation. Thank you very much, Dr. Bora. The floor is open. Anyone has got any question, please?
I think, Faiz, that was a very enlightening presentation of the application of technology and especially IT technology in planning your surgery. I think you previously told us also about some 3D models where your trainees could go through the operation beforehand. Would you like to tell us about the audience some more about that, which could be more useful?
Yeah, so
for our trainees?
Thank you, Amir. So in the past, when I was first looking at these software programs, we would actually print out, so 3D print out models of the lung, and I have about 50 of them in my office, where you could actually spin the model around in your hand and kind of understand the three-dimensional anatomy. But that is a time-consuming and expensive process to actually print out a model. And now, for the most part, we have just we've moved on to virtual simulations. So all our planning is now done in the virtual space. There are even more advanced software platforms that that turn a 2D rendering that you're seeing into more of a 3D type of rendering with the use of Google Lens and other platforms, and even holograms, where you can actually spin some of these images in a virtual environment, but look at it from a 3D perspective. But I think for most practical purposes, the software as you see it gives you enough information and enough understanding that you really don't need to have the hard 3D models anymore.
Thank you very much, Dr. Bora. And if there are no more questions, can we go on to the next speaker, please? Thank you very much, Faz. Indeed.
Can I ask
Pleasure
a question?
having you. There is a question coming. Hold on a second, sir. Don't go away.
Hi, very good presentation. I'm Said Qadri from UK. Just a couple of questions, if you don't mind. Number one, you know, your model, you see that 2 centimeter or distance from the resected margin. Because normally when the specimen go to pathologist, they're always a different report. And if it's very close to the resected margin, would you like to go and do a completion lobectomy?
Yeah, so that's a very good question, Dr. Qadri. As you know, there is no clear data on what a margin should be. But I think the accepted sort of dogma is that perhaps the margin should perhaps be at least the size of the tumor. There's another thought that it should be at least more than 1.1 centimeter, and the risk of local recurrence is then reduced by 90%. I think I would accept at least a 1 centimeter margin. If it's less, I think it's a case-by-case situation, right? What is the performance status? What are the PFTs? What am I willing to accept in a particular patient? So I think it's a little bit of a nuanced question and answer. You definitely need a negative margin, right? You can't do an R1 resection because we know that that will affect survival. But beyond that, there's still some work happening. In fact, there will be a paper presented at the AATS by Dr. Nasser Al-Torki, where they will discuss perhaps what sort of margin is required. So just throwing that out there.
Thank you. The second question, in the light of the current trial, which is finished, and I think presented ATD as well, regarding lobectomy versus sublobar resection, and it's mainly American trial, but the sublobar resection mainly was the wedge excision more than the segmentectomy, while the result of the wedge excision is almost the same as the segmentectomy or the lobectomy. Will it change your practice instead of segmentectomy, complex lumpectomy, you do a wedge?
I don't have any problems with the wedge for smaller tumors, but I'll tell you that I think once the tumor size is close to 2 centimeters, then more and more we are preferring to do anatomic resections. And quite frankly, it's a fun operation to do, right? I think you learn as well as you do these, and you want to do them more and more. So now I actually look for nice cases where I can do a segmentectomy. I don't get the same satisfaction in doing a quick, 5-minute wedge resection and a lymph node dissect, to be honest. So I enjoy doing these cases, and I know my partners do, and Dr. Razi is pushing us more towards doing these cases. So that's kind of been our practice.
Yeah, no, you're right. But just this clinical trial might affect the people around the world. That's the problem.
Yes. Yep.
Thank you, Faz, for an honest answer. Thank you very much. So, Dr. Qadri, this is your turn, sir. You're already here.
Thank you, Faz, for joining us.
Thank you very much,
Thank you for
Faz.
your time.
Take care.
Thank you very much. And I wanted to thank Dr. Razi as well for helping me.
And
with
Dr.
this.
Razi. Yes.
Thank you very
Dr.
much.
Razi.
Thank you.
Thanks.
Assalamu alaikum, and Good evening, I think afternoon over there in Peshawar. Thanks very much, Amit, for inviting me for say something about this topic, and also for the society or association just give me opportunity to mention that about this topic in here. Can I share my slide if possible?
Just going to pass on the screen sharing to you.
Sure, thank you. I mean, you didn't give me a favor. You give me the whole book to present here in a half an hour.
Got the screen sharing now.
So topic Amit chose for me is mesothelioma. I try to cut down my slide as much as I can, but I still end up more than 50 slides. I try to go as quick as possible. I'm just not covering everything. If there's any question, please kind of stop me and talk to me if we need. So myself, I'm a thoracic surgeon now, work in Constellation Hospital in Hull, which is the north part of the England, and has been there for a long time. And I have a special interest in mesothelioma surgery. And as you know, there are very few surgeons left in the world now. And in UK, you can count them on the finger. So luckily, I'm one of them, covering the north of England for this surgery. So mesothelioma, as all you know, is a malignant tumor of the pleura serosal membrane of the body cavity. Mostly you can see in the chest as a pleura, but it can be found in the peritoneum, pericardium, tunica generis, and ovarian epithelium. But we normally found this patient coming to us with a mesothelioma of the chest. It is a very rare disease, but it's very complex and invasive disease. When it found, it's very always you diagnose this disease in the patient very late stage, especially in Western countries. We'll go to latent period. It's a very long latent period. When they're diagnosed, are very elderly people, or the very lot of other medical problems, and sometimes most of them are not fit for any treatment. And despite all the form of the treatment, mortality is almost 100% after some time. Any treatment of the mesothelioma is not curative. It's all called palliative. So as we know, the pleura have a mesothelial cell with the various functions and the connecting tissue as well. So the risk factors for the asbestos for the mesothelioma is commonly is asbestos exposure around the world. There are some patients as well which is non-asbestos related mesothelioma, but mostly in the Western countries, asbestos is the cheaper can use for the insulation into industry, into the house, for the boiler and construction company for hundreds of years. And they can find in the mines, and they've also been anywhere with the shipyards or shipbreaking business going on, the people have been exposed as well. In UK, which is the highest incidence of asbestos because it was a cool country, you found it's still in the houses, in the hospitals, in the old buildings, that is still there. In Turkey, they found in the volcanic deposits, and you will see some pictures from Turkey, that mountain, the kids are completely white, playing in the white dust. Therapeutic radiation can cause mesothelioma, and some spontaneous mesothelioma. We found it, and we don't know why it happened. But the risk of death in UK is 1 per million per year. At present, although it's in Western countries, and most of the world has been stopped producing asbestos and using asbestos as well, but it still is being exported, and from the 5 big countries. Russia is using more of this, producing the asbestos, and other countries, Kazakhstan, Brazil, China, and India. And interestingly, more than half of this asbestos is used either in China and India. So these are we're talking about, these are the area where the disease will be moving or traveling to in the future. as Amir told me last time, that they have a lot of cases in the KPK area because of they have asbestos mountain in the Himalayas mountain area. So there are patients coming at a very young age, he told me, and it means if they're coming in the very young age, in 20s, 30s, and 40s, it means they have been exposed when they were a child. Also, there's ship-breaking industry in Karachi, and there's people, and there's ship, where the old ship coming from the Western countries, they have used boilers, where they use asbestos very commonly, and they're exposed as well. And normally, if you see the microscopic structure, you see the fiber like that between the unconnected tissues. Incidence of the mesothelium or diagnosing mesothelium is very rare, very late in the patients. Normally, if you take history of the people, they're normally exposed when they're young, in teenager or 20s, when they're doing some apprenticeship or involved in the construction business. And they'll after after 60, 70, or 80 years old, then when they can been diagnosed. Male have a high incidence because they are mostly working people, while the female will normally exposed when these workers come back home with the clothes covering with the asbestos, and they used to wash them by hands, and then expose. I've told some people as well, when the father come home, they use their mask, because they sometimes later on start using a mask as well, the mask full of dust, and the kids just playing put on the face and playing around as a game. And they will be later on come back as a mesothelioma. In England recently, more than 2,000 people died 2021, and the prediction there is around 65,000 deaths in next 50 years. He's talking about the Western countries. We're not including there's a new area which is being part of the disease as well in the future. So as I mentioned, that have very long latent period, and the median is 32 years, but you can find patient from 15 to 67 years time of the first exposure. But major time when the come patient is in here is 70s and 80s with the advanced disease as well. The clinical presentation is very difficult in Europe. Till recently, that patient came to GP, they've been talking about the short of breath, they treat with infections, and they never bother to do an X-ray or something till 10 years ago, 15 years ago. And these patients have a recurrent infection because of collapsed lung, and then after when they bother, they get an X-ray, and they found there's a effusion there. And this effusion and shortness of breath is most commonly the cause of presentation to the patients. And people thinking it's either asthma or just a recurrent infection. Chest wall pain normally happen when the tumor involves intercostal nerve or involving the rib. And the weight loss is a common factor. But again, in the elderly group, they were thinking, oh, it's weight loss because they're getting older. So it's very vague symptoms. But the commonest symptom we see in these patients are shortness of breath, suddenly happen within a couple of months' time. Sometime before that, they were playing golf, had all other activities. But they're the only symptom they have. You found sometimes abnormal ECG, but it's not really any helpful. Because of this vague diagnosing procedures, our British Thoracic Society developed a diagnostic algorithm to do what to do when the patient come up to you for these things. So it's a little bit algorithm, you can see, you can have it from Amir, and if you want to use it in your practice. How to diagnose? When the patient normally come, when they found the fluid, they normally do a chest X-ray. With the chest X-ray, the fluid, but the common thing they do, they take a fluid out, aspirate it, and send it for the cytology to see, and the microbiology, which is not very sensitive. Less than 40% they found some malignant cell in it, and or less than 10% patients have found diagnosed on the effusion that yet they have a malignant epithelioid mesothelioma or any mesothelioma. But normally, if there's no diagnostic, they go for the CT scan, and the CT scan shows some thickening of pleura. If the CT guided biopsy possible, they get a CT guided biopsy. But the commonest, what happened, they send it to thoracic surgeons. We try to do wedge biopsy. And at the same time, we have a look inside. They said what the thickness of the disease is, it nodular or not nodular. Because epithelioid normally is a fine nodule on the lower chest as well, if a disease picked a very early stage. In some time, lung completely stuck all around. You can't do anything. You cannot go into the chest. In that time, sometimes just open it space. Maybe sometimes make a small piece of rib out and just take a big stem of the parietal pleura and send it for histology. When the patient comes with effusion, it's difficult to just suspect that is a mesothelioma. There's a lot of other cancers we can call mesothelioma, pleural effusion as well. So it's very important to diagnose, do a CT scan the whole body, not only the chest. And if any, not initially, no, it should have PET scan as well. PET scan was not common to diagnose for mesothelioma, but PET scan is quite common to diagnose any cancer nowadays here. But it's still recently, if I'm doing surgery, we do PET scan as well. It shows us where the disease are more advanced and where the thickened, where the thin, or is a pericard involved, or sorry for the sound. So if you see the typical picture of effusion on the chest X-ray, see like that on the left side, and if you see on the right side, left side on CT scan, you see sometimes pleural thickening here. Come with this one. It's not very obvious in this scan, but sometimes you see thickening here, thickening on this pleural side as well. But with the PET scan, you see this thickening nodule on the top, thickening of hair. Thickening is all around, but you see this little bit nodular structure of the pleura, and this is on the pericardium side as well. So I tell you, if you see the whole thing top to bottom, you will see how the extent of the disease is. But interestingly, the disease is the pleura. It cannot penetrate into any lung or the chest wall. It goes between the ribs, basically the tumor lung, just pushing every structure outside. But it doesn't invade like a lung cancer into the muscles or into the bones. So effusion could be lots of things, but normally it's a hemorrhagic, you can see most of the time. But again, it's not very diagnostic. For effusion, for the only thing which is diagnostic for pathologist point of view is cytokeratin positivity, with confirm it is a mesothelioma. If it's not positive, it's always confusing, is a mesothelioma or not. Electron microscopy is always give a definite diagnosis, but sometimes in the absence of cytokeratin, it's always difficult to say it's a mesothelioma. We have a couple of few cases. We did a biopsy. It didn't show any cancer. Well, with thickened pleura, but after 1 year, disease completely advanced all around. Again, the CT scan tell you this thickening of pleura, but is sometimes distinguished from the benign disease to malignant disease, but not very useful, really. You can see the same sort of pleural thickening when someone have empyema, almost as thickened as a mesothelioma. So it's not always diagnostic, and sensitivity not very always good. So again, you are suspicious on the basis of CT scan. There's a highly suspicious of malignancy of mostly the mesothelioma. If someone have a history of asbestos exposure, then provisional diagnosis is more specific, especially in those patients who are not fit for any procedure. So we divided this mesothelioma into two types mainly, is epithelioid and sarcomatoid. Epithelioid is the commonest one, and sarcomatoid is the worst one. But also you found the biphasic or mixed, where both of them come together. And the prognosis of the treatment depends which is the dominant cell type, epithelioid or sarcomatoid, and it decided patient's survival. We also found some sort of desmoplastic mesothelioma, which is very rare, maybe 1 or 2%, but not very commonly you see. There's been discussion going on for some time now, because epithelioid is the commonest one, but you can find the cell type from well-differentiated to anaplastic cell. And the outcome of the treatment depends on the cell type. If it's a very differentiated, there's a good outcome. Is a anaplastic, is a better outcome. We're talking about to develop a new another separate classification for epithelioid. It's not done yet, but there's been discussion sometime. So sarcomatoid or biphasic biphasic mesothelioma is more aggressive at the clinical progression. They go advance very quickly. They're more invasive locally, and there are very few lymph node involvement you see. While epithelioid one is mostly called as a systemic disease, you found lymph nodes involvement, and you found various type of epithelioid cells. Although it's a lymph node involvement and 1 and 2, normally like in lung cancer, we're talking any mediastinal lymph nodes and 2. The new classification, TNM classification in the mesothelioma, they all consider as N1. Because mediastinal lymph node N2 lymph node doesn't show any worse prognosis compared to the N1 or N0 lymph nodes. So that's why the N2 disease in epithelioid or mesothelioma, if the lymph nodes on the other side of the chest. One side of the chest, ipsilateral chest, if the lymph node involvement, regardless what a lymph node it is still called N1. So biphasic prognosis, again, depends on the ratio of the epithelioid and sarcomatoid. And so it's very difficult to treat as well, and they have to treat like epithelioid or treat as like a sarcomatoid. So many of them oncologists end up treating biphasic as a sarcomatoid cancer. Again, the TM classification mesothelioma, if you see here, N1 node is only ipsilateral lymph nodes, regardless where they are, while the N2 is a contralateral nodes. That's an important factor. For all this, T1, T4 disease is just is difficult to see on the scans. Is normally pathological diagnosis. The management of mesothelioma is very, very controversial and is multifactorial. And it depends on lots of factors: patient conditions, patient present, patient age, other comorbidities, and the disease and the symptoms, various factors, which consider before any plan of management. So first thing, the patient come with the pleural effusion. So that's that we normally deal as soon as possible. When doing thoracoscopy for the biopsy reason, we take the fluid out, and at the same time we assess the inside the chest as well. And you put the talprodesis. Talprodesis give it two benefits. One is stuck the parietal and the fluid together, so patient doesn't have a symptoms of collecting fluid again. Secondly, if the patient fit for the surgery, it's easy to remove both layers together than the separately, because sometimes visceral layer is not as thickened as the parietal pleura. And if it's a complete trapped lung and patient not fit for anything, cannot do a talprodesis, we'll put an intrapleural catheter called pleural strain. So you can keep them for months, and then slowly the fluid will come out and slowly cavity will shrink by itself as well. Second management is treatment of the disease. Majority of patients not fit for the surgery, say they go either palliative or treatment, or if they are fit enough for first of 0 to 1, they can have chemotherapy, immunotherapy, radiotherapy, if any bone involvement or pain somewhere in the chest.
Qadri, sorry to be the interrupter. 5 minutes, sir, please.
Okay. So all other thing has to be considered for this for the remaining treatment. So treatment involved, as mentioned, surgery, immunotherapy, chemotherapy, or multi-modality treatment. Immunotherapy has been recently been considered as a first-line treatment in the non-surgical cases, and is being considered here now. We're also using for this one for the surgery now. Survival is always very difficult to tell the patient. If no treatment offered, only 6 months their survival. If the child produces 6 to 9 months, chemo with cisplatin alone 9 to 3 months, cisplatin primetics 12 months. With the multimodal treatment, including surgery, is up to 26 months. Immunotherapy has been recently starting using in here with after the checkmate clinical trial, and is in the patient with non-resectable is a dual treatment and is very expensive. What the immunotherapy does, mesothelioma cells display surface protein that binds and deactivates immune system T. So cancer cell release signal that mask it as a healthy cell. So immunotherapy drugs block this interaction, preventing the cancer cell hiding from it as a non-threat, and the cancer cell they reveal to the immune system so they can go and attack the cancer cell. It's very expensive to use it here. As a multimodality treatment, involves surgery, chemotherapy, immunotherapy, radiation as well, with the diabetes formation, the adjuvant or Q-adjuvant options. Single modality treatment is not always be effective compared to multimodality treatment. But the surgery for these patients, again, itself is not a good option. But the surgery option nowadays is called extrapleural pneumonectomy, this EPP, or depulking surgery we call extended pleurectomy decortication, or simple effusion drainage of effusion and pleurolysis. So the risk factor of the poor prognosis you can see is a contracted chest cavity or sarcoidomatic maxillary they are the poor prognosis. Longer than 6 month history of the symptom is also, and tumor more than 500 cc is also a bad prognosis. So again, the surgery depends on the patient's risk factors and these all the options, but the commonest operation we do either extended pleurectomy decortication, which happen only operation in UK, but in America and other part of the world, they also still doing extrapleural pneumonectomy. So extrapleural pleurectomy and decortication, which is I normally do nowadays, this is the disease you see all around. So disease removed, pericardium removed, diaphragm removed, and then patch it after that. And you see the disease, and this is a disease only the pleura. You see the thickness of the disease sometimes is like a ball, like a small tennis gelatin ball, and this thickens. So this small disease, it cannot be treated by a simple drug. So it's always, that's why the result is very poor. Evidence is very poor. The surgery, all these cases is mostly in America. There's 2 clinical trials run, Mars 1 and Mars 2. Both are controversial and very small studies. But we're talking about the Mars 3 trial now. So still you have this sort of clinical trial. You can go on internet and see what exactly the results are. So evidence after seeing that all the published data and reviewed by a Russian co-worker, Rashid, one of the lady who's doing the leading the mesothelioma surgery around the world, and that data show the stage 1 disease had a better survival compared to all advanced diseases. Similarly, they analyze the ILCS data, which is an International Association of Study for Lung Cancer, and again, this shows that this epithelial mesothelioma has a better survival in a stage 1 disease. Not every studies has been done. It's all is prospective studies, and this is first time there's a recommendation came in America by the part of International Mesothelioma Interest Group, IMIX, and on the basis of 80 study, we developed this recommendation. The surgery, aim of the surgery to remove the macroscopic complete resection. You cannot remove the microscopic disease. And out of 80 studies, one of the studies, our study, which is make this guidelines. And if it is mesothelioma surgery, the problem, but we have very few surgeons in the world, in the UK as well, and trial is not very good. And the training, there's no training program. If you're there, whereas people are around who are doing surgery, you can learn by staying with them. And we in Hull, we keep doing a surgery from 99, and we publishing data. We carry on all regularly. We have our result compared to the Mars trial was better, and we show the good survival as well. We keep publishing as time goes by, presenting as well, different society. And so the risk factor that now that this disease is most probably moving to China, India, and Russia, and Brazil in next 10, 20 years, and they'll see more cases over there than the European country. In conclusion, all patients should have access to specialized treatment. These patients should be referred to team or hospital who have an interest and experience in mesothelioma surgery, expertise in perioperative management, and the specialized oncology service available there. Surgery, either APP or EPD, can be performed safely with low mortality through proper staging, appropriate patient selection, better surgical technique, advanced perioperative monitoring, and better critical care support in a multimodality setting. And plus all this new adjuvant chemotherapy or immunotherapy will be very helpful for this improve the patient outcome. Thank you very much. Happy to have any question.
Thank you very much, Dr. Qadri. Is there any question from the... Yes, Dr. Bahauddin. Go ahead.
Mike, sorry.
You can stop sharing that. Sorry.
Okay. My question is that what is your criteria for selection of patients for surgery? I mean, what do you see before proceeding to surgery? That histology.
For my criteria for the patient.
Dr. Qadri, may I just add on to Bahauddin's question? After Mars-2 trial phase 3, what would be your criteria for selecting surgery?
Sir, that's the second question. The first thing is what they do now, because Mars is coming. Okay.
Yeah. Okay, I'll tell you about the both. My criteria is the patient is fit enough, his performance is 0 to 1, and no other cardiac or pulmonary comorbidities, which is may cause a problem. And if patient agreed for that, and as a part of the multimodality treatment, then we go ahead.
And what about the histology, sir? Like, do you mind if
it's always epithelioid?
It's always epithelioid. Supraclavicular nodes.
No, we don't operate sarcomatoid or biphasic. It's always epithelioid. Regarding a Mars-2 trial, yeah, you asked about Mars-2 trial. I'm going to explain to you.
Okay. Mars-2 trial question was the next question. I hope you can hear me. In light of that study, what would you like to change? Like it says that chemotherapy is equivalent to surgery. So do you agree with that? Do you want to change your practice, or like what?
Have you reviewed the protocol, study protocol? Have you seen it? No. So what a design of the study was done that all the patients have a chemotherapy first on both sides.
Okay, sir.
And after that, the patient has been reviewed. Are they fit for the surgery or not? After that, that one group, which is new people, go for the surgery. And after surgery, they should go for the chemotherapy again. While other limb of the trial is just a chemotherapy alone. So they never have any exposure to surgery or any risk, which is can cause the problem. While this side, this arm, patient have a new adjuvant treatment, which is not been evidence-based yet. There's no evidence, no clinical trial that mesothelioma with the new adjuvant treatment give you benefits. So they just design it without any evidence. After this giving it the new adjuvant treatment, after giving chemotherapy, the patient is not very fit enough after surgery. Then they have go for the surgery straight away after some time. They're not fully recovered regardless. And most of the patients were supposed to have a chemotherapy after surgery as well. They didn't have it. Secondly, we all know from the last 20, 30 years now, the only tissue type which is heavy surgery and offer is the epithelioid surgery, mesothelioma. While they took everyone on the board, epithelioid, sarcomatoid, biphasic. And that's why they have a results, poor results. If you because they haven't published yet, and they have not published, analyzed the sub-analysis of the data as well. If you review those patients who have epithelioid mesothelioma, their outcome is better than everyone, from the chemotherapy, from other surgery, everyone. And still, we haven't been, we questioned answering that why these patients have a surgery who back to normal after 6 weeks, why not have been offered chemotherapy? We haven't got an answer yet. So basically, the first line is Eric. Eric is a good friend of mine. He just presented this data into World Congress in Singapore. And the first line he said, oh, the surgery is bad in mesothelioma. He never published the data yet. He never analyzed the whole data. The team, we part of the clinical trial, we're asking that we know now that surgery with epithelioid mesothelioma is better results in all arms. So now we're talking about Mars-3 trial, because when in this trial, they will never use immunotherapy as well. But immunotherapy is now the treatment of choice for mesothelioma as well. So we're talking about epithelioid patients with immunotherapy versus oncology treatment only.
Thank you very much,
Right.
Dr. Qadri, for explaining this. And we would definitely be looking forward to go through the Mars 2 data with a fine comb and wait for Mars 3. Thank you indeed. Any further comments, Dr. Amir?
But thank you, Kadri, for joining us. I know it's a weekend for you over there, so go ahead and enjoy the rest of your weekend. And give my regards to Mike, please.
Thank you very much.
No, thanks so much. I really want to come here, but something suddenly happened just a day before my flight, so I didn't come over. So I apologize for that. But hopefully we'll see you soon.
Thank you for joining us.
Yeah.
Thank you. Thank
Take
you.
care. Assalamu alaikum.
Thank you.
Thank you.
And thank you, Rashid and Professor Otto, for chairing this long session. And thank you for the audience, special thanks for the audience for having the patience to staying with us and skipping lunch. But wo ilm ki pyas bujha rahe the. So I think you make up for that at dinner. Thank you, everyone. Thank you, everyone.